cohort from their registry. So they didn't know what all confounding factors each group was exposed to. So they employed this statistical modality and they calculate the inverse probability of each patient and how much they could have been exposed to if they were included in the trial. So as we can see in this data, initially when both the cohorts were put together, the higher stage and higher group, higher grade tumors were more in the neo-RP cohort, whereas the RP cohort had the lower grade tumors and lower stage tumors. But when they matched them equally by using their statistical modality, we can see from the data presented here that both the groups are equally matched or comparably matched. That made the analysis more sound. So coming to the primary outcomes, it's very evident from this graph seen over here that the neo-RP cohort had a significantly prolonged time, and at the end of 3 years, freedom from biochemical recurrence is 59%. Whereas in the radical prostatectomy, where they have upfront radical prostatectomy, it's only 15%. The second primary outcome which they assessed was metastasis-free survival. Even here, the neo-RP cohort has scored far better, which is about 96% at the end of 3 years, whereas it's only 68% in the upfront RP cohort. However, the study has its own limitations. Like I mentioned, it's a heterogeneous cohort. It's not a homogeneous cohort which they have taken, and it's an observational study. And it has its own unmeasured confounding factors. Though the IPTW had taken into account majority of the clinical confounding factors, this had its own unmeasured factors. And the main problem came from the inherent selection bias, because we said that all the upfront radical prostatectomy patients are also matching the key eligibility criteria for neo-RP cohort. So if that is the case, then there might be a possible different disease or patient characteristics in the neo-RP group. And the second shortcoming is the short median follow-up, which is only for about 4 years. So this group has concluded that neo-RP group had an improved pathological outcome at radical prostatectomy with terms of lower staging, lower grade, and lesser positive surgical margin. And they have also able to say that these findings have translated into having a significantly lower risk of developing biochemical recurrence. And as they had a significantly lower risk, it also translated into a less adjuvant or salvage therapy after radical prostatectomy with a superior metastasis-free survival. Though this study can't give out any confirmatory findings as to recommendations, this can be confirmed by a randomized control trial, and this will ultimately serve to complement the results from phase 3 Proteus, which we are all expecting to come out of in 2027, with the preliminary results coming out in the next year. So Proteus trial is nothing but a randomized double-blind placebo-controlled trial where they compared placebo plus ADT and apalutamide plus ADT in the neoadjuvant setting for a localized and locally advanced high-risk prostate cancer. Probably these results which come out as primary results in the next year will give us better data. Thank you once again for the GU Oncology team for this opportunity.
So we come to the surgical topic, real surgical topic, Regia sparing versus radical prostatectomy by Dr. Ashish Khanna. Some surgeons will wake up, I suppose.
Present this systematic review and meta-analysis on Regia sparing radical prostatectomy versus robot-assisted radical prostatectomy. Which technique is more beneficial for prostate cancer patients? This was from a German group, and I am Dr. Ashish Khanna from the Department of Uro-Oncology at Rajiv Gandhi Cancer Institute. So whenever we talk about the outcomes of patients undergoing radical prostatectomy, often a term of trifecta comes into play, which comprises of oncological control, achievement of urinary continence, and return of erectile function or potency. When we talk about cancer control, the immediate postoperative indicator would be a positive surgical margin, and following that, subsequently, a biochemical recurrence may predict recurrence of cancer. In this systematic review and meta-analysis, a postoperative PSA value of more than 0.2 nanogram per ml on 2 occasions was considered as biochemical recurrence, and for urinary continence, no or single pad usage was used to define return of continence. So going through the abstract, the aim was to compare the functional, oncological and perioperative outcomes of REDGS sparing radical prostatectomy with the standard robot-assisted radical prostatectomy. The trial, this review included only randomized control trials as well as prospective studies, and no retrospective studies, case reports or reviews were included. The primary outcomes measured were the return of continence, positive surgical margin rates. The secondary outcomes that were included were the perioperative complications. Finally, the meta-analysis has concluded that REDGS sparing radical prostatectomy has statistically significant advantage in terms of return of immediate urinary continence. However, it also has statistically significantly higher rates of positive surgical margins in patients undergoing this procedure for localized disease. So in the methodology, I'm not sure if we are able to see the flowchart correctly, clearly. Two independent reviewers did the work of data collection, risk of bias and quality of evidence assessment. The types of studies that were included were only randomized controlled trials as well as prospective studies. And the studies had to at least analyze one of these outcomes, such as the perioperative, functional and oncological outcomes. After extensive database search, we finally concluded to 4 randomized trials and 6 prospective studies. So the 4 randomized trials and 6 studies were included. The quality of assessment was acceptable for all these studies with minimal publication bias, and risk of bias assessment revealed low to moderate bias only. An important finding was that there was no significant difference in the age and the proportion of patients having Gleason more than 7 between both the groups, which has important bearing on the trifecta outcome. Coming on to the primary outcome in terms of continence, when we talk about immediate continence, which is at the time of catheter removal following surgery, in the forest plot we are able to make out towards the left of the line, one line is the REDGS sparing radical prostatectomy, and to the left is the standard prostatectomy, and we can see that the immediate continence recovery was statistically significantly higher with the REDGS sparing prostatectomy, with almost a 1.8-fold increased probability of the patient being continent. When we talk about the continence recovery at 3 and 6 months, although there is a trend towards better continence with REDGS sparing, however, this was not statistically significant, and the same was seen at 12 months, where the continence was almost similar in both the groups. When we talk about potency returns, it should be noted that only 4 studies out of the 10 reported on potency, and there was no difference in the immediate potency recovery which was seen between the 2 approaches. When we talk about the positive surgical margins, the rate of positive surgical margins overall for REDGS sparing approach was 18%, whereas for the standard approach it was 16%. When we substratify it according to the disease staging, we find that for patients who have a localized disease, pathological T2 or less, the positive surgical margin rates were statistically higher in the REDGS sparing approach. However, this effect was not seen when the procedure was performed for patients who had locally advanced disease. Surprisingly, or not so surprisingly, despite the higher positive surgical margin status with REDGS sparing radical prostatectomy, 2 studies reported higher biochemical recurrence with the standard approach, and the remaining 5 did not report any difference in the biochemical recurrence. And when we talk about the perioperative estimated blood loss, major complication rates and length of stay, there was no difference between either groups. So to conclude, we find that the immediate continence, that is at catheter removal, is better with REDGS sparing, which may or may not be seen at subsequent evaluation points at 3, 6 or 12 months. There are a few limitations of the study, that inter-surgeon heterogeneity could not be assessed in these studies, which is a very important factor when we assess a surgical technique based study, because REDGS sparing radical prostatectomy has a steep learning curve. Galfano et al., who have reported about REDGS sparing, have said that almost 100 cases of this procedure need to be done before the positive surgical margin status comes to a level. Importantly, the use of preoperative MRI was not a standard practice in these studies, and as all of us surgeons know, when we are doing radical prostatectomy, the know about of the location of the tumor is very critical in deciding whether radius sparing approach should be followed or not. At my center, we are routinely doing radius sparing, and we make it a point that patients who have anterior disease or disease that involves the bladder base, we seldom perform radius sparing approach because it is difficult to see within the bladder by this approach, and it is difficult to take an anterior margin. Also, definition of potency was not standardized, and also it should be realized that potency is not a factor that just depends on the surgical approach. It depends on the patient's preoperative potency status. It depends on whether nerve sparing was performed or not performed, and whether it was accurately assessed in the postoperative period as well. Thank you so much, and that's the conclusion from the study.
Is going to speak about the radioisotope guided lymphadenectomy for pelvic lymph node staging in patients with intermediate and high risk prostate cancer, the prospective sentinel study.
Good morning, everyone. I'm Dr. Ravi from Apollo Cancer Center, Bangalore. And my today's paper is radioisotope guided lymphadenectomy for pelvic lymph node staging in patients with intermediate and high risk prostate cancer, the prospective sentinel study. Well, during radical prostatectomy, extended pelvic lymph node dissection has long been a gold standard for nodal staging and as well providing prognostic insights for further management plan. However, it does harbor few issues like node present outside the template may be missed, and depending on the extent of the lymph node dissection, the perioperative morbidity would also vary. And there have been two recent randomized controlled trials which have been published in European Urology in 2021, which has failed to show any oncological benefit of extended PLND over a limited PLND. So with these issues in the back set, and with a systematic review data showing that a sentinel lymph node biopsy in prostate cancer is almost equivalent to extended PLND, has brought in new discussion in the forum. So with these issues in the back set, the sentinel group set out to further the evidence for sentinel lymph node biopsy in prostate cancer. So they performed a single arm, open label, multi-center, 3 centers to be precise, and a non-randomized study which was performed between February 2012 and May 2019. Around 178 patients were assessed, but then finally 162 patients were included for the analysis. The inclusion criteria is anyone more than 18 years with a histologically confirmed prostate cancer, which is clinically localized, intermediate or high risk. The exclusion criteria were a nodal positive disease or a metastatic disease, any previous treatment for prostate cancer, any previous radiotherapy or surgery in the pelvic region, or any contraindication for general anesthesia. Coming to methodology, they have followed all these steps which was set out in a consensus panel meeting published in BJU International in 2017. And that includes 1 day before surgery, a truss-guided injection of radiotracer, that is 99M technetium nanocolloid, was injected into peripheral zone of prostate, extending from apex till base to ensure a homogeneous distribution using a 22 gauge needle. A total activity of at least 222 megabecquerel up to 300 was given in a total volume of 0.6 ml. Subsequently, 2 hours later, a lymphoscintigraphy was performed, followed by a SPECT CT scan. All the images were reviewed by in-house nuclear medicine physician and subsequently by a central reviewer. Following that, all the approach in this study has been open. There is no minimally invasive approach in this study. So first, the sentinel lymph nodes were searched inside and outside the usual external pelvic lymph node dissection template using the lymphoscintigraphy findings, and then a use of intraoperative handheld gamma probe. And if at all any sentinel lymph node was identified in a region, let's say an external iliac region, then all the lymph nodes in that region were removed. Once the sentinel lymph node resection has been done, all the patients underwent extended pelvic lymph node dissection as well. and the number of nodes removed, both sentinel and non-sentinel, the number of metastatic nodes, and the locations were recorded. Any perioperative complications were recorded using Clavian window grading. Coming to statistical analysis, descriptive statistics were carried out and categorical variables were reported as frequencies and percentages, continuous variables and medians or means as appropriate. And subsequently, the diagnostic accuracy of SLNB was assessed by calculating sensitivity, specificity, positive predictive value and negative predictive value. And all of this was performed in R software version 4.1.3. Well, the median age in the study group was 65 years with a BMI of 26. Nearly 3/4 of patients belonged to clinical less than T2A stage, and nearly 60% of patients in this study had a PSA of less than 10. They had a biopsy ISUP grade group of 2, and nearly 65% belonged to intermediate DMECO risk classification. For subsequent to prostatectomy, around 42% of patients had grade 2 ISUP grade group, and majority were T2C grouping. Coming to the results, based on the preoperative lymphoscintigraphy, in 153 patients, sentinel lymph nodes were detected. That is close to 94.4%, totaling 890 sentinel lymph nodes. And with an intraoperative gamma-guided detection of in 142 patients, totaling 788 lymph nodes were done. As you can see in the diagram here, the distribution, the majority of the lymph nodes were in obturator fossa, followed by internal iliac fossa, and then external iliac. The mean number of sentinel lymph nodes which were removed was 4.9 per patient. And sentinel plus extended pelvic lymph node dissection, the median number was 14. And the median operative time for sentinel lymph node plus extended PLND was 70 minutes. Coming to the pathological evaluation, out of 162 patients, 22 patients only had a lymph node metastasis, that is 13.6%. And the lymph node metastasis were limited only to sentinel lymph nodes in 17 of those patients, that is nearly 77.3%. And 141 out of 142 patients were correctly staged by sentinel lymph node, and there was only one false negative patient in this category. And interestingly, they also identified one patient who had a lymph node outside the template of EPLND, which was picked just because of sentinel lymph node methodology. Well, the sensitivity, specificity, negative predictive and positive predictive value of this method to detect patients with at least one lymph node mets ranged from 95 even up to 100%. And at 1 year of follow-up in the overall cohort, biochemical recurrence was occurred only in 23 of these cases. Coming to discussion part, the study group set out with a question saying, does EPLND truly represent a gold standard in lymph node staging, which is with its inherent lacunae like missing node outside the template, risk of perioperative morbidity, and does EPLND have any therapeutic benefit at all, with the two RCTs showing that there's no real oncological benefit with those steps and methodology. And with a sensitivity of close to 0.954, does sentinel lymph node biopsy set a challenge for the established EPLND was the question. And this sensitivity is much higher than any other preoperative staging methods, including PSMA PET CT. And apart from that, there has been a recent meta-analysis where it has confirmed that every 1 in 20 patients undergoing EPLND, a metastatic lymph node would have been missed without a sentinel study. So with all these information at the back set, with a sensitivity of close to 0.94 and with accuracy of 99%, the study group set out to challenge the conventional dogma that EPLND is the gold standard of lymph node staging in prostate cancer. However, it does have some limitations. There was no analysis of long-term oncologic outcomes in the study group. There is no comment on sentinel lymph node biopsy specific intraoperative morbidity because all the patients anyway subsequently underwent a EPLND. It was only open approach between 2012 and 2019. And as we all know, the current practice, the minimal invasive has taken over the landscape with a very bare minimum open approach being done, and if it really makes any difference at all. And majority of the patients in this study group belong to intermediate risk, and very few node positive patients would have been included. And the sentinel lymph node was picked up only in 87.7% of cases. And what about rest of the cases? and an unavailability of a dedicated gamma probe for MIS when they did the study. Coming to the strength of this study, it was a prospective, multi-center design. It followed all the established expert consensus statement which was published in BJUI in 2017. And now, currently, we do have a radio-guided robotic surgery can be done using drop-in gamma probes. So we really don't know if it does make any difference in the management. Coming to the conclusion, this prospective study does show that SLNB is an effective method for lymph node staging and has a potential to avoid significant number of ELNDs in patients with intermediate or high-risk localized prostate cancer. The place of the sentinel lymph node for staging needs to be defined in future studies with a much better large volume and with a much longer follow-up, as it could be used alone or as a part of strategy that includes PET-CT in high-risk prostate cancer has to be seen. Well, coming to Indian scenario, as we saw in the patient characteristics and tumor characteristics, our patients behave much, much different from the Western set of population, and our incidence of node-positive diseases are much higher. So does this approach really have a benefit in our subpopulation needs to be looked upon. Thank you.
He is going to talk on duration of androgen deprivation therapy with post-operative radiotherapy for prostate cancer, the first results of Radicals HD trial.
Thank you, sir. Thank you to the organizing team for giving me this opportunity. But anyway, so currently today I'm going to discuss about the Radicals HD, the most awaited trial in terms of hormone therapy in post-operative prostatic cancer with radiotherapy. So Radicals was actually a trial which was planned to see two different aspects. One is whether radiotherapy immediately or should we do radiotherapy after there is a biochemical recurrence after radical prostatectomy. And the second component of this trial was whether hormonal therapy in post-operative setting with radiotherapy had any benefit with any benefit in the long term. So basically, Radicals, as I said, is radiotherapy and androgen deprivation therapy, and its chief investigator is Dr. Chris Parker from Royal Marsden. So as you can see, there is the first randomization that is between the timing of radiotherapy, that is whether we have to treat them immediately versus salvage, and this is mostly seen in post-radical prostatectomy setting. And the second randomization was whether the hormone had to be 6 months or long term, that is 2 years, or what there was there any benefit with giving hormone therapy at all. So the hormonal therapy arm had again further two randomization, whether we would plan for at the time of radiotherapy was 6 months versus long-term hormone therapy. Whereas there was another randomization, that is 3-arm randomization, where patients were also put into radiotherapy alone arm, 6 months alone arm, and 2 years hormonal therapy arm. So this bias was basically inherent because the selection of choosing with 6 months versus long-term radiotherapy arm versus no hormonal therapy arm and 6 months arm was invested with the patient's physicians based on the clinical risk factors and other surgical and pathological factors. So the trial specifications were, it was originally planned for 12 to 13 years. The primary outcome measure was actually changed to freedom from metastasis down due to low event rates. The original primary outcome was disease-specific survival, but they didn't achieve the expected events within that span of 7 to 10 years, so they had to change it to freedom from metastasis-free survival. So probably, the statistical methods also suggested that it was powered to say that. And the secondary outcome measures were time to salvage of androgen deprivation therapy and overall survival. The androgen deprivation therapy used here was both LHRH agonists, that is leuprolides, and bicalutamide. But except in Canada, because it's a multi-institutional study, Canada did not have the license for this setting. So in Canada, it was mostly LHRH agonist, whereas rest of the institution had the choice of making between bicalutamide versus LHRH agonist. So as you can see, the inclusion criteria, obviously the post-operative PSA should be less than 0.2. As per Radical's radiotherapy trial arm, the biochemical failure was considered to be 0.1. And ideally, it should be more than 4 weeks and less than 22 weeks after radical prostatectomy, the introduction of hormones. And one or more of the high-risk features, that is PT3, 4, or Gleason 7 to 10, biopsy or surgical sample, preoperative PSA more than or equal to 10, and positive margins. These were the high-risk features. Patients due to receive postoperative RT either early or deferred later for salvage radiotherapy would have been randomized at that point in time when they would have planned for radiotherapy. Exclusion criteria was any previous bilateral orchidectomy, prior pelvic radiotherapy, any other active malignancies, no distant metastasis from prostate cancer, preoperative hormone therapy within previous 6 months, and any previous hormone therapy longer than 8 months, any post-operative hormone therapy, and PSA more than 5 at the time of randomization. Most importantly, the staging method, what they used was the standard bone scan and CT chest abdomen pelvis. Mind you, they did not use PET, PSMA PET or MRI for that matter. So the trial methods, it's again multi-institutional, multi-centric international phase 3 randomized controlled trial, mostly Denmark, UK and Canada. The radiotherapy arm had recruitment from Ireland as well. The representation of Ireland in hormonal therapy was lower. The trial period was from 2007 to 2015, a total of 2,839 patients. Whereas 492 patients underwent the 3 randomization arm, although this has not been yet discussed in the current abstract because we are waiting for that result. Whereas what they have published currently is 1,480 patients who were randomized between none versus short-term hormonal therapy, which is about 6 months, and 1,523 patients data, which is short-term, which is 6 months, and long-term hormone therapy, which is again 2 years. So the assumption to even begin with this trial was, how did they get these numbers? It's because they thought that there is about 6% absolute benefit between the disease-specific survival for people who are undergoing hormonal therapy after radical prostatectomy with radiotherapy. And with this number, they thought they would require about 1,500 patients for a trial running for about 7 to 10 years. The sample size also incorporates about 30% of loss to follow-up in 5 to 10 years, which is a standard statistical method which they use for a long follow-up trial. So this is the current patient characteristics which they have reported, that is last year in ESMO. So the 2 randomization, the 3rd randomization they have not reported yet. So the 2 randomizations, none was short and short versus long. So what you can see is the median age is about 66 and PSA is standard about 0.22 in both arms. They've matched mostly. But what you can see is the high-risk features, especially the Gleason 810, pathological staging T3B and 4, positive margins, are quite more common in the short versus long arm. That means there was an inherent bias among the clinicians to recruit these patients in the hormonal therapy with radiotherapy arm. So you can see that representation is fairly minimal in terms of none versus short, because randomization was completely computerized, so you never know whether your patients would be landing up in a hormonal therapy, which I think the clinicians had their bias with. So there was a selection bias to some extent. Obviously, so as the results have been published, the results say that there was about metastasis-free events in none versus short term, which is fairly a better group in terms of clinical pathological staging. And they saw about 268 events, that is metastasis-free survival events. Hazard ratio was 0.89. It was not significant because the confidence interval is crossing 1. Whereas the short term versus long term, you can see that the hazard ratio is 0.77 and not crossing the significant. I mean, it is significant because there is about 313 events and confidence interval is below 1.0. And even free survival at 10 years, whereas none versus short was about 79 versus 80, not much of a difference. Whereas there was about 6% difference. Actually, that was the assumption what they made even at beginning of this trial, that they were looking for a 6% benefit for this trial to continue. And I think they found that in the short term versus long term. Now, time to salvage, the ADT was about 0.54 hazard ratio, again significant. And even in the short term and long term, there was about 0.73, and confidence interval was 0.59 by 91. So in essence, there was about 27% difference. And overall survival, as you can see, it's identical in both the arms. So what they are saying is there's no overall survival difference between hormonal therapy arm versus none, and also short and long arm. What they are trying to tell is the metastasis-free survival events have been better in short versus long-term arm, and even free survival is improved. So in essence, we are not improving overall survival, whatever hormonal therapy we are using, but in essence, metastasis-free survival events can be reduced in people who are having longer-term hormonal therapy. So the conclusion actually by authors is in patients having post-operative radiotherapy after radical prostatectomy, 24 months ADT versus 6 months ADT improved both time to salvage ADT and metastasis survival. But in contrast, the 6-month ADT did not. They didn't pay more attention to the overall survival because we are still yet to receive rest of the data yet to be published, that is toxicity data, secondary events, and they still need more events to complete and mature to comment on overall survival. But currently, yes, there is no overall survival benefit as per the current published data in terms of hormonal therapy with radical prostatectomy. So I think rest of the questions we can have at the panel. Yeah. Thank you.
Thank you, all the speakers. I would request the experts to have a quick comments on the sessions, and then we'll move on to the panel discussion. Yeah, I think all the papers were very novel, and lots of new things are there, but at the same time they are very ambiguous. Like in the last paper, at least we know that now long-term, ADT will have some survival benefit, but that is also not quite a lot, 6%. Then about a ratio sparing, now it is very difficult to achieve that 100 cases and then have a negative margin. So that paper is also not very conclusive as far as the radius sparing versus the radical prostatectomy by robotic assisted laparoscopic surgery. The one paper that is a radioisotope guided lymphadenectomy is an eye opener. Because in Indian scenario, we are getting quite a lot of lymph node positive. So in this, if we can do this practice, then I think we can have the better lymph node dissections and better outcome. So I think
so you want to
we can have the.
Okay, sure. We'll move on to the panel discussion. Sure. So with this, thank you, chairpersons, for this particular session, and we will have a quick panel discussion on the same pertinent topics. It's immense pleasure to introduce our moderator, Dr. Sanjay Adla. He is a consultant uro-oncologist, Apollo, Hyderabad. I would also request my panelists to come over. Dr. Genil Kumar, consultant uro-oncologist, Amruta, Cochin. Dr. Manav Suryavanshi, consultant urology and uro-oncology, Amrita Hospital, Faridabad. Dr. Aditya Pradhan, consultant urologist, BLK Super Speciality Hospital, Delhi. Dr. Tarun Jindal from Narayana Super Speciality Hospital, Calcutta. Dr. Tongaonkar sir, sir is a director of oncology and geo-oncology, Max Hospital, Nanavati. Dr. Anime Saha, radiation oncology consultant from Apollo, Kolkata. Dr. Suparna Rao, medical oncology consultant from PD Hinduja Hospital, Mumbai. And Dr. Aditya Agarwal, Paras, radiation oncology consultant, Paras Hospital, Gurugram. I hope we have enough chairs. Yeah. Perfect. Sure. Thank you.
So there are two radiation oncologists on that side and one on this side. Okay. We are surrounded by the radiation covered. Okay. Good morning. Thank you very much for this opportunity. I haven't criticized any of the papers. I just wanted to know what are the take-home messages. That's one. And what can we do trying to implement any of the knowledge that we have gained for Indian scenario. And if I'm going to cut you short, please, there is nothing personal. We just want to finish all the 6 papers. So I've got 5 eminent uro-oncologists and 3 radiation oncologists. So I'm just going to start off with the only professor who is here. Then we should kill Ganesh Bakshi. He didn't know. You are Suparna Rao. Okay. Even in that one, it said radiation oncologist. I Googled all of you to know who you are. Okay. So you might get some bouncers. Don't worry about it. Okay. Ginil, we can start off. Null hypothesis. This is the starting statement of this paper saying patients who have the same disease grade but were diagnosed with that grade of disease at 2 different time points, diagnostic versus confirmatory biopsy, have similar outcomes after radical prostatectomy. Do you think that is right? Do you think they can prove that? That was the basic null hypothesis they started of the study from.
So they were telling that actually in the later stage they may be having the patient who had a biopsy later may not be having the high risk factors like that may encounter in the primary biopsy, like when they are doing the biopsy in the initial stage.
So this study was the Gleason. So these were low risk prostate cancer patients who were on active surveillance, who were on follow-up biopsy, were found to have intermediate risk features, went on to have radical prostatectomy. So they compared the patients who were intermediate at the outset to the intermediate at the confirmatory biopsy, and they say that both of them behave the same.
So they were telling, but thing is the outcome, they were telling that the long-term outcome was similar if those to the active surveillance if there was a delayed pickup.
Okay, I'll do the other way around. Do you think that is the correct statement or not? Do you think they will be able to prove the null hypothesis, or the null hypothesis will be disproved?
I don't think that with this paper it will be confirmatory. We can say that this can be done.
Okay, so you think that they won't be able to prove the null hypothesis? Pradhan sir, any comments on that?
Sanjay, there has been before this also some data on this matter.
We are going to come to that.
Yeah, so in this paper, actually, this is an inviting concept that if you have done a prostatectomy probably 6 months apart in similar pathology, you would expect actually the outcomes to be similar.
Yes.
That is the null hypothesis, and it makes sense if you're dealing with the same pathology, low grade, with a 6 months difference in time. Probably your results should be the same. That is
the only difference for me, in my understanding, is the one that you picked up the second time took more effort from you to pick up.
Agreed.
Yes? Yeah. That's the only difference.
That's the only point.
Okay. So these were intermediary, they were all similarly matched up. The only difference is that the MRI didn't play that big a role in the initial workup. So if you try to implement that now, you would just say that MRI would have picked up all these things. Yamana.
So my contention is MRI was always the confounding factor in confirmatory biopsy.
Yes.
Because it was done in 62% of the patients. And that would change the course of the way we were approaching both these groups.
How would it change?
Because in MRI, you're picking up a Gleason grade 2, and we are not sure this is correlating with the higher pathology. On a pirate scoring, the correlation of a Gleason grade 2 is it same vis-a-vis the histopathological correlation is open to?
Yeah. Agree with that. So there would be, that's what I was saying. You have put in another extra step to pick up the same thing,
So
and that
the,
would
the
alter
comparison is not a fair one between both the groups.
Yes. Okay. So if you look at this is what I was trying to get at, Ginil. If you look at the active surveillance group to the immediate RP group. So just to start off, these were 2 intermediate risk prostate cancer group who were diagnosed at the outset or following confirmatory biopsies. So the question is, do they behave the same or do they behave different? Okay. The null hypothesis was that they behave the same. So here, if you look at it, the patients who underwent immediate radical prostatectomy, there was a higher, we can all look at the statistical, there was a higher proportion toward, they had a larger volume of disease, the ones who underwent radical prostatectomy at the outset. And if you look at the lymph node invasion as well, 7.8 versus 2.6. So that itself is giving you an indication that somebody who lets themselves out to be an intermediate at the outset are slightly different. Yes. So, yeah, okay. Is active surveillance still relevant in 2023? Yes or no?
Yes.
Why?
So I would say there's still, there is a data which is maturing up, and there is data available saying that active surveillance can still be done in fair number of patients, specifically in the GG1 in which this particular study was.
So this paper came, and I don't need to tell you this is the PROTECT paper.
PROTECT paper.
15 years, 17 years. So all the newspapers said there is no role for radical prostatectomy. They didn't go into the minor picture of it. How will you convince somebody puts this in front of you and say prostate cancer survival at 17 years, you can't even see there are 3 lines. There is only 1 line there. And then you say that, oh, metastasis-free survival is different. How come metastasis-free survival is different, but overall survival is the same? Any comment on that?
See, every metastatic patient, the OS will not vary in the sense that even if the patient develops metastasis, it is not mandatory that this particular metastasis is going to have a culminating effect on his OS. So I believe OS probably is going to remain the same. It depends upon the pathology of the disease per se, but metastasis will not probably determine the OS.
There was the 10-year data, then there was a 15-year data. They looked at the patients who were diagnosed with metastasis at 10 years. None of them died by 15 years. So just the fact that they have metastasis doesn't mean that they die of it. That's one. And then the second is, this is the same point that I was trying to make. These patients have an indolent disease. They do happen to have metastasis. They are not same as de novo metastatic disease, the ones that present as metastatic. Manu.
So I also want to tell you something. The patients will not die of their metastasis because this is such a slow indolent course that the overall survival does not vary because they're going because of other causes and natural age-related progression causes in many subset of patients.
Yes and no is the answer. We always think that by preventing metastasis-free survival, by improving metastasis-free survival, at some point we'll improve the overall survival, but they might not live long enough to realize that benefit.
Duration of your lifespan.
Okay. Active surveillance, what are the components if you are going to put a patient for active surveillance? You have a grade group 1, 70-year-old has got medical. What are all the things that you are going to look at? PSA?
Yeah, there is, if there is more of an indolent disease like less PSA.
No, you have decided to put the patient on active surveillance. I don't
so
want to ask
PSA every 3 months we assess.
Okay,
then,
and why
at
are you
18
doing
months,
the PSA? What would be the trigger for you to go for radical treatment? PSA doubling time or PSA density or what?
Actually, I depend on the repeat biopsy and the MRI finding.
No, I'll come to that. So you were doing a PSA, yes?
So,
anything on the PSA that would make you change your mind?
So if it is a increment of PSA on follow-up like 0.75.
So upward rise.
Yeah, upward rise.
Okay.
Then I will reevaluate.
MRI, how often?
18 months is usually my protocol. But
so 0 and at 18 months. Okay. Yeah. Do you do standard repeat biopsies?
I usually do standard biopsy at present.
When would you do it?
At 18 months usually if I am having a follow-up.
So
MRI followed by a biopsy.
3 monthly PSA, at 18 months an MRI scan and a biopsy. Even if there is no progression on PSA or MRI scan, you would still do a biopsy?
At present I am doing, probably MRI may substitute later. But at present
Hemant sir, do you think that's an acceptable one or do you think that's too laid back or too aggressive?
First of all, let me say that I'm not a great proponent of active surveillance. Yes, there is a place today, and as Ginil very rightly said, that you need to monitor the PSA as well as the biology, the repeat biopsies. I'm not very sure whether if your PSA is remained in the same range and everything else is fine. Whether I would
I'll do this way. Okay.
But I
You're
have
not a big fan.
I have been doing at 12 months, not 18 months.
Okay.
I repeat the biopsies at 12 months.
Okay, 12. So you do PSAs every 3 months?
But I don't give too much importance only to PSA.
No, it will always be a
It's
multifactorial.
only a trigger to do the biopsies.
Okay. So you do, if the PSA is going up, you won't operate based on the elevated PSA, you want a confirmatory histology.
Yes.
Okay? And you would do an MRI scan at
MRI,
12 months.
yes.
Overall, we are fine with 12 months. Mano.
So in my practice, a biopsy would be triggered depending upon PSA doubling time and MRI. Otherwise, I may not trigger a biopsy even at 2 years.
Okay. Fine. So I think if I ask the same question in 6 months' time, our active surveillance protocol changes. The PROTECT also kept on changing what their protocol is. Depending on PSMA might come into this and destroy everything else and say, do 6 monthly PSA, PSMA, it will give you all the answers. But active surveillance, the 3 components are PSA, MRI scan, biopsy, variable indication for the biopsy. Okay, we have already answered this. So this is what they found. When you look at the immediate versus the chances of biochemical recurrence is higher with the immediate compared to the ones that were intermediate on the second biopsies. Okay, and my understanding is, as I said, that's what was my understanding. Okay, I'm going to ask each of you, I'm going to put 2 scenarios, which one of them is worse. Okay, the first biopsy is positive or the second biopsy is positive. Overall, who might do worse off? Pradhan sir. The first one would do worse. Even if they have got both Gleason 3+4,
Yes,
the one who was
grades,
diagnosed,
the equivalent grades, you picked up the one at the outset. He has probably.
he would do worse.
He would do worse.
Agree with that? Gleason grade group, this is what we were talking about, in that the ones that are picked up to be Gleason 2 or 3 at presentation are worse compared to the ones that are picked up later. Okay. Does anybody can take up, does Gleason grade 1 transform to, you have done full mapping, 70 core biopsies, there are only Gleason grade 1 in 2 or 3. Will it transform?
No, I don't think. These are the cancers which are missed in the first biopsy. I don't think they have transferred.
Okay. Any changes on that? I thought so. I thought so is my answer. They can. So it is an acquisition of a mutation.
I understand, but it's too soon.
No, I'm not saying time period. I didn't say time period.
Okay, I thought in this particular study.
I didn't say, I just said, I didn't say time period. Yes. So somebody who can have Gleason grade group 1 can acquire a Gleason grade group 2 or 3 at an later date. Okay. Intermediate risk on biopsy or intermediate risk on RP? Which one has got better prognosis?
I would say probably an intermediate risk on an RP.
RP. Because the biopsy said low grade, but the RP said. So I think the further the time we spend with the patient, which will give us the truth, probably is a better prognostic and compared to everything being known at the beginning. Just because of the volume of the tumor, you will know the truth at the beginning.
Because there is around 40 to 50% upgradation in RP specimen compared to the biopsy. So that is also a factor.
So this is the basis for the radical prostatectomy versus Gleason score. So whoever is intermediate or high risk on the radical prostatectomy compared to the biopsy, they tend to behave like their diagnostic risk factor rather than the pathological risk factor. You do need to take the pathological risk factor into consideration, but they do behave like the risk stratification at the outset, not at the end point. So that's the reason the DMECO always sticks at the beginning, not later on. You can't alter it. Okay, so take home messages from that one is the more effort you put into diagnosing a patient, the better is the prognosis for him. Okay, so this one all about radiation oncologists and the one alone medical oncologist. This is the PACE A, B and C. there was one surprising thing which the radiation oncologist missed, but I'll just try to point out. So here, if you see the low and intermediate risk, surgical consideration, the moment it went from intermediate or high risk, there isn't any plan of offering surgery there. That means that actually none of us would be doing any surgeries if we were living in this country. They didn't offer surgery as an option to those patients. So only in low and intermediate risk, which we can say patients who didn't need anything done, were the only ones who were offered surgery or radiotherapy. And anybody intermediate or high risk, they were said 6 months of ADT. But anyway, we are looking at this element, which is low or intermediate risk, the PACE A, comparing SBRT to prostatectomy. Okay? These are the numbers. They wanted to do 2, 3, 4 because the numbers were 2, 3, 4. They ended up with 1, 2, 3, which I thought was quite coincidental. Why SBRT? Why is it different to radiation other than the convenience to the patient? Anything else? Is it oncologically better?
So the radiobiology when we do SBRT is different as we are giving a higher dose per fraction. And as prostate has a low alpha by beta, so it is known to multiply very slowly. So a higher dose per fraction would work better for prostate. We want to escalate the doses to prostate, which would happen more conveniently when we do SBRT.
So the bothersome symptom score has already been explained. I don't want to go further into it. I'm going to come back to you. The next question. Pad usage at 2 years of 46.9%. Either of you can take it. Yeah? And anyone can take it.
The pad usage at
2 years.
2 years is 46 is too much. Like in our practice, we had published this one. It was around 12 was the pad usage, and out of it, more than one was 3 in our.
Hemant sir, what do you think is an acceptable number of more than one pad usage at 2 years?
At 2 years, I would say 10% or less.
Okay. I'm going to point towards both the radiation oncologists. If you just look at this one, this is the hood technique for preservation of the continence. Nothing to do with you, but something to do with the surgeons. So this is a new technique that we are trying to do. And when a patient comes to me, should I tell them these numbers? So the numbers are, at 1 week, 20% will be pad free. By week 48, 95% will be pad free. Because I have read the paper, can I quote those numbers?
No, I don't think.
Why can't I quote those numbers?
See, because surgery is skill based, so if you're not doing it really, you might not achieve them.
Good. That's a learning curve for the surgeons. Okay. Is there a learning curve for radiation oncologists? You will quote those numbers to me and say that patients are pad free at 2 years. There isn't any learning curve for radiation oncologists?
So there is a learning curve for each and every one where skill is concerned. So there's a learning curve for radiation oncologists as well. And looking at this data, looking at this paper, no radiation oncologist would jump and say, I will start doing it tomorrow in their practice. Okay. SBRT, for that matter, is not a very new technique. We've been doing SBRT at multiple sites. So we understand the nuances of SBRT. It's not like doing a surgery in head and neck and doing a surgery in prostate would be absolutely different. But doing SBRT in prostate and doing SBRT in pelvis would be quite similar.
Doing a radical prostatectomy with hood technique, I would say, is similar as well. Okay. For radiation technicians, is there a learning curve? If I'm starting off as a radiation oncologist?
Yeah, I think there is definitely a learning curve. And we have, as Madam
told...
How
would you know you have gone past the learning curve?
So
you might still be learning. You might be senior consultant radiation oncologist.
No, there are definite protocols of contouring. So we know with the advent of newer imaging techniques like PSMA PET, MRI, we know what to contour, what to treat, what margin we need to use for the PTV, what margin.
The last question.
No, so I'll just add to it.
There are definite image guidance protocols that we
I'm
follow.
a patient. I need radiation for something. How do I know somebody is good among radiation oncologists? If I go to Hemant sir and said, what is your margin positive for T2? He gives me a number, I know.
So I give my toxicities that I have with patients. Now, as you said, there is a learning curve for a new technique. For SBRT, if I start doing it in my practice, I would take some time to build up that data, but even I would have that data of toxicity for my patients with that technique.
So if you were a patient, you were giving SBRT for... Yes, sir.
Data, that can be definitely a discussion. But otherwise, when we have been part of these group studies, RTOG, you get fed up of sending the data, the kind of data they ask for. So they do have a huge quality control. But it is a fair question that how do we implement it and how do we talk about
No,
it?
the reason is both medical oncologists that Vamshi is going
So
to
again,
be.
Dr.
I'll ask the question, then you can. Like when they say, oh, docetaxel, they'll say that, okay, the survival benefit is 12%. And they've ignored that there might be a mortality chance of 1 to 6% depending on, I'm just exaggerating the numbers, depending on the experience of the center. We ignore the second part, we only quote the first part. Now you can.
Simple way to do it is through an audit. And that is something which any good radiation center will do. They have their own audit. Our center does an audit for all their patients. So that's one way you know that what they're doing is the correct thing. Second thing, there's always the, like sir is saying, the data on the machine is stored. You can't fiddle with that data. It is the data which is needed.
No, apart from that, there is a lot of standardization of what we draw, what we treat, and what we achieve in a plan. So we know what toxicities we will get if we are achieving something for an organ.
Good. If I made a radiation oncologist a bit angry, I've asked the right question. That study was sponsored by Varian. I totally agree with the trial setting. If I wanted to be involved in a trial of radical prostatectomy, Ginil would not take me unless I provided the data. I'm not talking about if I want to get to anybody, how do I differentiate? That was the question. So for clinical practice, I was asking a question. Okay. Yes. Yes.
He's talking about a different paper.
No.
That wasn't the question. That is taken for granted. You are not operating, of course the patient will be continent.
No, but and as for the other studies also, like phase 3 itself, the pad usage and everything, the geotoxicity was very acceptable. Like,
No, it should be minimal, as you would expect, because you are not operating.
yeah, it is minimal. So when we compare surgery and SPRT or radiation for that matter, the pad usage has always been lesser with radiation.
110%. I'm not even questioning that.
I think the question is not that. He's questioned the fact that 46% of patients used PAD at the end of 2 years.
2 years of surgery. That was too
Which
high.
is not acceptable by today's standards.
That was the question. Because there were quite a few laparoscopic radical prostatectomy done in that. Okay. So we'll come to this one where everyone... Sorry? Yes. 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 Yes.
You know, what is the number of surgeons performing robotic or laparoscopic radical
As I
prostatectomy?
said, I wasn't criticizing the paper. It wasn't a journal club criticizing the paper. I just wanted to learn from whatever I can learn from it. So that's why I've read the paper, but I didn't want to even look at those elements.
So, but can I make a comment on this paper? Just a small one?
Yeah, sentence.
So the ADT is not permitted in low-risk patients in this paper. Active surveillance could have been offered.
Yes.
So the effects of ADT and side effects are totally taken away from this paper. They're not worried about giving the oncological outcomes which will come after 6 months. They're presenting only a smart frame of the paper. They're not presenting a wholesome paper.
Yes.
It's just one frame in the journey. So they should have presented a complete outcome analysis along with the side effects.
That is going to come.
Yeah, it's going to come. They have
But
only
they should have
presented
given
what
it together. They're giving a low risk patient which should have been offered active surveillance.
Let me add to, again, coming to SBRT, because one of the study was done at Tata Hospital, done by Vedang was the PI, it is in JCO. See, I think so efficacy data is there in intermediate situation. No one is saying that option is not there.
Yes.
So I think so that is option is there, and how to take those options in the clinic, I think that's what I think Sanjay is trying to put in, and it's absolutely wonderful data.
The way I wanted to look at it is, if a patient asks for an intermediate risk prostate cancer, wants to have SBRT, how do I know somebody is doing a good job? That's the question that I wanted to comment.
Quality control, what people are putting in the place. Sanjay says the way I do it, you need to also do in radiotherapy side.
Sir, so, no.
Come to that. I will park that question. I'll park that question and come back to it later. So, neoadjuvant novel hormonal therapy.
I think what he is saying is absolutely right.
That's
you should
right.
choose your surgeon.
Even,
but yes, probably the quality of surgery in this was very, very poor.
I understand that. That wasn't the...
See, 50 surgeries over 10 years.
Hemant sir.
Time.
Yes, I'll leave it there. Okay, so neoadjuvant novel hormonal therapy. As I said, I wasn't criticizing the paper. I was just trying to understand the take-home messages from it. Neoadjuvant novel hormonal therapy. This paper has been published. So I was looking at what are all the evidence basis and what are we trying to do. So the way they compared it was there were 3 studies that were randomized controlled trial for the neo-hormonal agent. Then they compared it to retrospective radical prostatectomy group. And as they said, it is better. So they only gave it for 6 months. It was only neoadjuvant, that's one. Then all the patients I had to read again and again. They didn't mentioning about ADT. Only when you went to the previous trials, you realized all of them had ADT and newer hormonal agents for 6 months, did not have any adjuvant. So just with 6 months of ADT and newer hormonal agents, that is the impact. Okay, I reiterate again, none of them had 24 months of ADT. They had 6 months of ADT and newer hormonal agent. And if you see, the effect of it seems to be there even at 6 to 8 years. I don't know why that effect is there, but the effect is there for that long a time period. Probability without BCR, I would have probably put a testosterone level somewhere in there just to see when does the testosterone return to normal, so that we have altered the biology of the disease rather than just the testosterone suppressing it. But by 6 months, you would expect that by 9 months, the testosterone would have come up. And this is the metastasis-free survival. Is that a good enough? Currently, we are using in a short-term study, metastasis-free survival, we say it's a surrogate marker for overall survival, especially when the difference is so much. Okay? So this is what they have said. They have achieved a PCR and MRD of 22%, decrease in the margin positivity as well. Manav, that's cheating, isn't it? The second statement. You're using a drug to alter the pathology and then saying that I'm better.
So, but then you are basically going on a multimodality thing, then it's again not a fair comparison between both.
Yes. No, as in it makes us feel good that we are a good surgeon, but I would take it with a bag of salt and say, let's see how you are in 6 months' time.
Sanjay, can I make a comment?
Yeah, Adis.
So first is, this is not a randomized trial.
Yes.
This is an observational study.
Yes.
The second is that, what they have used in terms of this IPTW kind of weightage, they have tried to match non-similar kind of groups. So whatever you actually score out in the end is probably heavily biased. Because
I totally take on, it's a proof of principle to say that it does tend to alter the way we are treating. That's it. Nothing more.
You can't draw any inferences beyond this.
Nothing more.
Okay.
So better than a case series,
Better than a case.
but nowhere near any randomized control trial. Yes. But the issue was that docetaxel would not work in that setting, and they have given normal hormonal agents. So normal ADT with docetaxel. So probably the combination that you were giving did not alter the intracellular androgen status. I agree with that. It's just that the docetaxel and ADT was appropriate at that time. This is what is appropriate for now.
So I'll make one comment on that paper. So this is basically a paper on high-risk prostate cancer by definition. And if you see the need of adjuvant or salvage radiotherapy in the paper, the standard arm you see 70% patient needed adjuvant or salvage radiotherapy. And in the study arm also, about 41% patient needed adjuvant and or salvage radiotherapy. So we are going to multimodality treatment, neoadjuvant therapy with abiraterone, then surgery, then radiotherapy, and you are adding up the toxicity of all these modalities.
I would do that. We are adding up the efficacy element as well.
So my point is, why not just treating them with the standard radiotherapy and adjuvant deprivation therapy and avoiding surgery in this patient?
I would say the same thing like Stampede, wherein why give docetaxel at the beginning, wait until they relapse and then give docetaxel. I know that's a crude exaggeration. We are trying, I'm just trying to prove a point to say that this is probably the way we are going to treat in future. This isn't a randomized control trial like any of the ones that we have studied.
I read one comment, Sanjay, when I was going through this article by one of the editorial comments. And this Proteus which has been quoted.
That won't give us the answer.
What has been brought out by that comment is that probably we have no randomized data. Even in this Proteus, the placebo, so-called placebo, actually has hormone deprivation. They are on leuprolide, and then you have added APA to that. So you don't have a blind placebo, you non-treated placebo. So
actually you need three.
You need a patient without any ADT.
Radical prostatectomy plus ADT, radical prostatectomy plus ADT, and neohormone. Yes.
One of the other parameters that has to be studied is the chance of not getting a hormone in lifetime, because that is where actually a multimodality treatment may find difference.
Sanjay, just adding one more, because there was a comment regarding giving 6 months and benefiting at 15 years, 15 or 7 years, whatever. Many adjuvant trial is there where we give only for 6 months chemotherapy. Benefit is at 30 years also. So it does happen. There is another very good example. That is intermediate grade glioma. Given treatment for a year, benefit starts at 7 years. Till 7 years, no benefit. And after that, the benefit continues at 15, 20 years. And 3 NEGM paper on that. So idea is that when you give treatment, when you have effect, by tumor-wise, things changes. Not necessarily it remains what we think.
That's an excellent, what I was trying to say was rather than masking the effect, probably we are changing the tumor biology. That's what I was
I totally agree with your interpretation. Neoadjuvant, if you're doing surgery, do good surgery.
Okay. So agonist or antagonist, what would you use, Hemant sir, as ADT? Which one would you use? There wouldn't be any evidence. What do you use in your practice if you were using it?
I will use an agonist.
You would use an agonist. You would not, or would you?
I would, except in certain cases where the high-risk cardiac cases.
No, okay. I'm talking of
as a routine.
No, I'm talking of neoadjuvant before you do a radical. You are inspired by this study and you say, I want to practice this.
Yeah, as a routine, I don't give neoadjuvant hormonal therapy, but if at all, then I would give agonist. I will not be inspired by this study at all.
Anyone else changes?
I sometimes, in patient with impending bladder outflow obstruction, I tend to use antagonist.
Okay.
I don't use it as of now, but yes, there have been literature saying that antagonist may be slightly better because the surgery, the kind of post-op, the intra-op adhesions that you have with the agonist are not there with the antagonist.
Would you use AAP or ENZA? Which one would you use?
I'm using abiraterone at present, if at all I am using it. But thing is, I am not a fan of neoadjuvant hormones. At present, there is no data, but we have to have some trials.
Okay, Mano, would you use enzalutamide?
You are asking the question about neoadjuvant. So I would use AAP.
Okay, so you would use AAP?
Unless it's contraindicated.
Yeah.
Because there's one paper which says possibly if a sequence is to be done, then ENZA acts after AAP.
So agonist or antagonist? Which one would you use, Mano?
Antagonist.
Antagonist, okay. Apalutamide, darolutamide, which one would you use? If you had the option of either using abiraterone, enzalutamide, apalutamide, or darolutamide.
I would go with the simplest, Abby. I would go with Abby.
Okay. Docetaxel chemo, we already know. Medical oncology doesn't know.
This is all in neoadjuvant setting.
All in neoadjuvant. And how long neoadjuvant? 6 months is fine?
I would believe even 3 months is fine.
Okay. Triplet therapy here. What do you think about that, Adis? Neoadjuvant triplet therapy.
Why 3 months, may I ask?
Sorry?
Why 3 months?
Because there has been a randomized trial comparing 3 months versus 8 months of neoadjuvant.
Yes.
And only in the 8-month arm, there was some difference in the pathology.
Yes.
So Sanjay,
So in case you want to do that, achieve that, then 3 months is inadequate.
Okay.
man.
Yeah, go ahead.
Triplet, you'll have to target, you'll have to tailor what you're doing. If
Okay.
you're dealing with a very high
I'm
risk,
just saying,
triplet.
in the future, do you think we'll come to triplet?
I doubt it.
Okay.
I doubt it.
Hemant sir is vigorously shaking his head.
I think so. I think the way things are
Neoadjuvant
going,
followed by
yes.
adjuvant,
I'm not too
like
sure.
they do in
Not too
radiotherapy
sure.
people. So that nobody knows the truth for 2
Before
years.
surgery, I think only neoadjuvant. I wouldn't say.
Okay. I'm going to skip the RETCS pairing because none of the medical oncologists or radiation oncologists would be interested. Okay. This one, I'm just going to ask, is this relevant for India? The reason why I was asking that question is we haven't proven a point that EPLND does anything. We pick up a lot, but it doesn't seem to make a difference with respect to the overall survival. That's one. Second, picking up an extra one node that is in the pararectal space surely won't make a difference if that is not making a difference. And then the third one is, where does PSMA PET sit? Because none of these guys have got access to PSMA PET. So I wanted to answer the question difference between this one and PSMA PET. Aditya sir.
See, PSMA PET, obviously high sensitivity, low specificity is the crux of the PSMA data. High sensitivity, low specificity.
Yes.
So for us, with the easy availability of PSMA PET, trying to get into this would probably take a lot of effort, and maybe only a few centers who are doing a trial would go for this.
Okay. So you would say I would do EPLND guided by PSMA PET. Okay. So that's so this one I just wanted to show the numbers here. If you see that the sensitivity of this is 95% specificity, as you would expect, it's a pathology, it will be 100%. Negative predictive value is 99, positive predictive value is 100%. Answering your question of PSMA PET, these are the numbers. So when you look at it, you said sensitivity is high, actually it is. So positive predictive value is 67, negative predictive value is yes. So the PSMA PET probably is somewhere in the middle for us, and when I looked at the methodology of trying to get that lymphoscintigraphy, again the learning curve with that, I don't think we'll ever reach in the normal setting. Mana.
Can I make a small comment?
Yeah.
This is a good concept, but you know, you add a truss injection the last night, you add a lymphoscintigraphy, you add a SPECT CT scan and the expense to avoid 2 centimeter extra of sampling of lymph nodes, and to try to prove that we are avoiding lymphoseal, which I have not had in more than 1 or 2 patients in last 1,500 patients over last 12 years.
So that's why I said it wouldn't. Currently, the sentinel lymph node for prostate cancer doesn't seem to work just because
As a
of the
concept,
logistics.
it's fine.
Yes.
I agree.
Yeah, agree with that.
Just a comment.
Yes, sir.
About this PSMA. Basically, the thing is, which PSMA agent is this? There are multiple PSMA radiomagnetic.
Gallium-67 is currently the standard unless mentioned.
It is used in the US. So this is a 2019 paper. The gallium was licensed only in 1st December 2020. So this must be Fluciclovine.
That's an Australian one.
It's Australian.
That's an Australian. Almost all the groundbreaking PSMA work is done from Australia. Yeah, you have a. Then we'll have 2 minutes of this last one, and then we are done. Yeah.
Just to make a comment as a radiation oncologist, so when we are treating high-risk prostate cancer, we've got data
Comment.
from POP-RT trial that pelvic RT versus prostate-only RT.
Makes a
Pelvic
difference.
RT
Pelvic
makes a
RT is the
difference.
standard.
That's why I think elective pelvic lymph node dissection still hold promise, even if it is negative on the sentinel lymph node.
No. Okay. We already know where to do the EPLND. Yes. We do it, but we still don't know why we are doing it because we haven't shown any survival benefit. But as oncology surgeon, we would like to prognosticate the patients better. That's why we do it.
From the radiation perspective, we have got the benefit that treating the pelvic node do benefit in patients
Agree
with
with that.
node negative patients.
Agree with
high
that.
risk patients.
Agree with that. So this one, so when it was presented, they said there might be bias. Actually, the way they randomized it between RT alone and short hormonal therapy RT, they had 3 randomization, but each center could only randomize using one of these. They were not offered more than 1 randomization at center. So there was no bias at that center. So if you look at this RT alone plus short-term RT, which was 6 months, this one short-term RT versus long-term RT, and then there is the 3-way arm. And I was, okay, so this is one. Short arm doesn't, so either give ADT for 2 years or don't give ADT. That was my take-home point. And this one is between short and long arm, the metastasis-free survival is better with the long arm. Then there was this sentence. So conclusions were this. Then there was this sentence. Dr. Parker, who was presenting this,
That's a very important.
said, so the other one wherein no hormone therapy to long arm hormone therapy, which was one of the arms, when they studied it, there was no difference. So there is no difference when there is no hormone therapy to short arm hormone therapy. There is no difference between no hormone therapy to long duration hormone therapy, but there is a difference when you use 6 months to 24 months. So again,
So
going
is
back-
the short arm causing some harm?
some way. It's like using the zoledronic acid in any of those monthly ones will lower it rather than doing any better. Okay? So take home messages, whoever presents early with intermediate disease, they are worse compared to later on. Compared to surgery, all the radiation oncologists, SBRT is better. That's the last time I'm going to say it. SLND is the effective method, but probably not practical. Using the newer hormonal agents, I think we will be revisiting this space. Probably they'll be using this more in radiotherapy before we even use it in surgery. Immediate continence recovery rates were better with Retsya sparing at the cost of having higher margin positivity. And if you were using ADT with salvage RT, use it for 24 months. I asked one of our Manchester medical students what this meant. They had various versions. That is, the art of providing care is very long and the life is too short to get to them. But anybody can read anything into it. Thank you very much.
Thank you.
And for this, I would like to invite to chair the session Dr. Pankaj Maheshwari from Mumbai and Dr. Ajit Sawant from Mumbai.
Good morning. I thank the organizers for this kind invitation. Good that Bhalchandra has joined me. It has been a great learning experience. So let's move with the first talk by Ashwin. Pooled outcomes of performing freehand transperineal prostate biopsy with precision point transperineal access system.
Thank you, sir. The slides. Yeah, sure. Thank you. So it's a pooled out. The study title is pooled outcomes of performing freehand transmeal prostate biopsies with precision precision point technique. It's a transperineal biopsy technique. For those who are not very aware, probably the radiation team will know better. They were doing brachytherapies earlier in early era. Not currently, not many centers do it, but basically instead of a guide, we use a stepper, and that's a transperineal biopsy kit. So they had conducted a systematic review until October 21. Primary outcomes were cancer detection rates, any grade and clinically significant ones beyond or equal to grade group 2. And other outcomes were understanding clinical detection rates or cancer detection rates in biopsy naive patients and compare that with PIRAT score as well. So 16 studies in USA, UK, 2 from Asia and Australia, roughly around 3,000, nearly 4,000 TP biopsies conducted. Good point is around 3,400, so nearly 89% biopsies were transperineal local anesthesia. MRI targeting with precision point was done on about 75% studies, not the number but the studies. So coming to the results, overall pooled analysis of cancer detection rates overall are about 60%, variable range 40 to 80, but the median is 68%, and clinically significant ones are about 42%. Similarly, in biopsy naive patients, which were about half the numbers, 1400 across 7 studies with the available data, overall numbers are 66, so similar, taking you back 66, 68 there and 66 here. And clinically significant ones a little better, 42 in the overall pool and 54 in the biopsy naive group. The table below shows the outcomes of similar overall and clinically significant cancer detection rates with respect to the PIRATS 3. One good takeaway from this is we always say PIRATS 3 nearly about a literature says 20% positivity. So in this particular context, there is a positivity of about 55% if we compare PIRATS 3 lesions and 31% for clinically significant ones in PIRATS 3. PIRATS 4 and 5 are similar what we have as a standard, roughly around 80 and 55 and 90 and 70% in PIRATS 5. Coming to the complications, sepsis varied between 0 to 2.5. Retention, which are very much concerning in TP biopsies, that's the criticism or TP biopsy which always has, but it is not very high, 0 to 4.7%, bleeding 0 to 2.3%. Another criticism for transperineal is pain. So visual analog score for pain quotient is similar, 2.8 to 4.5, and tolerability, not every study reported this, but tolerability between 2 biopsy comparisons was almost similar as per only 1 study out of these comparisons. So number of cores taken, one potential thing, just look at the right side column on the highlighted table or highlighted mark. So number of templates which were taken were very high. The word Ginsburg means there was it's another paper which has been published in 2019. Ginsburg protocol is given for transperineal prostate biopsies, and roughly the number of cores taken are nearly 24. So that's a huge number of cores which they take in transperineal, and majority of the other studies had their respective ways of doing it by having a variable percentage of 20 cores or 28 cores, but majority followed Ginsburg, which is at least 20 to 24 cores. The MRI targeting was cognitive majoritively. The other parameters of biopsy naive versus prior negative biopsies, which we discussed earlier, the numbers are represented here. Coming to the complications, I've just highlighted in urinary retention because sepsis is obviously going to be less, and that is the main domain, or that is the main parameter in which the transperineal is coming up in a big way. So just look at the urinary retention rates. They are not very high, 1.5, 3.8, 2.5, 0.9, almost 0.4 and 0 at some point of time, and significant number of percentage. Also look into the antibiotic types. So the next slide will give you the antibiotic patterns. About the biopsy naive patients, cancer detection rates were about 54%, which is favorable comparison to the standardized percentages. And efficacy for detection of anteriorly located tumors was apparent in the analysis. Obviously, it's a retrospective meta-analysis. So it's a meta-analysis. So it's not a direct comparison, but overall, the detection rates in the anterior transition zone tumors was much higher, and almost the detection rates in one particular study was about 49% for overall in biopsy naive patients, and clinically significant it picked up to 83%. So if you see those percentages actually change because you're trying to detect an aggressive cancer in the anterior transition zones, and it is indirectly a significant one, and the percentages jump off to 83%. So More specifically about the antibiotics, nearly 3,000 odd patients had mentioned about the antibiotic usages. Out of nearly 40%, that is 1,257 patients did not receive even a single dose of antibiotic. So that it was completely omitted. That's the way the change is happening for transperineal biopsies. Certain limitations are retrospective design, single arm nature, so it's not going to be productive for comparing this particular precision point technique. This particular paper is in favor of precision point technique of transperineal biopsy, so you can't compare that with other techniques. And no stratification, so it's just the number of biopsies, complications, but we cannot actually stratify or find out the data with respect to the patient understanding or patient level factors or the PSA factors, MRI, apart from pyrite score, other MRI findings or use of MRI and indications of biopsy. So what did authors conclude in this? Authors mentioned that unique aspect of precision point device is its ability to facilitate performing transperineal prostate biopsy under local anesthesia. So what this paper revolves around is a utilization of this particular tool, which acts like a stepper on an ultrasound probe. There is a wide bore needle which goes through the transperineal skin. So you try and avoid number of entry punctures into the transperineal skin, that is by minimizing pain and minimizing retention rates. So this is how the overall outcomes are favoring. Thank you so much. I'm not gone into the literature search. I think that will be covered in the part of discussion. Thank you.
Thank you, Ashwin. I'll invite Dr. Himesh Gandhi from He's going to present his paper on cancer control outcomes following focal therapy using HIFU.
So I'll just start the presentation, and this is HIFU is now coming as a office practice in many centers across US, UK, and this paper revolves around this. It's 15 years experience, and basically we are all aware about the standard treatment options in intermediate and high risk patients. Initially HIFU was only recommended for low risk patients or very low risk patients, and now it has been climbing the ladder as a replacement for active surveillance or as an alternative. And this paper mainly revolves around the data what they have accumulated in the registry in 13 centers in UK, and they have come up with the outcome measures. The objective is to have an oncological outcomes and adverse effects following HIFU for a non-metastatic prostate cancer, especially intermediate and a high-risk disease. So they pulled out around 1,379 patients with at least 6 months of follow-up, and the HIFU machine used was sonoblade. Gleason score 6 to 9 prostate cancer patients were taken up, and few patients had stage 3 disease also. 1.5 to 3 Tesla MRI was used in this, and the indication was any MRI visible lesions and the patient having no high volume disease in areas which cannot be treated by focal ablation. D-amico classification was used, and when the patient had an intermediate high risk group disease, further imaging in terms of bone scan and cross-sectional imaging was done. Ablation was done with the help of MRI fusion or sometimes expert guided visual estimation, and in this analysis up to 2 sessions of focal therapy were allowed. And some cases where the operator felt that okay, the disease is a high volume disease and cannot wait up to full effect of HIFU to set in, then they were given neoadjuvant and an adjuvant hormonal therapy, especially within 12 months of the focal treatment. Protocol was as similar like what we do, like PSA every 3 to 6 months in first year and then 6 monthly. MRI was routinely done every 6 to 12 months. However, for cause MRI, as in if the patient has an elevated PSA, then it was indicated as and when required, and then subsequently biopsies were taken, and if the patient seems to have progressed or a new de novo disease happens, then a repeat focal treatment, that is a second treatment of HIFU was given, or a patient could have offer a treatment for radiotherapy or a radical prostatectomy. All adverse events were also identified. So outcome measurements was mainly in terms of failure-free survival, and secondary outcomes were mainly related to the retreatment free survival, salvage, whole gland, either RP or RT free survival, ADT in those patients who were offered free survival, metastatic free survival, and prostate cancer specific survival. all the adverse events were reported as per Clevin-Dindo classification. So if you see this, the mean PSA was 6.9, and the predominantly in this study, in this paper, the authors managed to pull up more of an intermediate and a high risk group disease patients, which accumulated around 93% of the total population. And if you see the last paragraph, then the predominant accumulation happened from 2010 to 2020. So last 10 years, 10 to 12 years, they were able to accumulate these patients because then they were including more intermediate and high risk group patients. So, sorry, couldn't pull out much of the table. So this is what I have been given. So the Kaplan-Meier estimation for failure-free survival, that is the primary outcome, was, if you see in all risk group, it is 69%. And if you see in intermediate and high risk group, so in intermediate, if you can appreciate the green curve, so it is 68% at 7 years. And the red curve, which is a high risk group, it is 65%. So definitely up to 70% we can take home that failure-free survival can be achieved with two sessions of HIFU. Similarly, if the patient progresses on the 2 sessions and then they have offered a salvage protocol in terms of either RP or RT, then subsequently we can still achieve a 70-73% failure-free survival after such treatments in both intermediate and high-risk group patients. Secondary outcomes, like I mentioned, so up to like it's already discussed that up to 75% at 7 years in those patients who had RP or RT, they have failure-free survival, and many patients were followed up to 5 years. That comprises of around 75%, and still they were doing better with 2 sessions of focal therapy and didn't require any more treatment. If we pull out of 1,300 patients, 91 underwent the whole gland treatment, that is 53 were undergone RP, and 39 underwent RT. So up to 75% patients we can have a reasonable control of the cancer in both intermediate and high risk disease. The complications rate were also very less, where the reported complication was for Clevin-Dindo more than 2 grade was just less than 0.5%. So at 7 years, if we take into the consideration, almost 69% patient has a failure-free survival with a primary focal HIFU therapy in a non-metastatic setting, with a metastatic-free survival of 100% and prostate cancer specific free survival of 97%. 20% of the cases needed a second session of HIFU over 7 years, and second focal treatment appears to be effective and remains part of the focal therapy intervention. The patients are already counseled at the time of inclusion, when they were offered HIFU, that they might require at least 2 sessions, if not more. So this paper actually doesn't require any patient informed consent because it is just pulled out of the registry, and ethical board approval is also not required for this paper. So there are strength in this paper is that predominantly almost 93% is a intermediate and a high risk disease, whereas the very few are the low risk group, and complications have been reported, which is it's 0.5%. I would just missed the 0.0. And incidence of rectal injury and urinary retentions and UTI rates are also very low. The important part in this paper was that all patients undergoing HIFU were advised to do, were actually had a catheter for 7 to 10 days, and they were self-taught to have a self-intermittent catheterization, which on and off, if they have undergo a retention, they were supposed to do it. And a 7-day antibiotic protocol was followed. So that might also affect this low rates of retentions and UTIs. So limitation is there. The patient, the follow-up is quite low. The median follow-up is just 32 months, and sometimes patients may not are not willing to undergo a repeat biopsy if the PSA is remaining stable and non-suspicious MRI results are there. So this is always a risk and benefit when we offer this kind of treatment, because the whole crux of the treatment is the follow-up protocol, which if the patient doesn't comply, then it's a problem. location of recurrence was not captured, which is very much important, whether the same area is recurring or because HIFU is normally practiced as a quadrant or a hemi-quadrant ablation therapy. So which part of the prostate, which quadrant is recurred was not mentioned here. And also the compliance with the patient-reported outcome measure score was very low in this. So whether patients were really happy, whether the retention and all part, they were really okay with the self-care and all, that were not reported properly. So in conclusion, HIFU seems to be a reasonable alternative to active surveillance, or maybe a form of a treatment in intermediate and high-risk cancer in terms of having a good cancer control in medium term. Thank you.
Thank you.
Good morning, one and all. At the outset, first of all, I'd like to thank the organizers for giving me the opportunity. I'm going to speak a paper presented by Dr. Michael Zalewski at the ASTRO 2022 in San Antonio, and we know he's a very well-recognized radiation oncologist, especially focusing the genitourinary tumors. So he spoke about the superior post-treatment biopsy outcomes with high-dose SBRT compared to high-dose conventionally fractionated IMRT for clinically localized prostate cancer. Dr. Zalewski has been instrumental for justifying the role of SBRT in prostatic tumors, and he already had a lot of papers which emphasize the prognostic significance of a negative post-treatment biopsy result after high-dose IMRT, highlighting his team's prior work demonstrating that patients with a negative post-IMRT biopsy had significantly improved PSA failure, distant metastasis, and cancer-specific mortality rates. The aims and objectives of this study was that it is to retrospectively compare the post-treatment biopsy outcomes of prostate cancer patients treated with high-dose conventionally fractionated IMRT versus high-dose SBRT. The study had about 416 patients with lower intermediate risk prostate cancer who underwent a post-treatment biopsy following the high-dose EBRT. So this biopsy basically was a scheduled biopsy. It was nothing related with the PSA report or any other features seen on the radiological grounds. The 186 patients were being treated with conventional fractionation IMRT with a median dose of 81 gray, and 230 patients received SBRT to a median dose of 40 gray in 5 fractions. The biopsies were performed 2 to 3 years after radiation therapy with a median 12 to 15 course. Looking at the baseline patient characteristic, about 80% of the patients in this cohort were NCC and intermediate risk group patients. The use of short-term ADT for 6 months was more common in the patients with the SBRT arm, that is 84% versus 56%, and expected radiation dose was higher in the IMRT group, that is 81 gray versus the 40 gray. So the results were the proportion of the patients with a positive post-treatment biopsy was significantly lower in the SBRT arm, 11% versus 38% in the IMRT arm, with a significant p-value of less than 0.001. And it bears note that these were not those patients, as I mentioned before, they had a PSA relapse or something seen on the radiological grounds, but this study already had a prior scheduled biopsy. Incidence of the post-treatment biopsy, however, was being found to be significantly higher in patients who did not receive ADT, that is 28%, as compared to those who received ADT is 13%. So what results were seen was restricting the analysis to the patients with unfavorable intermediate risk group and looking to the ADT use among the IMRT versus the SBRT cohorts. The authors determined that the use of ADT in these patients was associated with a decreased incidence of positive prostate biopsy, irrespective of the radiation regimen being used, that is IMRT or SBRT. And the multivariable logistic regression analysis evaluating predictors of a positive post-treatment biopsy demonstrated increased odds in the following subcohorts of IMRT conventional fractionation with the odds ratio of 2.7, no use of concurrent ADT as odds ratio of 2.2, and unfavorable intermediate versus low or favorable intermediate risk, that is with the odds ratio of 1.43. However, there is no sufficient evidence to suggest that the effect of hormone therapy on the biopsy outcomes differed either between the two radiation types or between the different risk groups. So to conclude from this study, among the patients, mostly the intermediate risk group, who underwent post-treatment biopsies following high-dose radiotherapy, the most significant variable associated with an improved biopsy outcome was the patients treated with SBRT as compared to IMRT. There was a trend for significant reduction in positive biopsy outcomes for patients treated with short course ADT with a p-value of 0.05, and improved local eradication of prostatic disease appears to be more frequently achieved with high-dose SBRT, likely in combination with short-term ADT. I did not know the pattern of today's conference, but that's why I have put 2-3 papers, but I'm sure Ritika would take this forward in her panel. When we talk about the use of ADT with the SBRT, you would find many papers advocating it and many papers against it. Like this is one of the paper in the 2020 where they showed that the effect of ADT on the long-term outcomes of intermediate risk prostate cancer, especially the secondary analysis of the RTOG 9408, it had proved to be beneficial. And it did support the NCCN's recommendations also for the use of ADT. Another paper published in the European Journal of Cancer 2021 had the same interpretation where the ADT was found to be beneficial, whether it was a radiation dose of 70 or a dose escalation of 76. Another in the 2019 where in fact they've said that men who are 70 years or younger with favorable intermediate risk prostate cancer treated with radiation alone to 70 gray are at increased risk of biochemical failure. So even in this favorable group, they advocated the use of ADT. And then there are papers who would be not very much in favor of using ADT. Like this is a meta-analysis published in 2022, which says that ADT plus radiation did not provide OS or biochemical relapse-free survival advantage in the intermediate risk group of patients. Similar such studies. There were certain papers, very recent papers, who also has observed that there are disparities in the terms of socioeconomic grounds when we are advocating ADT with SBRT or IMRT in the intermediate group of patients. But finally, one last paper, which is about the SBRT and the androgen deprivation therapy for localized prostate cancer, recently published in 2022, which says that SBRT dose of about 42 gray in 7 fractions with the short-term ADT represents a very safe and effective method for the unfavorable and high-risk prostate cancer. So probably I think with this paper, where we don't have much randomized or more properly defined patients, we still have more time to count on this conclusion, and probably a more better designed randomized trial will be giving us better information. And I'm sure Ritika will take this forward in her panel discussion. Thank you for being a patient audience.
Presentation.
Thank you, Ritika. Thank you, Dr. Aditi. Thank you, Kumar Prabhash sir, for a kind invitation. I'm Dr. Prahlad. I'm a radiation oncologist in Chennai. So the topic, the paper abstract given to me to present is about salvage radiotherapy. Yeah. So it's about salvage radiotherapy. We know along with salvage radiotherapy, we have to give 6 months of GnRH analogs. Along with that, this paper is studying whether the addition of abiraterone, apalutamide, and prednisolone improves outcomes. The paper was presented by Dr. Guyan, who's a well-known radiation oncologist from Dana-Farber Institute. It was presented in ASCO last year. So we know the background that from the Getug paper, we know that RT plus 6 months of ADT, there's an improvement in progression-free survival with a hazard ratio of 0.54. So the investigators, they proposed that when patients needed salvage radiotherapy, and if they had at least one unfavorable risk factor, and they listed the unfavorable risk factors below, those with Gleason 8 to 10, PSA more than 0.5 when they started the radiation, either nodes were positive, T3, T4 disease, and surgical specimen, PSA doubling time of less than 10 months, negative margins, or a persistent PSA which never dropped, or a local recurrence as seen on imaging. When any of these risk factors were seen, the investigators suggested that whether the addition of 6 months of intense treatment with abiraterone, prednisolone, and apalutamide, seen here, somewhat to our population, our patients, race was equally distributed among the 2 arms. Gleason score, again, Gleason 9 was almost 1/3 of the patients had Gleason 9, similar to our patient population, PSA at enrollment, and node positivity. So when they study low hazard ratios and significant p-values, But this was not the case when they in the pre-planned subgroup analysis. Even the PSA was more than 0.5. When the PSA was less than 0.5, there was no improvement. Even in node-positive disease, there was no improvement. So the final conclusion, as presented by the author in ASCO, he said this, that although the primary analysis did not meet the pre-specified threshold for statistical significance, it strongly suggests that addition of abiraterone, prednisolone, apletomide to salvage radiotherapy and 6 months of ADT may improve progression-free survival and metastasis-free survival. But what has shown improvement is when patients started their salvage radiotherapy after PSA was 0.5, they showed a statistically significant benefit in both progression-free survival and metastasis-free survival. So we are discussing since morning about salvage radiotherapy and whether 6 months no ADT or 6 months ADT and 2 years ADT. So this, and we have come somewhat getting to the point that 2 years ADT is good or is better than 6 months ADT. So in the context when patients start their radiation salvage RT after PSA is more than 0.5 and they would require prolonged ADT, 6 months of intensified ADT with next generation anti-androgens may provide an attractive alternative to lengthening ADT for patients with rising PSA and unfavorable features after radical prostatectomy. So my take on this is that final mature results may show an improvement in all subgroups. It was just bordering the level of significance. It might show improvement in the final results, mature results. But we now have an option of intensified 6 months of treatment for those starting salvage RT when PSA is more than 0.5 rather than the 2 years of ADT. Benefit is almost in the range of 18 to 20% as compared to ADT plus bicalutamide of 6 months. And the side effect profile, which I did not mention earlier, was acceptable in both the arms. Thank you.
Thank you, Dr. Prahlad. I invite Dr. Triranjan Basu for the next paper.
Good morning. Thank you to the organizer. And this, like Dr. Sarupa said in morning, we actually look forward to this U review. So my paper is on sequencing of androgen deprivation, especially the short duration of androgen deprivation with radiotherapy for non-metastatic prostate cancer. It's a sandstorm study, a pooled analysis of 12 randomized trials. So this was published in JCO last year, sometime back. This is a pooled analysis of 12 randomized trials. We know the background that ADT with radiation improves survival. The two main source of the data is from RTOG 9413 and the Canadian 0101 trial. They want to see the optimal sequence as well as relation to the radiation field size, whether we're doing a prostate only or a whole pelvic radiation. Now, in lieu with that, the Amar Kishan study of the individual patient meta-analysis has suggested that addition of ADT, prolongation of ADT with a modern radiation dose increase metastasis-free survival irrespective of the risk group's age and the RT dose given. However, to keep in mind, this has not to do with the prolongation of the neoadjuvant hormone schedule. Based on that, this MARCAP consortium hypothesized that a short-term androgen deprivation, which is 4 to 6 months, and a radiation field size, either doing a prostate only or an whole pelvic radiation, in the concurrent and adjuvant scenario would offer an improved metastasis-free survival. Now here, neoadjuvant means that the hormone has gone 2 or more months before starting the radiation, and concurrent initial PSAs and high NCCN risk groups and higher percentages of utilization of whole pelvic radiation. However, there was improved metastasis-free survival in the concurrent adjuvant protocol than the neoadjuvant concurrent protocol. If you see the 10-year estimates, it's around 65% versus 61%. Whereas improved biochemical control also in seen with concurrent adjuvant protocol than with neoadjuvant concurrent protocol. Improved overall survival also seen in this. So all these three parameters were better in the concurrent adjuvant protocol than neoadjuvant concurrent protocols. After the statistical adjustment, except for the overall survivals, all other endpoints were correlating to the radiation field size. So in the whole pelvic ways, the prostate only radiation, there is improvement in MFS and overall survival and in a concurrent adjuvant ADT sequencing. Whereas once we do whole pelvic radiation, there's improved distant metastasis-free survival by an neoadjuvant concurrent regimes. Now these are contradicting results to RTOG 9413 and the Canadian data. There are unclear mechanism related to that. This is authors have concluded as well. Maybe the adjuvant ADT causes a protracted radiation-induced tumor cell death, whereas an whole pelvic radiation might eliminate pro-inflammatory lymphocytes. These are all hypothesis generating. Now, they accepted their limitations. There's a lot of heterogeneity. You are trying to pull 12 trials results together. There were not a mandate on outcome. So probably for intermediate risk, especially for the favorable ones, we really don't need to do a neoadjuvant hormone and wait and then do, which has been done in traditional way. However, there are a lot of weaknesses like the heterogeneity of the data, combining intermediate and high risk together. For high risk, this is suboptimal. The short report as well is suboptimal after the POP-RT data. There are no toxicity data reported on this and no comment on the type of ADT agents used and in relation to achieving the castrate range. Now this also opens window of opportunities documenting in a prospective evaluation of short-term androgen deprivation in purely intermediate risk and see the sequence between prostate only or whole pelvic. There would be further documentation in the high risk for long term. We'll have a lot of already articles on SBRT and hormone will also open opportunities by this, and maybe we can avoid ADT in the favorable intermediate risk. The imminent threats would be relying on an IPD and then changing the practice, and which is somewhat different to the standard of care of neoadjuvant, concurrent and adjuvant ADT as we do. There should be a strict caution on omitting the whole pelvic radiation after the POP-RT data and also the SPORT trial and other datas. And they have again clubbed high risk, so we really don't have a clear answer for short-term androgen deprivation and how come high risk be included. So probably these two would answer these questions in future, one related to ADT with and without whole pelvic radiation, coupling both unfavorable intermediate and high risk in the RTOG 0924 and the pivotal boost trial, which is in 2x2 factorial designs of whole pelvic prostate only with an prostate dominant interprostatic nodule boost with and without. So we'll have to wait for these two probably in the 6th or 7th GU review to get an answer for this. Thank you.
So the last paper of this session, I invite Dr. Rohit Malde.
So I would like to thank the organizers for giving me this opportunity to speak. So this is a very unique phase 3 trial, which is trying to influence and incorporate a molecular imaging. So this was done by Jeremy Calais, who from the UCLA Center. So they work in the Department of Theranostic and Molecular Imaging. So it's a nuclear medicine department which had initiated this trial, and this was collaborated by the NCI. And this was done at a time when there was COVID time. So it's been completed in a record 2 years. So which is again really, credit to the investigators who've done this trial. So giving you a small background about this trial. So this particular trial, we know that biochemical recurrence takes place in 20 to 80% of patients within 10 years, after radical prostatectomy, based on the different NCCN risk groups. The concept of giving radiotherapy is now shifting from adjuvant radiotherapy to early salvage radiotherapy treatment, and the whole gist is to try and detect them as early as possible. So you do a PSA, and as soon as the astrophoenix definition is met, which is more than 0.1 nanogram, we would call this as biochemical relapse. And the idea is that earlier you treat, the better are the outcomes. But the overall salvage radiotherapy, we know that can cure almost 50 to 60% of these patients. Now, the standard of care imaging for these particular patients who have got very, very early sort of recurrences, the thing is, the problem is it's too insensitive to detect the real site of recurrence at this particular PSA levels. So hence, the thing is, there is this new radioligand 68 gallium PSMA 11 molecule, which is highly specific. It is reproducible, produced from a cyclotron machine, and it is superior at detecting early disease. The same group have done some 270 odd patients, and they've said that if the PSMA, if the PSA is less than 0.5, there's almost a 50% detection rate, whereas 95% of patients would have detectable disease when the PSA is more than 2. So the question, the thing is really this trial is trying to answer is, could we incorporate this PSMA CT PET scan and help the radiation oncologists to try and see if we can influence and improve the outcome of successful salvage radiotherapy treatment. So this is the trial schema. The inclusion criteria: you need to have patients who are histologically confirmed prostate cancer, those who have had a biochemical relapse, PSA more than 0.1. They should be willing for radical radiotherapy treatment. The treating radiation oncologists should be able to randomize, and those where the thing is they are randomized in the arm of PSMA CT PET scan, the radiation oncologist should use that information from that and influence the plan if they must. The exclusion criteria would be any patients having extrapelvic metastasis, as it was believed that these are metastatic cancers and they may not, many clinicians would not treat them with radical intent. They shouldn't have gone to a medical oncologist. So the thing is, any patient going to a medical oncologist where ADT has been started, or novel hormonal agent has been started, or any systemic therapy is started, they would be excluded from this particular trial. And of course, there shouldn't be any contraindication for radiotherapy like inflammatory bowel disease or any other condition different. So hence, they had to have more sort of power on the interventional arm, and hence the randomization was 1:1.13. So in the conventional arm, so these patients would be, they would have any standard of care imaging, be it CT scan, bone scan, MRI, whereas in the interventional arm, the PSMA CT PET scan would be done, and the thing is the radiation oncologist would have access, and they had the opportunity to change their management plan based on that. So now what they have done is they have asked the radiation oncology to fill case report forms as what they would do prior to randomization, what would be the radiotherapy plan. And then the thing is, at the end of treatment, they would actually have to submit another case report form or actually what has been delivered. And this was all recorded. In this particular trial, the radiation was left to the clinicians enrolled between 6th of September to 17th of August. So completed record within 2 years. 90 control subjects and 103 intervention subjects. There were 13 dropouts, 8. In fact, the thing is, they got randomized to the control arm where no PSMA, but the thing is they used their influence and they got PSMA done at other centers. And the thing is, 8 patients sort of thing is, they were excluded. And there were 5 who withdrew consent. So they may have gone to the medical oncologist and some systemic treatment or something was started. So they also withdrew the consent and they were out. So eventually they were left with 77 patients who proceeded with standard imaging. And there were 103 patients, out of which there was 1 dropout. So this was a patient who had severe complications of COVID, and he was by the radiation oncologist. Major changes were 22% in the control arm, whereas 44% in the interventional arm, with escalation seen in 30%, de-escalation in 12%. These are in the interventional arm, as opposed to 9 and 8% in the control arm. And there were mixed changes. So here to summarize, the change in management which were PSMA related were almost 32%. There were lots of other changes which were made in the management plan, but these were all patient, physician choice or non-PSMA related. So we don't have the detailed breakup of these. So this is a schema which shows that in the control arm, 77 patients who proceeded with the treatment, 60 had proceeded without any change, whereas 17 there were some major changes. Whereas in the interventional arm, there were 53 major and minor changes, 49 proceeded without any change, and there were 36 who had escalation, 13 de-escalation, and 4 were alternative therapy decision. So my conclusion, this is the first prospective phase 3 trial which has tried to incorporate a molecular imaging modality to influence the SRT therapy. The PSMA PET findings provided information to the radiation oncologist, which initiated a major change to the SRT in 32% of patients, almost a third. The major changes between the pre-randomization RT plan and the definitive RT plan was 44% in the PSMA versus 22% in the controls, almost double. And these trial subjects, of course, will be monitored and, to see really the impact on the 5-year biochemical recurrence-free survival, and probably we'll have these results in ASCO 2025. Thank you.
Thank you, Dr. Rohit. I'll invite Dr. Pooja Patel to give her expert comments for 5 minutes.
So very thought-provoking trials, and I'm sure the next moderator will take it further, but just a quick comment for all these studies which has been presented so far. So the first one was a transperineal prostate biopsy with a precise TP access system, and it looks very promising and unique because possible of doing it under local anesthesia and with minimal pain and decreased retention rates. The second study where the 2 short courses of HIFU for the non-metastatic prostate cancer again had shown to have a good cancer control. However, it's a very short median follow-up study, so we need to have more follow-up on those patients. In the third study where for the salvage cases where Dr. Prahlad had his inputs on intensifying the treatment with abiraterone acetate, prednisolone, apalutamide, along with 6 months of ADT, may be promising in the increasing of the progression-free survival rate and the metastatic-free survival rates. Regarding Triranjan's paper of sequencing of the ADT of the short course along in the non-metastatic prostate cancer, probably it looks that concurrent and adjuvant ART looks to be optimal. However, we are awaiting the RTOG 0924 and the pivotal boost study. And the last paper by Dr. Rohit Malde, where it looks very different change with about 32% of the planning portals being changed with the impact of PSMA PET scan. And however, we would be monitoring it further also, as he mentioned in his last concluding slide, for the 5-year results. So that's all, and I hand it over to the organizers again and for the interesting panel after.
Thank you, Dr. Patel. I'll now invite the moderator for the next session, Dr. Ritika Harjani. And I'll invite the panelists for this session, Dr. George Mule, Mumbai, Dr. Rakesh Sharma, Hyderabad, Dr. Saurabh Vasisht, Bangalore, Dr. Deepak Abrol, Jammu, Dr. Ram Alva, Bangalore, and Dr. Vamsi Krishna, Hyderabad. Over to you, Dr. Ritika.
Thank you, sir. Thank you. I welcome all the panelists. I think Dr. Ram is not able to join us for a personal emergency, so we have all others here.
Yeah, hi, I'm Dr. Gargi.
Hi, Dr. Vamshi here.
Dr. Rakesh, urologist.
Deepak, radiation oncologist.
Saurabh Vasisht, urology.
Okay. So we begin with the panel discussion. So these are the abstracts we would be covering in this panel discussion, and going to the first abstract first about the precision point transperineal access system. So my question is to the uro-oncologists here with us, Dr. Rakesh and Dr. Saurabh. So what comprises your practice? So when you do a prostate biopsy, what is commonly done by you?
As of now, standard transrectal 12 to 13 core with targeted biopsies of the lesion.
Okay.
On the MRI. Okay. MPMRI is done prior.
With the cognitively
Yes.
fused MPMRI.
Yes.
Sir, the same. Have you all ventured into transperineal biopsies?
No, I don't have any.
Anyone maybe from the audience who is doing transperineal biopsies would want to add? Yes. Hi. Okay. Yeah, I think so. If we could hand the mic to them, please. I'm a radiation officer.
We switched over to transperineal last more than 1 year, and almost 90% of our biopsies are transperineal now. What we see is retention rate is slightly high, infection rate is very low, and the pain component is one factor. We are doing it under anesthesia because majority of our patients, they are comfortable with the anesthesia rather than local because they are apprehensive about that.
Okay.
No, I just
So,
want to make a comment.
yeah.
Although it is very good and I don't have personally any experience about it, but I think a very specific subset of patient qualifies to have a transperineal biopsy. In an Indian scenario where most of the time we are getting the disease which is rectally palpable, and on MRI if the disease is mainly in the mid zone or this, I don't think so that
I'm
it
going
will
to come to that, in the relevance of it in our setup, but yes. So I think with transperineal biopsies, there are a number of procedures. There's freehand, there is precision point, what this talk talks about, and there is grid-based. So personally, actually, we've been doing in our institute grid-based transperineal biopsy with not much of a problems as compared to freehand also. So any problems in any areas of transrectal biopsies where you feel that these cases are the ones where I don't want to go ahead with a transperineal, a transrectal, and should be, if I have the opportunity and the system,
I
transperineal?
think if the disease is mainly anteriorly placed, then it will going to make a sense and it will going to increase the positive predictive value of the procedure by doing a transperineal biopsy. But if the disease is in the peripheral zone or in the mid zone, I don't think so it will going to make any difference.
Okay, so your experience?
We at cancer centers generally we get larger volume disease only. Very rarely we get the screen detected patients. So never face such problems. Transrectal has been doing good, but we want to switch. The problem is the anesthesia part.
Anesthesia. So as someone mentioned from the audience that they do it with anesthesia. Actually, this
So generally what
trial,
happens, whoever I've spoken, they have started the program. Initially they start under anesthesia, and once they are accustomed to how to handle that, then they move on to the local based procedure. So initially you need anesthesia too, because you are yourself learning. So that time you take more time.
So Dr. Ashwin is here who presented. I think he has some experience on transperineal precision system from what I've heard. So you did it with anesthesia or local anesthesia? Okay. So the cancer detection rate overall, what they showed in the study was overall and the clinically significant disease was 68% and 42.6% respectively. These are good numbers, but the variability, when he showed the trial was huge. For overall, it was as much as 40 to 80% or 85%, and for clinically significant disease, it was less than 20 to more than 65%. So what could be the factors that can affect the cancer detection rates in this type of biopsy? Like in terms of the technique, what is it that can change these numbers?
So I think mainly if we are dealing with the anteriorly placed cancer and trying to hit with the transrectal approach, there is a...
Yeah, I'm talking about the difference, variability in studies of precision points. So transperineal biopsies are having these ranges. Of course, one is a learning curve.
A learning curve is
Other than
important.
that, anything that you think could influence these numbers?
I don't think so.
Okay, anything? So maybe a pre-biopsy MRI with cognitive fusion or a system-based fusion and pre-biopsy PSA levels are some. So one of these studies which had only a 20% detection rate, they actually, in the entire review we don't come to know, but they were actually re-biopsying previously negative ones. So we are expecting them to be negative just on the screening and surveillance. So that could be the difference, and the MRI could add. And...
Dr. Ginil wants to speak.
Yeah, please.
Axial, so we get a better yield of prostate tissue when we are entering coaxial with the urethra. So I was not initially thinking that this can give a
puncture the individual, and which is not warranted if we can do with a single puncture. And so would you decide on the technique based on the situation? So in surveillance versus initial staging, it has been known that surveillance, the upstaging... Sorry, is everything okay? Yeah. So surveillance, of course, as you mentioned, as per the location on MRI, you would select transperineal and anterior situated. And any difference in your preference if you had, everything available to you between surveillance biopsies and the initial staging biopsies? Because this paper talks of an improved upstaging when we do transperineal as compared to
Makes sense if we are looking forward for a surveillance biopsy, because there we are looking more forward to look forward for the cancer detection rate, and we don't want to miss them. So I think if first transrectal biopsy is negative, it is better to go for a second transperineal biopsy
I agree.
rather than other way around.
Yeah, so maybe when we are starting off as a system, those are the indications where we should first start off and then gradually,
So it is just like that, that the initially transrectal biopsy is done on the basis of cognitive base, but later on if it is negative and you are having a high suspicion rate, you will like to switch over or offer a MRI transfusion guided base. So I think that's the same thing.
Okay, thank you, sir. Gargi, in TMH, what is the general practice? What are you all doing? Of course, the urologist.
We are doing transrectal exclusively.
Commonly for everybody. Yeah. Okay, thank you. So 89% of the times in this study, the procedure was done under local anesthesia. I think I have one doctor here who's talking about transperineal. So, and beginning with GA is preferred, and then probably we would move over to local anesthesia is what I got as an answer. So we talk of less sepsis rates with transperineal biopsies, less complications. So of course that means transrectal has their own share of complications. As a surgeon, talking to others, the radiation and medical oncologists, could you brief what exactly is the sepsis rate and how bad it becomes, and a little bit of the general information you can share with all of us?
Generally, all the precautions are taken, the pre-procedure precautions, but still these patients might be having some resistant organisms and acute prostatitis.
So one in how many you feel actually develop some infections, and one in how many goes into a sepsis?
Less than 5% actually. We don't see that commonly, but every patient will have some low grade
Biopsy, they continue it for next 5 to 7 days. So practically as such, I have seen only 2 cases in my entire career.
Okay. And the next question, feasibility in our Indian setup. We were once in our journal club discussing the cost of a transrectal versus a cost of a, we have grid, so grid-based system versus precision point. So any comment on the feasibility in our Indian setup based on cost effectiveness? Of course, the trial talks that, ultimately it is cost effective because of the low sepsis rates. But overall, as an initial procedure, do you think it's cost effective in our setup?
I think so. It should not be a problem. The cost, unless you're using GA, means anesthesia has been given.
We are going to use GA in our initial learning.
So if you're going to use GA, definitely the cost will rise, depending on center to center.
Tug of war, I'm not going to ask you on what you would prefer, because we'll move on with the case. Between the patient was started on neoadjuvant hormone therapy, but patient took an opinion of a uro-oncosurgeon and went ahead with radical prostatectomy after 1 cycle of ADT. So patient underwent robot-assisted laparoscopic radical prostatectomy with bilateral pelvic lymph node dissection. And so while we await histopath report and before we move on to salvage, my question is to the 2 radiation oncologists here and the surgeons, because you're going to refer to us, any factors you look for to suggest immediate adjuvant treatment in the histopath? What are you expecting?
We'll first look for the histopath report, look at Gleason scoring. We'll look at how many cores have been taken and how many percentage of cores are positive. And then PSA level.
Well, I'm talking about a radical prostatectomy has been done. We are waiting in those 4 days for the report. When are you looking for any pointers in your brain that, if this patient has these factors, maybe an early radiation versus a salvage would be better? I want to treat immediately. Or the surgeon wants to refer immediately.
Yeah.
So basically, we'll look into the margin positivity. We'll see T3A, T3 is already T3B clinically. Margin positive lymph node positivity is there. And those are the mainly 2 criteria we'll see. Depending on that, we'll decide on the adjuvant. Plus, we'll look into the first PSA, which is done at 4 to 6 weeks interval.
Okay, so nothing immediate you're looking at. Gargi, any comment on early adjuvant versus waiting for salvage?
Yeah, so we would definitely wait for the final histopath, but since this patient had a Gleason's of 4+4 and T3B disease and PSA, I think, of
24.
more than 20. I would feel he's likely to require.
Gleason score is 4+3, and previous PSA we have seen 24. It's coming into intermediate risk group. So we will take him for up for adjuvant treatment, RT with ADT.
Okay. Gargi, any thoughts?
So, though not a radiation oncologist, but looking at this high Capra score, you have a seminal vesicle. Wouldn't this be a candidate for actually a adjuvant RT? I mean,
Yes,
not a salvage.
It would be. But then that's why I asked initially that,
That's what I
factors
told
would you look for?
adjuvant
Yeah.
RT.
But then this patient per se, this is a real case scenario, had, undergone waiting, and then 6 months later when the PSA rose, salvage RT was initiated, and I'm looking forward to take that forward.
In this scenario, I think one more important thing is the yield of the pelvic lymph nodes. They are very less.
Okay.
So that also has to be seen in view of seminal vesicle involvement, the volume of the disease, and inadequate lymphadenectomy.
Okay.
It all justifies to start a RT as soon as possible, adjuvant setting, rather than waiting till that much of time. Because these are the indicators where we should look forward for the adjuvant RT, even though if the PSA is less. Because these are the patients who will going to fail very soon. And then when the salvage RT will be started, at that time, the outcome will not be as good as it should be in the adjuvant setting.
Gargi, any difference of opinion?
Yeah, in this patient, I would go for
Go ahead with
adjuvant
immediate
RT.
adjuvant
Yeah.
RT. Okay.
Yeah.
Yeah, this patient had a number of high-risk factors which would RT, but coming to the case, this was what happened, and this is when 7 months later, patient.
There's the number of cases you're going to pick up extra pelvic with 0.36 PSA. I don't know if anyone can call it. I mean, less than 5%.
Since the patient is on follow-up, we have just watchful waiting ही चल रही है. So that's why I think PSMA PET.
But with a PSA of 0.36, what is your expectation? It will be local recurrence, yes. But the PSMA will.
But previously, when biopsy was report, you saw.
I got your point.
Actually, PSMA PET CT in this setting will going to help you out to decide whether the systemic treatment should also be added with this patient or not, because here we have not done an adequate pelvic lymph node dissection. So that will going to help us in two aspects, whether to include the pelvic lymph node field in the radiation also or not, and secondly to consider for the systemic therapy.
Exactly where I'm coming, because our article also talks about minor and major changes that PSMA PET CT has brought about. And PSMA PET, as Dr. Krishna, you mentioned that. So studies show that there is a 50% detection rate of some focus, although clinically in practice, I have not seen so many foci being picked up, and including this case. So PSMA PET CT was done, and it was absolutely normal for this patient. No PSMA avid local, regional or distant disease. I would request one of the radiation oncologists to take this question. Would you elaborate on the volumes?
Hello.
So we would. Sorry, sir.
Sorry. One comment. I don't know whether you recall 2003, Dr. Patrick Walsh had given his information on 3,000 radical prostatectomies. And he had clearly said that if the seminal vesicles are positive, you should treat the disease as a systemic disease rather than loco-regional disease. I do not know whether the concepts are still there. But that would solve all these problems, that this patient requires to be treated like a systemic disease rather than then the question about, node number of nodes, and they will have no meaning perhaps. A lot of people used to believe that lymph node dissection was only for staging and not a therapeutic benefit. However, we have progressed because the morbidity was low and everything, so making it believe that lymph node dissection is a therapeutic benefit. But these are the 2 points I want you to consider. Thank you. Yes, please. Yes, sir.
Jagdish, what you said about 2003 is right, but things have changed a lot. Seminal vesicle invasion is again divided into 4, type 1, 2, 3, and 4. That is number one. Second thing, it is not only some grade of the tumor, the stage of the tumor, and all those factors have to be combined together. Then you take a conscious decision whether you have to start the systemic therapy or not. But local radiation therapy, my answer is yes, it has to be given.
I think sir is right, because considering the impact of the morbidity of the systemic treatment in terms of hormonal treatment, and that too without any evidence on any imaging, I think it is not justified to start. But yes, it holds true today also that he is a candidate, but with some evidence in our hand.
Excuse me. We also have to look at the PSA doubling time. In this patient, it is changing in a week time from 0.28 to 0.36. The doubling time I calculated is 1 month. Likely to actually give him ADT and wait the time till you get to the point where you can add radiation to this patient.
Hello. You
So, yeah.
So that is what I'm saying. Before contemplating whether radiation can be added, there should be a statement that the patient is continent.
Yeah, so in most trials that have studied adjuvant radiotherapy, they've allowed radiotherapy to be given within 6 months of surgery. So I think most patients become continent well before that.
But that is what I'm saying. That is true. But in the previous session, that is what we were talking about. That there was data for that. But it is important to know that the patient is continent, and only then you give adjuvant radiation therapy.
But then even if we would, of course, continence will become worse after radiation if it is already incontinent.
Yes.
But that doesn't preclude you from omitting. Radiation has an impact on the cancer outcome, not just the quality of life.
That is why early salvage is to be contemplated, because such patients will they will perform equally well with either adjuvant or early salvage.
This is early salvage only.
No, this is 0.28. It is not early salvage.
So
it is salvage.
what you are mentioning, see, it is. No, what is
just 1 second.
No,
just
what,
1 second.
See, what he is saying is correct. The intention is adjuvant, but fortunately, what happened? Patient had PSA rise very early. That's why it turned out to be early.
I have not seen actually continence as such a big issue precluding us from giving radiation therapy. Patients talk of incontinence in the immediate period, but not when we see, in my experience, people can differ. And given that this patient is on incontinent, I add that point. Can I request one of the radiation oncologists to talk of the volumes, the dose, technique, and concurrent ADT? Dr. Abrol, you want to take first?
I'll include prostate, seminal vesicle, and lymph node volume into it, and go from 75 to 80 gray IgIMRT. And in concurrent ADT, we'll use leprolide along with abiraterone, since it looks to be a systemic disease to me.
So in your practice, in adjuvant setting, would you, or salvage adjuvant setting, you would go up to 80 gray?
75 gray.
75 gray. And you said give abiraterone with your ADT?
Yeah, in ADT.
Okay. Gargi, any difference of opinion?
Yeah, so we wouldn't go as high as 75 gray. It would likely be too toxic. So we would do around 64 to 66 gray. 64 gray is, I think, standard. And now in the radicals, they had even tried 52.5 gray in 20. So that is something we have recently started doing. And coming to the volumes, I would treat the prostate bed as well as the pelvic lymph node volume, preferably with IMRT. Coming to concurrent ADT, in sport, that did show benefit, but then there were a lot of fallacies with the sport trial also, that the patients who were recruited, they were not exactly salvaged. They had PSAs anywhere between 0.8 to 1, a significant number of them. So in some selected patients, I might avoid concurrent ADT.
Okay. So you would avoid concurrent ADT also in this?
Yeah, in certain patients. Probably not this one.
Because, of course, I agree with both of you over the volumes. We would treat the prostate bed along with the lymph nodes. And the dose, sir, I would agree with Gargi, because in adjuvant setting, there is a trial which compares high dose with 64 gray, and 64 gray has been the standard.
Moderated hypofractionation is nowadays used, which she is talking about.
No.
She's
talking about conventional fractionation.
Or if we do moderate, I would do 52.5, which was used in radicals.
But in which fractionation? 2.2, 2.7?
So 2.5, that would be.
But I think 2.2 and 2.7 is being used most commonly.
Yeah, but the total dose you are suggesting, sir, is quite high.
It may be variable.
It may be variable. I agree, completely agree.
Excuse
And,
me,
the technique.
what about the dose of the radiation to the lymph nodes? It will be the same what you give for prostate, or is it different?
Would the panelists take this?
Yeah, it would be lower to the pelvic lymph nodes considering the bowel toxicity. So normally when we use 64 gray to the bed, we give around 55 gray to the pelvic region, and when we are using 52.5, we give around 44 gray to the pelvic region.
Usually I go up to 46 gray to lymph nodes volume, including lymph node volume, and then boost the prostate and seminal vesicle up to 54 gray, and only prostate for the rest of the dose.
Beyond that. We are talking about post-op, yes. Yes, sir. Yes, sir.
ADT, in such a case, should be used for 4 to 6 months.
And she said no ADT.
She said in selective cases, I might
but in this
omit
particular
ADT.
case, she
In
would
this
not.
case,
So can you take me to the molecular level? How does it help,
Sir,
ADT?
medical oncologist can clear it, I think.
I think
No,
every urologist here writes more ADT than us, so let them answer it.
No, how does it help in radiation, ADT? Just take us to the molecular level.
yeah, so no, in
And
this
because
case,
I have seen radiation oncologists giving it for 3 months, some give for 6, some give for 2 years. So, I mean, there is so much of difference in opinion. I thought only surgeons may differ, but...
Sir, you're talking about post-op setting?
Yes, yes.
Post-op setting.
Yes.
so
There is no standard duration what has to be given. So
I think one of the experts did mention that based on the Stampede, one of the data set of Stampede, in the post-op settings, there are clear guidelines that you add 2 years of abiraterone, and the indications are any node-positive prostate cancer, any T3, T4 with one of the high-risk feature. One of the high-risk feature is PSA more than 20 or a Gleason grade group 8, 9, 10. These ones. In this, you have to give 2 years of abiraterone, and most of the guidelines, EUA was quoted by one.
Randeep, that is
definitive
not for
setting.
post-op.
In the
That is not
post-op,
a post-op.
Ajay, now we are talking about the
Post-op.
post-op.
We
Okay.
are
so
talking
it's
of is
better
giving.
trial.
So the question remains of sir is that on molecular level, how it helps?
No, it's a kind of a systemic disease. My understanding is the ADT is more for the systemic disease, not the local level. That's my understanding.
You see, again, just talk about the basics. I mean, one of the studies somebody presented, PSMA PET tells you where is the disease.
Yes.
Okay, so it has been my query, and I'm panelists would answer that. So one thing, like if you know the disease in the pelvis, why to irradiate prostate? You know, it's not about the incontinence. Even after radiation, patients have bladder neck contracture, which at times are very difficult to treat. I have patients after radiation, I have done BNI for 13 times. So we should think about these things when it comes to radiation. So why not only irradiate what
exactly
is
my point.
visible? That
Sir,
is one.
actually,
Another question.
yeah.
I mean, that
Okay.
could be interesting. The second is,
It's restricted within the pelvis, you would treat with adjuvant, but it's a trial. It's still not started. So these are just preliminary discussions, and risk holders are having these meets and meetings.
Yes, sir, exactly. So this is the hypothesis now. So many a times when they have done the PSMA PET, there are some studies which have showed the next question exactly is how often do you find a PSMA PET positive focus? And then many a times in studies almost to the extent of 40% it's outside our normal field. So the idea is slowly moving towards weight and then let the PSMA PET light up and treat because maybe we are over treating the bed and missing out on some points. That's the future I'm saying. I'm not saying this has come already, but some articles do discuss this. Presently, 100%. I completely agree. Just that the volumes will change based on PSMA PET. As of today, the practice remains. We observe the patient after radical prostatectomy. We do not give adjuvant radiation. We wait.
Pick up disease that may still be there.
But why would you treat only the external iliac? That's not the standard of care.
No, that is what I said. You were saying that we treat only what we see, and we did
No,
that.
we are
in
not
a-
advocating.
Do
No,
that in
no,
the present era. This cannot be done outside
Because
of a
any
clinical
microscopic
trial.
foci will be in the bed. From that only
But
it's coming.
In the
Yes.
in that case, there was no adverse pathological factor in the prostate itself.
But
It is
you're-
T2.
But now you are seeing a gross node, right? You are seeing a gross node now.
That would be an
We can't treat every
non-standard of
patient on
care, I would
anecdotes,
say.
Doctor Saab. So this is a one case, na?
It is okay, but discuss kare to I'm
No,
also
of course, it's good that you raise the point, but in a patient who has had a recurrence, PSA is 0.04, sorry, PSA is 0.4, you are seeing a focus on PSMA PET. We would treat, any radiation oncologist here would treat the prostate bed
also.
along with lymph nodes and probably giving a boost to that lymph node that you have picked up,
Very
right?
true. You have to do the whole pelvic nodal.
Okay,
There is
point-
no point skipping.
Point taken.
So we cannot skip the radiation there in the present standard of care. So this author, I think we've already covered. So the volumes might change based on radiation because of paucity of time. Just to the medical oncologist with us, Dr. Vamshi Krishna. So in Formula 509, patients had a PSA of greater than 0.1 post RP and one of the unfavorable risk factors, and they implied a benefit in subgroup of PSA in the subgroup with PSA greater than 0.5. Any thoughts on addition of abiraterone in the present setting?
I wouldn't add it. There's data from Stampede that addition of abiraterone and enzalutamide doesn't help. So enzalutamide plus abiraterone in the Stampede trial is showing no benefit over abiraterone alone. So number one, I would not do this. If you want to do it, add only abiraterone. Again, this study was not powered to design it. The study power itself, they said it should be 0.5 and they did not meet it. So again, I would not.
What type of patient you think would be suitable for? I'm assuming none of us here have experience with HIFU, and taking that just on the basis of the knowledge that this trial has generated, which patient would be well suited, and what are the major contraindications?
Only localized disease probably would consider, and screen detected patients, patients with very low PSAs.
So how do you say HIFU playing a role in prostate cancer treatment over the next 10 years? Anyone wants to take it? Dr. Mukul, if you have experience, do you want to take it? Role of HIFU in the next 10 years? She said it has gone down. That's what, but this trial, yeah. But what is the advantage of, I'm from a prototypical learning point of view, what is the advantage of HIFU when, we have non-invasive other methods available, if invasion is the point?
So that is one of the issues. The point is of focal treatment. The point is not treating the whole gland. So when you treat the focal part of the prostate only which has tumor, then the side effects are practically zero. So it's even less than radiation. So, so that way, that's why the patients are driving it, that they have absolutely zero side effects.
But the second HIFU rate is also high,
There is
right?
it's very minimal. If you see the long-term studies, the second HIFU rate is not that high. But of course, to do surgery and things after that, it becomes more and more difficult. So failure rates are pretty good at 5 to 10 years. We are looking now for 15, 20 years, and after that, only then we can compare with radiation and surgery. So it's still a long way to go for that.
I will beg to differ because majority of the lesion, they are in peripheral zone. They are close to the rectum. And in HIFU, the disease should be fairly away from the rectum. So rectal injury is the major concern when a patient considers.
But it is through a
That
probe
is with the older machines. The new machines, there is no rectal injury. Rectal urethral fistula is less than 0.1%, which is probably similar to radiation.
So we have recently bought the third generation HIFU machine at Rajiv Gandhi, and we have started doing HIFUs. So it is now indicated, as sir said, for focal cases, it has to be HIFU is primarily for peripheral zone only. When the lesion goes anteriorly, you go with cryo or irreversible electroporation. So for peripheral zone lesions that are occupying low volume disease 3+4, 3+3, high volume 3+3, you can target that quadrant of prostate, ablate it without damaging the nerves on the other side. So this patient will be continent, will have his normal erectile function. A second HIFU can still be done. If the patient fails after second HIFU, he is still a candidate for surgery as well as radiation therapy. So these patients do quite well from the data in the literature. they'll go, the second HIFU is normally needed after a median point of 6 years. Until that time, he's continent, his erectile function is good. We treat them around younger patients, 50, 55, then they are 60, 61. They don't mind getting radiation or surgery done and can still survive for long periods.
Because this
thank you
says
for...
Kaplan Meier of 7 years, 69. If it is a T1, we have 15-year data of 85 plus. So why
They are...
do this?
So that
And
was...
they are comparing radiation, we are treating whole gland. If you treat focal radiation, it will be less. But it's not yet proven.
So it is another non-invasive technique that is coming up, and the question from my end was that the same, that why, what is the...
It is invasive.
It is not non-invasive, sir. So going ahead, due to lack of time, just last 5 minutes, and we could later discuss amongst ourselves if required. So superior post-treatment biopsy outcomes with high-dose SBRT compared to high-dose conventionally fractionated IMRT. Just quickly from one of the radiation oncologists about practice of SBRT in your patients, and who is an ideal setup, and otherwise what do you do? And also the next question, just because we are running short of time. The multivariate analysis in this study showed concurrent ADT in both groups, which improved post-treatment biopsy rates. So do you in your practice, I'm aware TMH does SBRT considerably. So in your practice, do you use ADT? Because PACE-B, hypo-RT-PC, and the prospective study meta-analysis all had disallowed from use of ADT. So what's your experience?
Yeah, but the data for using ADT is much stronger so far what we have. So we do use ADT, what is used in the normal hypofractionation.
So how long do you use?
2 years for high risk and 6 months, 4 to 6 months for intermediate risk. So SBRT we do as a standard only in intermediate risk, and in high risk only under trial setting. So I would not feel comfortable omitting or shortening ADT in high-risk patients.
So you do use ADT in all your cases of SBRT?
Yes.
And you would agree, sir?
I don't use
SBRT, okay. So ADT, I thought, influenced the outcomes in this study significantly. And otherwise, in all your intermediate risk cases, you use SBRT?
Yes.
As a standard of care in all intermediate risk groups? Okay. Any radiation oncologist has any comment to make about the use of SBRT in all intermediate risk? Okay.
Actually, SBRT is a good proposition, but it should be done at a good center with higher clinical expertise and physics expertise.
I agree, and I think too that SBRT, I agree on that this is contradicting to what we have been doing commonly, although in intermediate risk we say neoadjuvant concurrent or concurrent adjuvant. Another thing Dr. Trinanjan has highlighted already, that these patients had high-risk cancers, and we are not talking about short-term ADT. In any high-risk patients, do you give short-term ADT? Because this trial talks of significant number of patients receiving short-term ADT with high risk.
Maybe patients with one risk factor for high risk, like a T3A disease or a marginally high PSA.
That is high risk, because the other one falls into
but
very high
then
risk.
we would consider for a short-term ADT, especially if the patient has multiple comorbidities.
Okay. That is one odd patient with multiple comorbidities, but otherwise any 24 months. So maybe this trial per se, I thought the major point was high-risk patients are included, which changes the scenario, and that was very well highlighted by Dr. Trinanjan, that they've not included whole pelvis, not included the pelvis in many patients, and given short-term in only high-risk also. So that kind of is the negative point here. What could be the possible mechanism? Somebody already raised this question. So, sir, ADT, why is it helping, and why do you think concurrent adjuvant is doing better than neoadjuvant concurrent? Any molecular?
I have no idea about this. Honestly, no idea.
So they talk of some extended continuation of RT.
Next session, session 3 for today. What is happening? Deepak Abrol and Dr. Asim Samar. Okay, Dr. Deepak Abrol, sir, are you here? Sir, have it. So I would like to ask Chairperson to invite the first speaker for the session. You're on it.
So we are moving towards our next session on prostate metastatic systemic therapy. And to present the first paper, I invite Dr. Milap Shah from Ahmedabad, and he will be speaking on feasibility and safety of radical prostatectomy for oligometastatic prostate cancer. Sir.
Thank you. Good afternoon, everyone. I'll be presenting the abstract on the TROM1 trial that is testing radical prostatectomy in men with prostate cancer and oligometastasis to the bone. So basically, the trial was started depending on the seed and soil hypothesis and the self-seeding phenomenon, which represents that if the receptive microenvironment is available, the malignant cells can proliferate well. So keeping this in mind, two trials conducted first the role of RT. The Stampede trial studied in a subgroup analysis the role of relative survival advantage of around 32% at 3 years. But when this was extrapolated on the high burden disease group, it did not show any benefit. The role of RT then further was studied by the HORAD trial, and it did not support or show any benefit even in the low risk metastatic group. So there was an urgent unmet need at the optimal recruitment strategies and to collect the quality of life and the early oncological safety and the functional outcome. It was a prospective randomized controlled feasibility trial. 50 patients was considered to be the ideal sample size because they found that an average of 1 to 2 patients were recruited every month in these centers, and over thinking that only 50% would be eligible and included in the group, this sample size was decided. It was a period of over 18 months after an initial 3-month setup period. Randomization was stratified on a 1-to-1 basis ratio. It was a non-blinded study, and only descriptive statistics were used to inform a future possible full trial. They used a particularly new aspect, that is a quantity recruitment intervention, where it was conducted in the 2 phases. I'll describe regarding it in the later part of my talk. The inclusion criteria were all the men with oligometastatic prostate cancer, that is 1 to 3 skeletal lesions that were diagnosed on bone imaging, no visceral mets, age less than 75 years, locally resectable tumors T1 to T3, good performance status 0 to 1 ECOG, and suitable for radical prostatectomy within 3 months of starting the SOC. The exclusion criteria included contraindications to radical prostatectomy, presence of visceral mets, prior radiation therapy, or current involvement in any other interventional research. The intervention arm comprised of the group undergoing robot-assisted radical prostatectomy and EPLND, and all the patients in both the group received the standard of care, that is ADT and docetaxel. Preoperative parameters, intraoperative parameters, and postoperative parameters were recorded until 6 months to it, and in the next phase, they found out that the randomization rate was higher, although the eligible patients were fewer than expected. The secondary outcomes were the quality of life assessment at baseline and 3 months, perioperative outcomes, the early oncological data, and the early functional data at 1, 3, and 6 months. They found that in the intervention arm as well, even after they underwent surgery in this particular setting, the functional and the oncological outcomes were similar to what the surgery was performed in the localized group as shown in other studies. The limitations were the heterogeneity and the lack of consistency in the imaging modalities, because few centers use the PSMA, few other cross-sectional imaging modalities. But however, due to this heterogeneity, it increases the study's generalizability and application of the results across all centers. The quality of life impact was measured by a generic tool, and the role of SBRT was not examined, but the authors are planning to examine it in the full trial. Whether this is a landmark trial or not is still to be decided because it was the world's first randomized clinical trial examining the feasibility of RP in the OMPC setting. It was not only feasible but also safe. The confidence of the surgeons operating this particular group has also increased, which will definitely have an impact in the future definitive trial. Thank you.
Thank you. Now I invite Dr. Anoop Toshniwal, Aurangabad, for talk on efficacy and safety of darolutamide in combination with ADT and docetaxel by disease volume and disease risk.
Thank you for giving this opportunity to talk about this trial. So the paper is the efficiency and safety of darolutamide in combination with ADT and docetaxel by disease volume and disease risk in recent study. This was a meeting abstract present in 2023 ASCO. The key objective here was to determine the efficiency and safety outcomes for maracins in patients with metastatic hormone-sensitive prostate cancer by disease volume and disease risk to determine if a specific subgroup of the patient could achieve greater benefit from combination of ADT, docetaxel compared to ADT and docetaxel only. So it was a sponsored trial by Bayer and Orion Pharma, and the paper I am trying to discuss here is a post-hoc analysis of the ARISIN study. So just revising the ARISIN study design. So what it was a global randomized double-blind placebo-controlled phase 3 randomized control trial where patient metastatic HBC were enrolled who were candidates for ADT and docetaxel, and with performance status 0 and 1, 1306 patients were randomized. Certification was done on extent of disease, whether M1A, M1B, M1C, and depending upon alkaline phosphatase level, that Daro plus ADT and docetaxel significantly reduced the risk of death by 32.5% versus placebo plus ADT plus docetaxel in this metastatic hormone-sensitive patient. And the treatment emergent adverse event in both the groups were same. So in this trial, pre-specified subgroup analysis was done, and whether the disease was de novo or on the recurrent setting, the OS benefit was maintained. In here, what they try to do is, depending upon the high risk or high volume or low risk or low volume, they did a post-hoc analysis to see whether the OS difference is maintained in this 4 group or not. High risk disease, 23% had low volume and 30% had low risk disease. So, in high volume metastatic HSPC or in low volume metastatic HSPC, darolutamide, ADT plus docetaxel prolong OS regardless of the volume status, and the HR for there was 0.69 and 0.68 respectively. Even if the disease was stratified.
See, there is data in the second line of using the PARP inhibitors. So that data was for the second line. So logical conclusion to anything when medical oncologists find something working is we try to push it further and further. Already the data has come now in the first line, and now I'm sure in the future there are trials in the HSPC. We are going to push it even further if possible. Right, so there are 3 trials in the first line combination that run for a lot of patients. So this was stratified, whether this was you given or not. HRR gene status, deficient versus proficient. Now, interestingly, they did try and prospectively assess the patients for these mutations. Then, the gene mutations they have used. Again, I spoke to you about the 14, 15, whatever number people check. They looked at BRCA1, BRCA2, PALB2, ATM, ATR, CHEK2, and other 3, 4. Does a PARP inhibitor work in all of them? Other than BRCA1, BRCA2, possibly ATM, the data is unclear. So then they used talazoparib with enzalutamide, placebo with enzalutamide. Primary endpoint, radiological PFS. Again, we are not looking at a biochemical, we are looking at a radiological PFS. How many of us would continue doing a scan in a CRPC? Most of us wouldn't, but still this trial looked at that radiological PFS with a key secondary endpoint of overall survival. So these were the baseline characteristics. Now I've highlighted the ones which are very important, that is prior abiraterone or docetaxel usage was in 27% of patients. 73% did not use it. 27% of which 5 were abiraterone, 21 were docetaxel. In HSPC, at least anecdotally, I think in India most patients do go on to abiraterone rather than docetaxel, but their study more were on docetaxel. What about HRR gene status? HRR deficiency was seen only in 21% of patients. All the remaining were either non-deficient or unknown. Again, important, enzalutamide arm was not reported versus 22 months in the placebo arm. So CRPC first-line enzalutamide 22 months is quite good. I mean, it's actually more than what the original trial would have reported. 22 months there, the hazard ratio 0.763. So we need to keep an eye on these HRRs. The hazard ratio is 0.63, median RFS. Look at the HRR status. So HRR deficient, it's 0.46. HRR non-deficient is 0.66 or unknown 0.7. So this is the number we need to remember. 0.63 is a headline number. The one which really benefits is this 0.46. So if you have a HRR deficient, that is where I would like to use my PARP inhibitor. But remember, the trial has not included a third arm of only a PARP inhibitor. So does PARP enzalutamide, is enzalutamide adding anything to talazoparib in survival? Now, very interesting. I was not able to explain this. When you look at the median RFS, it is not reported for the entire group, but the median OS has been reported. I really want to look at the events and number of events to understand this. They had enough median overall, not have enough events to give you a median PFS. I am not sure how that works. I really need to look into the final paper when it's published, but be as it may, when you look at the overall survival, 36 for the talazo, not reported for the other arm, yet the hazard ratio is 0.89 in favor of talazoparib. Crossing the unity, p-value all over the place. So overall survival not met. Following the trend of almost all PARP inhibitors in prostate, overall survival benefit is not seen even with the talazoparib. So that is something we need to remember. Right. Now what about other efficacy outcomes? You have response rate, the CR rate is 37%, which is rather astounding when you look at the combination. But again, if that CR is not translating into an overall survival, and an RPFS which is just there, I'm not sure what significance it has. Serious adverse events, again, I'm not looking at everything because in a trial you get much higher adverse event related, but treatment related serious adverse events of 20%, it's not something we can ignore, especially when you're combining two drugs together. So again, looking at the major side effects, anemia, thrombocytopenia, and fatigue. So their conclusion was that this significantly improves the RPFS as compared to this, and a clinically meaningful RPFS improvement in all benefit with and without HRR gene mutation. So I'm saying it's their interpretation. Personally, I'm still okay to use this in a group which is got HRR deficiency. If it's HRR proficient, 0.7 HR with no OS advantage. In fact, a slightly lower OS, I am not sure this is the right drug for this combination. So I think we are given 15 minutes. I think your stopping clock in 10 minutes. It's 15 minutes. Yeah. So the investigators concluded that the trial supported the use of talazo and enzalutamide. I would personally not really agree with this. Again, the reason why, when you have another trial, the PROPEL analysis. Now, PROPEL looked at abiraterone and olaparib versus abiraterone and placebo. Again, remember, if you want to target something with a PARP inhibitor, it's the BRCA that you should target. Anything non-BRCA, the results are really not favoring you in any way. Whether you combine an NSA with it, you give it however you want, somehow the benefit seems to be driven by this BRCA mutant subset. What about the overall survival? And again, like Talapro had an initial overall survival which was not met with a hazard ratio of 0.85. Here it's 0.91, touching the unity of 1 and the p-value of 0.0544, which is beyond the boundary. It's only 48% maturity. Yes, you can look at this graph and hope that that trial, that the curves keep separating, but honestly, I am not very convinced with this data that it is actually going to give you an overall survival advantage. Results with OS across subgroups, again, looking at the hazard ratio, the HRR mutant group, 0.68, HRR non-mutant, again, 0.89, non-significant. BRCA mutant, 0.29, non-BRCA, not of any use. Yes, you have secondary endpoints, TFS3, PFS2, all showing 0.76, 0.78, all these numbers are there on the paper, but again, for me, the headline numbers are what matter, and those headline numbers simply don't match up to me. Looking at the AEs, death due to AE is around 6 and 5, so similar. Dose interruptions and discontinuations are higher in the olaparib, it's 17% and 19% in the previous arm. Most common AEs, as expected, anemia, fatigue, and thrombocytopenia. Quality of life, surprisingly, like all medical oncology trials, quality of life never matters even if you keep pumping them with extra drugs. The HR quality of life is always similar. Take it with whatever you want. So again, the conclusions of the author that the PROPEL met its primary endpoint, demonstrating a significant and clinically meaningful RPFS benefit. Median benefit is around 7 months overall. The OS is only a trend which was sustained but not significant. The combination is better by around 7 months. It is only in the BRCA mutant subgroup. Other HRR, not so much. Only RPFS benefit, OS benefit is very, very questionable. Second, third line, I'm okay to give a monotherapy with either olaparib or rucaparib, but that again is in BRCA 1 and 2. In ATM, well, I could make a case for it. Any other combination, any other usage is...
Thank the organizers for inviting me. So I'm asked to review this abstract, which is the Key Link 010 study, which is pembrolizumab plus olaparib versus abiraterone or enzalutamide for patients with previously treated metastatic CRPC, a randomized open-label phase 3 study. This was presented last year in the ESMO Congress at Paris. So, to introduce, we all know the different standard of care options in metastatic CRPC. However, in certain molecularly selected subgroups, after few lines of treatment, we have the PARP inhibitors and the immunotherapy coming in. 1% of patients, we may have MSI high or TMB greater than 10, where pembrolizumab can really work well. And HRR mutations are patients which will be around 20 to 25% of patients, where PARP inhibitors and possibly a platinum may 8 or more than 8 in 69, but they did not have much information as to what was the visceral metastasis status, what was the PSA, and what was the response to ADT, what was the time post ADT progression in these CRPC patients. HRR status, so again around 25% patients were HRR mutated in both arms, 26% in pembrolizumab plus olaparib arm, whereas this was also somewhat met in the HRR mutated subgroup with a hazard of 0.69. So just as what Dr. Vamshi was saying, that BRCA mutated, you had a very good advantage, but in the HRR mutated, you had some advantage. But this was a very small subgroup analysis, probably, which is applicable to only 25% or 10% patients. In the PDL1 positive or negative, there was absolutely no difference in the outcome. If you look at the overall survival, again, there was no difference in the overall survival, 15.8 months versus 14.6 months in both the arms. And here too, what we see that the BRCA mutated subgroup, the overall survival was better with a hazard of 0.52. And the only other subgroup which had better overall survival was North American patients, probably because they have better access to other treatment options. Again, PDL1 positive or negative, there is no difference. And HRR mutated, again, just as Dr. Vamshi was saying, the advantage, OS advantage had gone. So the PFS advantage was there, but the OS advantage was not there in the HRR mutated subgroup. If you look at the other secondary endpoints, time to first subsequent therapy, this was also not met. It was almost equal. And when we look at the subsequent treatments that the patients had received, 48% of patients, around 45% of patients did not receive any subsequent therapy. And olaparib or PARP inhibitors, which are important treatment options in BRCA mutated 10% patients or HRR mutated patients, which are 20-25%. Here also we see that this treatment was not given to the opposite arm, that is the control arm. If you look at the response rates, so yes, response rates pembrolizumab or olaparib based combinations. What is my critical analysis is that I would compare this study with the PROFOUND study. And what I see that the trial design was very similar to PROFOUND except the patient selection. This was an absolutely molecularly unselected population which was included here, and there was no information on the MSI and TMB status. Also, key prognostic factors were not included. Patients were well treated. They were 99% were exposed to docetaxel, whereas in the PROFOUND study, almost 65% were exposed to docetaxel. Post-progression treatment was inadequate, just as I said, and there was no PARP inhibitor in the control group. 25% would be having a HRR mutation even in the control group, but yet there was no OS benefit in the treatment arm, whereas there was a significant benefit in PROFOUND study in both cohort A and cohort A plus B, if we remember. Subset analysis did confirm that the similar benefit of treatment was there, which was driven by the HRR positive and BRCA mutation subgroup, just like in the PROFOUND study, and toxicities look similar. So Monday morning practice, my key takeaways would be metastatic prostate cancer, send germline mutation for all, and NGS or somatic mutation panel, including TMB, MSI, HRR in the affording patients. Pembrolizumab plus olaparib, it is costly, it is potentially toxic, and we cannot use this in an unselected population in today's era of precision medicine. PDL1 is not a good biomarker for immunotherapy in prostate cancer. There is no use of doing PDL1. And we must try to expose our patients to multiple treatment lines, including cabazitaxel and radiopharmaceuticals for best outcome. Thank you for patient listening.
Thanks, Dr. Vivek. Now I invite Dr. Nandini Menon from Mumbai, and she will be presenting abstract on early results from a phase 1 multicenter trial of PSCA specific GO-CAR T cell in patient with MCRPC.
Good afternoon, everyone, and thank you for giving me this opportunity. So the abstract that is allotted to me is the early results from a phase 1 multicenter trial, which looked at PSCA specific CAR T cells and metastatic castration resistant prostate cancer. This was a multi-center trial from various centers in the US and was presented as a poster in this year's ASCO GU conference. So just a little background, basically CAR T cells, like we all know, are T cells from a patient which are isolated and genetically engineered to express a protein that targets antigen on the tumor cell. And then these T cells further have properties of expanding within the body and then circulate and attack all the tumor cells and lead to an immune response and lead to a control in the disease. So various antigens have been looked at for target. As a target in prostate cancer, they looked at PSCA, which is a prostate stem cell antigen. And to improve the function of these CAR T cells, they are engineered to have certain co-stimulatory molecules which enhance the T cell proliferation and allow the CAR T cells to expand within the patient's body. So this study included the administration of this drug called Remeducid, which was supposed to trigger, it was a switch to these T cells to enhance their potency and keep them persistent in the circulation. And this was a phase 1, phase 2 study which was looking at this particular CAR T cell in prostate and pancreatic cancers. So we focus on the phase 1 dose, and this was a cell dose escalation study to look at the maximum tolerated dose. The phase 2 is not yet started. So they included metastatic CRPC patients who had failed 2 prior lines of therapy, including an androgen receptor antagonist and a taxane. And they excluded, of course, patients with unstable bone lesions, coagulopathies, cardiac dysfunction, or active or symptomatic CNS mets. The primary objective of this phase 1 study was, of course, safety and tolerability, that is to identify the MTD and dose-limiting toxicities, and to get a dose for the phase 2 part of the study, that is the recommended phase 2 dose. And they also looked at characterization of clinical efficacy, pharmacokinetics of Remeducid in the as part of the secondary objectives, including biomarkers, which looked at T cell expansion within the body. So what they actually did was they gave lymphodepleting chemotherapy, prepared the T cells, CAR T cells, and then these CAR T cells were given at the dose of 5 × 10⁶ cells per kg of the patient's body weight. In addition to these CAR T cells, 1 week after the CAR T cell infusion, Remeducid was given at the dose of 0.4 milligram per kg. Here there was a dose escalation. Patients either received single dose of Remeducid or they went on to receive up to 30 doses of Remeducid in the 3+3 study design. So 8 patients' data has been reported. These were patients that were recruited up to September 2022. All 8 received the CAR T cell dose. 3 patients received, in addition, a single dose of Remeducid, and the remaining 5 received multi-doses, which ranged from 1 to 30. So since this was a phase 1 study and looked at safety as the primary endpoint, These were the major toxicities that were noted. So the most common toxicities that are expected are myelosuppressive events because of the lymphodepletive therapy before you give the CAR T cells. But in addition, there are certain toxicities of CAR T cells that are of importance, like the cytokine release syndrome, which is a known toxicity of CAR T cells and was also seen in all patients here. Most of them were grade 1. Only 2 patients had grade 3. Immune-related neurotoxicity syndrome, also a known toxicity of CAR T cells. Only 2 patients had it, one grade 1, one grade 4, but both resolved. And there was one death because of neutropenic sepsis, which was considered a dose-limiting toxicity. So this was the secondary endpoints looking at the activity of the cells. So they had a PSA 50% response at day 28, that is a decline of PSA to 50% of the levels in 3 patients out of 7. And these are the data available till now on the RECIST responses of these patients. So 1 out of 8 had a partial response and of stable disease for more than 9 months. 1 progressed and 2 patients had not yet reached the imaging time point in the trial. And as they looked at biomarkers and the activity of the T cells within the patients and how they expanded, these were the T cell expansion that happened. So these were the copy numbers of the T cell in the first week. And when they administered multiple doses of remidesivir, which stimulated the T cells further, these were the re-expansion copy numbers. So the authors concluded that this product, that is the T cell product that they have designed, targeting PSCA, had good evidence of biological activity and known toxicity like other T cells previously reported. Also, they said that remidesivir, which they are administering as part of the trial, induced activation and proliferation, and they were planning to escalate further to increasing the dose of remidesivir to more than 0.4 milligram per kg, and also escalating the CAR T doses. But there's an update. This study now is, although ongoing, has stopped recruiting patients further because of the dose-limiting toxicity. It is not very clear whether it is the same death due to FN that was the dose-limiting toxicity due to which the study has been, the recruitment.
Thanks, Dr. Nandini. Now I invite Dr. Deepak from Indore, and he will be speaking on ANZUP 1603 trial.
Good afternoon. So the study is therapy trial. It is a lutetium PSMA therapy versus cabazitaxel in metastatic CRPC patients who have progressed after docetaxel. This is the overall survival result after 3 years of follow-up. So this was an open-label phase 2 multicentric randomized control trial, and patients who are metastatic CRPC patients who have progressed on docetaxel, rising PSA or a PSA level of more than 20 Ng per ml, and all patients underwent PET imaging and a PSMA PET. PS0 to 2 patients were taken, and patients with FDG positive but PSMA negative, they were excluded. More than 50% objective response rate. These all were higher with lutetium overall survival as compared to cabazitaxel. There is another study, which is phase 3 study, which was published in NEJM last year, Vision trial, that included patients. That was a comparison between lutetium PSMA versus the available standard of care. So there was no available standard of care at that time. The available standard of care was either bisphosphonates, denosumab, steroids, palliative care. So that study has shown a survival difference of about 4 months, 11 months versus 15 months. And that study included higher number of patients, about 800 patients. So these 2 studies, they conclude that lutetium PSMA therapy as a third-line treatment is a valid option. Thank you.
Thank you, sir. Now I invite for last abstract presentation, Dr. Mukul Rai from Mumbai, and she will be presenting a talk on phase 2 double-blinded placebo-controlled trial of prostate in oligometastatic prostate cancer.
Good afternoon, everyone. Thank you, organizing committee, for giving me the opportunity to speak. So I have been presented with this abstract, NRG GU011. It is a phase 2 double-blinded placebo-controlled trial of prostate oligometastatic radiotherapy with or without androgen deprivation. It was presented in ASCO GU 2023 this year. So a little bit on the background. There is no clear standard of care for biochemically recurrent prostate CA with PET detected oligometastasis but normal on conventional imaging. Phase 2 trials show that SABR, stereotactic ablative body radiotherapy to the oligomets may delay cancer progression and initiation of ADT. So ADT plus RT prolongs survival in locally advanced prostate CA and in conventional imaging metastatic prostate CA. However, there is a knowledge gap about the time and the benefit versus toxicity of ADT with SBRT in early OMPCs. So I searched on the NCCN guidelines and I found there is no clear-cut guidelines in the NCCN for the oligometastatic prostate CA detected on the PET but normal on conventional imaging. Though there's a point that ADT for metastatic castration-sensitive diseases, they say that ADT with treatment intensification is preferred for most patients with metastatic prostate CA. So this study aims to evaluate the impact of relugolix when combined with SABR in oligometastasis. So mechanism of action of relugolix is that it allows for rapid testosterone recovery and it has lesser cardiovascular events, that is 54% less compared to leuprolide, and therefore it is hypothesized to have low late ADT toxicities. So a little bit on the theoretical benefits of radiation cancer, similar to therapies like with degarelix, but degarelix requires a subcutaneous administration. Hence, it is less burdensome therapeutic option for patients who otherwise may need repeated clinical visits. It has been used exclusively for symptom palliation. And this is a summary of all the trials which have studied metastasis-directed therapy in hormone-sensitive prostate cancer, out of which the Oriole and the STOMP trial are the landmark trials in this category. The conclusion of this paper was that role of RT in systemic prostate cancer has historically been limited and palliative in nature, but the recent studies show a value of radiation, especially metastasis-directed SABR in patients with limited metastasis. And this effect is noted in both hormone-sensitive as well as hormone-refractory prostate cancer, along with a significant improvement in biochemical and radiological progression-free survival. So thank you for your kind attention, and thank you to our patients who are our greatest teachers. Thank you.
Thanks, Dr. Mukul. Now we come to close to the abstract presentation in the session on systemic therapy.
Get me wrong, I do agree. CT scan wise picking up metastatic disease and PET scan wise picking up metastatic disease, they may have a different biological behavior. But this is a good example to convince our ethics committee to allow these kind of studies. Think about stage 4 and you say, hey, I'm not going to give you ADT. That was the design. Only give RT and RT plus, it was RT plus ADT. ADT and ADT for 6 months. Impressive. Not giving ADT beyond 6 months, and we debate here when to stop it. And I think, urologists, we keep debating, once you start ADT, either you orchidectomy or still CRPC, it continues. We never stop it. So that was a very good design, to have it, because we debate that we need to stop it early, not necessarily we'll need for 5 years, 7 years, which we keep giving. So interesting design. How to implement will be a challenge. How someone will take this project further, that will be a challenge. I didn't see that where it was done, which place. And the drug is very good. Oral, we are all looking for. I wish we get oral. So, but I think so. Orchidectomy remains, I think so, easiest, and most of our patients they do that, take that. Coming to a presentation for cabazitaxel versus lutein PSMA, I think so. PSMA lutein therapy is going to come. It's going to keep creeping. We have seen now 2 data, looks promising, looks that it will come in some form and some combination. Only it's bit more toxic than what we have thought about, and same is in that clinic, that trial, the previous trial which was there. But response was impressive, 40%. That was the response in the previous study. So looks here, they interpreted a non-inferior, number was too small to interpret that, but curve looks good. And if something is as good as cabazitaxel with the similar curve, and you give once in 6 weeks, well, no, most likely we'll choose that. Looks so, lutetium PSMA will keep creeping in. That's the way we look for. Phase 1 CAR T cell, we sincerely hope. We are struggling with CAR T cell in solid tumor. Doesn't look like, we have some leads somewhere we keep seeing, but not those leukemia responses. We have not seen those leukemia responses that going into CR, except once in a while we have heard that. Pembrolizumab and olaparib, again here looks like olaparib is in. We'll keep debating where we are going to use. HRR, BRCA1, all, combination. Immunotherapy is struggling. Again, we are not able to see in prostate cancer, immunotherapy really showing something, replace disease, and can we treat like that? Thankfully, sanity prevailed and we say, no, give systemic therapy right now, wait for 6 months and then, we'll see it again. But majority of the site, it will keep coming because we have seen with this PET based diagnosis of metastatic disease that those biologies are different. These patients, they will have metastatic disease, but a group of them keep doing very well. And that is where we want that they shouldn't grow. So we will have those struggles, that how we are going to treat them. Lung cancer, not lung cancer, 2 randomized trial in oligometastatic disease with local treatment with radiotherapy. Positive, they had to stop it because it was so good. Third one in lung cancer, it was so good. But the problem is that they're competing with the systemic therapy. So in lung cancer, by the time the trial happens with gefitinib or osimertinib is there. So again, going back, so lung trial again was stopped because of the PFS was so good with adding the local treatment. So DSMC, data monitoring committee didn't allow them to continue that study. It is doubling of the PFS.
And one more minute. Now that balances. One surgeon is enough for all. Yeah. So there are 30 minutes, 8 abstracts. I am going to be very crisp. I am not going to show all those curves because most of the speakers have eluded the data. And what you have done, the organizers, you have already given the expert comment. So we know the answer, right? We know the answer. Dr. Kumar Prabhash has done a fantastic job. So we are going to discuss what we actually do in our clinics. So we'll start with the case quickly. This young male, 58-year-old, with a family history of cancers, with well-controlled comorbidities, presented with no urinary symptoms, and the PSA was 11, biopsy was Gleason's 4+3, group grade 3, and the lesion was a little bit touching in the capsule, extraprostatic extension. So what all the investigations when such patients comes to you? Because we have been practicing for more than, say, 4 decades, where the investigations have been improving. And those cases which have been labeled as a locally advanced, now if you add a PSMA, suddenly you upgrade those patients. But those patients who have been operated years back come for follow-up, then we really have to ask ourselves whether we are over treating them by over investigating them. So what are the investigations you judiciously use for the patients in prostate cancer?
So in this patient, I would like to jump directly for the gallium PSMA PET scan instead of doing conventional. Apart from the, when I do PSMA, I do DRE, and if it's because in my mind, I may treat him surgically. If it is resectable, then PSMA PET will answer my all staging purpose. The purpose will be served. Or else bone scan with MRI with the CT.
Okay.
MP MRI and the CT, or MRI pelvis, that will tell us the lymph nodes.
Okay. Kulkarni sir, so why I mentioned 4 decades, because in the span, we have senior surgeons sitting in the, at least there.
Well, thank you, Bharat. I agreed that we started in 77 and now 46 years. Of course, that time we had only bone scan. We didn't have anything. Then came in other scans which are F18 and other things. In between, we have been believing in whole body MRI was another good way for bone metastasis. Having said that, PSMA has revolutionized completely, even in Europe for that matter. That non-metastatic CRPC is going down because they were all actually metastatic CRPC, if you recollect that. So I think PSMA scan is very much, although of course the cost is a little issue, but I think in the long run, 25,000 or 20,000 is really not much. So I think we shouldn't make the cost as an issue rather than, the only thing which we're talking about a PSMA PET scan is today even to diagnose the primary disease.
No, but
that's going to come up. That's going to come up. But I think PSMA is the right way.
So you agree that PSMA. So Dr. Kumar Prakash has rightly mentioned it's a systemic disease. You can't do without the systemic therapies. So that is why PSMA is very, very important. Now burden of disease we discuss as per we'll come to that criteria because there are only 30 minutes and otherwise it will go on surgery only. I have to talk about CAR-T. So this was the PSMA scan, no? Don't ask me too many questions. We have to finish it.
It's very
so
clear.
to the surgeon, would you like to operate this case? Only one lesion. That is because on the PSMA
first
scan.
paper which was discussed, surgery in the oligometastasis. My take on the surgery, if it is a T2 disease in the PSMA scan, I don't know what is the report exactly and what is the examination. Solitary mets, and what about the primary disease? But in the examination, if I am okay with the plane,
it is operable. Primary is operable.
or the planes with the rectum are okay, I am not very much concerned of the neurovascular bundle involvement, and the disease is not going into the bladder.
Including the systemic therapy person, even the radio imaging persons can discuss about these scans. One odd cases, sometimes we end up in saying non-metastatic disease. Those scan must be discussed in detail whenever you see some, when you don't expect to have metastasis and you see something, the scan needs to be discussed.
Primary should be treated if we are not harming in the sense of no rectal injury, no incontinence for a long time, maybe patient.
Point.
So we should go for that.
This is a very important point. If we are not harming, then this modality needs to be discussed. Now surgery versus RT. So this abstract is actually for another purpose. So there are phase 3 trials where the RT in oligometastatic setting has been discussed, Stampede and one more trial, where it has actually shown benefits. So when we have a radiation modality of treatment in this setting, whether we should prefer surgery or radiation to the radiation oncologist. First you and then Dr. Parneet can.
Thank you. I would like to ask the surgeon, you didn't ask for an MRI. You said you are not going to harm rectum, so I'll operate.
Yeah.
But if you have extra prostatic extension, the margin comes positive, again you'll send it to me. That's
no worries.
Again, after that, if small met is there, again you will send it back to me. So why operate?
Based on why I am discussing, there are patients, anecdotally, we have been seeing those who are surviving.
What do you want from me? You tell me.
So how would you treat? Whether you treat with systemic therapy first, upfront radiation, or you?
Of course, I will do. It is a favorable intermediate.
So this is the oligometastasis, single lesion, high risk disease.
One lesion. One lesion, he showed
extra prostatic extension.
So the question is, would you like to add something upfront, or you would straight with the RT?
It is metastatic. I would like to use ADT.
Perfect.
Okay? At least 1 year.
1 year.
Yeah. And I would do radical radiation therapy.
Okay. Anybody wants to differ? Vivek, and then.
So I think the debate is coming nowadays because we are just extrapolating our facts.
Ajay?
Yes, sir. I also agree with the Vivek, sir.
So basically,
response duration will be around 3 to 6 months.
Yes. So basically, everybody wants to start with the systemic therapy, that is ADT, and then wants to see the response whenever up to 1 year, maybe 6 months, 1 year. I'm coming to that.
Oh, what response?
Okay. What response? Vivek, you started. What response? Biochemical, radiological, because Vamshi clearly mentioned most of the time we end up in following with the biochemical.
I just want to ask my radiation oncologist why he is waiting for 1 year. What response?
No, I will give.
So you said you want to wait for 1 year. I want to ask, so why are you waiting for 1 year? For what?
No, he's mistaken me. I am not saying wait for 1 year. I said treat locally. If you want to give as a neoadjuvant, then
So-
it's okay.
Correct, sir. So we can go after 3 months also, we can go after 6
So
months
Vivek,
also.
what
Dr.
response
Vamshi mentioned in his center, they are starting after 2 weeks only of AD.
Vivek, so you are saying 3 months also we can be treated. So everybody agrees that at the 3 months also we can treat if the depth of response. So main idea here is that we can't do without ADT, and that is what the next abstract is, where no, in oligometastatic setting they tried the feasibility of not giving ADT. I think we are not there to avoid ADT. It's good thing that we have an oral agent where they tried for 6 months. Something which we have tried in the past is intermittent ADT, where you can, but again, compliance of the patient is very, very important. Patient has to come.
Those
So you
data
don't-
only for recurrence.
Oh, yeah. So what
Sir,
I'm
what-
saying is
what
that
actually-
has been tried before. 6 months in a metastatic setting is not acceptable thing. One has to be on the ADT in a metastatic setting.
For upfront, we don't have.
No, for this.
Sir, actually what time gives us is a test of time to test the biology of the disease as well as the metastatic site to see whether it is actually an aggressive disease which is progressing or not. And 5 to 10% of patients we are going to get such kind of an aggressive disease.
Vivek, I differ with the other Vivek that it will not progress on ADT. This is small disease, we've never seen progression upfront.
So-
Castration sensitive.
So that is where our surgeons also say these patients are going to live for 10, 15 years. Some of them. We don't know the biomarker, and that is why not to operate. So we'll not go into that debate. So that is why they provide that modality also. But we don't have a level 1 evidence. I don't know. I have to say the surgery in oligometastatic setting. So you have asked the question to him, but I am not answering. Biology of the disease, we yet not there to know what is biomarker. What biomarker can tell us that this patient is going to live longer. And surprisingly, we have patients who have been operated in the past and they do well. The modality was not there to detect them in the, maybe they were the oligometastatic disease. But yes, I'm not here to support the surgery. Main thing is, this is a disease where discussion of all the modalities together is very, very important, including the patient knowing the pros and cons of the modalities. So we'll not go into details of this. So there is no, I have already discussed this. These are the trials. So in metastatic setting, the space is getting crowded. With the French group IGR data of 3 modalities, chemo, abiraterone, steroids, and now you also have questions, okay. For the surgeon,
For the medical oncology.
for the medical oncologist.
You said you will give novel hormone agent, I agree with it, but will it be treated indefinitely or you would like to restrict ABI at 2 years for this patient? Only one bone met and prostate primary. So that's purely an oligo.
Yeah,
So the second abstract,
So
maybe that oral.
looking at
GR.
oligometastatic curative setting, I think 3 years
Let me
time.
complete the question. ADT indefinite, I mean the GnRH analog.
I think, sir, because it is the oligometastatic disease and if we have given definitive RT,
Yes, we have
and
given
if everything is
definitive
in control, then I would want to stop at 2 to 3 years.
Both ADT and ABI at 2 years.
Yeah, I would not want to use abiraterone. I would use rather an enzalutamide or an apalutamide or a darolutamide.
Enza or AB, whatever.
Yeah.
And any novel hormone therapy plus ADT at 2 years. You agree?
Yes, sir.
So this trial where they looked at placebo versus 6 months of GnRH oral antagonist. And after 6 months, we maybe getting the data. So he said 3 years. There is no data for 3 years also for oligometastatic. Once metastatic is always metastatic. But yes, on a individual case basis, you can discuss based on the toxicities of ADTs.
I think you can extrapolate from the high risk prostate. What they are doing is ADT plus
Exactly.
ABI for
So
2 years.
extrapolation from high risk,
High risk non-metastatic prostate.
non-metastatic. I think in our clinic, as the debate goes for surgery also, we do take the decision based on the patient's tolerance to these therapies. And if the patient is doing good, we really fear to stop that particular therapy because nobody wants to jump to again from a controlled disease to a metastatic setting. But yes, as he said, you can take a decision, individual decision. So as this space is getting crowded. We have chemotherapy, newer androgen steroid now.
I think, yes. So we did not add ADT to any patient. We said that we are giving RT for oligometastatic disease because we want to delay initiation of ADT. And only when...
have one in Mars.
No, British Columbia group is a big group. We don't read that. See, they have done, I will treat this as high risk disease, and then they've stopped at 1 year. And when it recurs, they have used intermittent ADT,
I agree
and
with
they
you.
have done well.
That I agree with you. So
that
my
is why
apology
I
for
said-
that comment.
That is
I
why
agree.
I said 1 year is good enough. When it recurs, we will again restart.
Okay, so basically as sir rightly said, so again we are not discussing the circulating tumor DNA mutations to stratify this thing. So when that debate will come, so we'll stick to the next abstract. So Daro plus ADT and chemotherapy together. So 4-5 years back, the IGR group.
Patient factor is also important. How is the patient young and what is the comorbidity? If patient is elderly having a comorbidity, then I will not prefer using a triplet regimen.
So this is very important point, as you mentioned, the comorbidities and patient factors. And we have recently started the geriatric clinic. And this is a disease largely of a geriatric age group. The assessment is very, very important. You have, why the assessment is important? It is not for the overall survival of PFS, it is to reduce the toxicity. I'm talking about a lot of toxicities of ADT. You are trying to add the newer anti-androgens, which is the most important factor.
Comment which have cognitive functions.
Yes, very important.
That's the most important thing
Yes.
today. I think we have which have cognitive functions.
Yes, very important.
That's the most important thing
Yes.
today. I think we have never looked at that. And this is the time for us to look into that.
Yeah, so not as a geriatric assessment, we have been doing at a spinal level assessing the patients, but now the cognitive function is a part of the ultimate survival. A 60-year-old male with no comorbidities operated by robotic surgery, followed by 2 years of adjuvant ADT, followed regularly for 3 years, post-ADT, slow rising PSAs. So in the clinic, we get patients with very slow rising PSA where actually, a few of, this is again anecdotal, we have followed them and nothing we have added and they have done actually well. And that is why all these questions come. So for a slow rising biochemical failure, what are the investigations? Maybe no surgeon can add over here. Only you answer. For all comers. So quickly, I'll short it. In the trial, they have come down to the benefit to only BRCA patients. This is another trial, Propel trial, and 2 days back, the FDA granted permission to this combination, and this combination is abiraterone and olaparib, and talazo is talazoparib with enzalutamide. So there was no overall survival benefit in statistically significant, but yes, based on the PFS and OS benefit in BRCA1, BRCA2, not in all HRR mutation. Forget about those BRCA1
patient.
So will you use upfront or will keep the PARP inhibitor in sequence?
What I believe is, sir, is that the PARP inhibitors, we need to bring them early on into the management in the selected subgroups of BRCA1 and BRCA2, whether it is breast cancer, whether it is ovarian cancer. So if it is BRCA1, BRCA2 positive, I would want to bring in the PARP inhibitor.
The PARP inhibitors upfront. Now quickly going through your trial, Vivek, that this stopped because of futility. But again, you clearly mentioned the benefit was in the BRCA group. So why to use immunotherapy? Use only PARP inhibitor over there.
I totally agree that using, the trial design was not correct, and I don't think that there would be any advantage of adding immunotherapy to BRCA positive patients. Probably they need to do the study, they should have had an only olaparib arm to really prove that pembrolizumab was adding on. So in the unselected group, probably never add immunotherapy, even only with when they have mutations TMB greater than 10 or MSI high.
So message is very clear. When a metastatic prostate cancer comes to you, you have to counsel them for genetic counseling. Don't advise them BRCA testing. Send them to the counselor. It is the counselor's job to counsel, and then with all information in mind, the patient has to decide about the genetic testing, because we have molecules available which patients are getting benefit. Geriatric assessment is very, very important. Now the showstopper of the today's meeting is CAR-T. Dr. Nandini is there. She has presented the data. Now everybody is aware about the CAR-T. These are genetically engineered, the immune cells which are re-injected in the patients, and they look after the refractory disease. It has already achieved success in hematological malignancy like ALL and lymphomas. I have recently met a patient who has undergone CAR-T therapy 4 years back. So it has changed the game in leukemias and lymphomas. So we are seeing in solid tumors that this could. What is the idea behind it? The immune cell has to have a target, single target. Now what happens if you target at one target is achieved? Again, the cells are very smart enough. But in leukemia, CD19 is the target. In myeloma also now we have genetically engineered CARs coming from abroad. We don't have one person from the IIT has designed this CAR-T vector, and 15 patients' data is already out. This is first India-made indigenous CAR T cell, and the data looks promising. They have already moved into phase 2, which is designed, I think. The adult patient is also recruited. Initial data was from the pediatric. So immunity. So immunotherapies are evolved in that way only. We used to kill the tumors with chemotherapy, but in spite of getting the excellent responses here, this is the future. We have to enroll our patients in the clinical research trials. Fortunately, we as an oncologist community coming together on various platforms, and we should discuss ongoing clinical trials with the patients. Enrolling on the clinical trial is something which NCCN or any other guideline always recommends. So do look around yourself that there are clinical trials and your patient is fit. We must enroll those patients on the clinical trial. Thank you all my panelists to having audience. Before the lunch, the hall.
I would now request Dr. Vivek to come and coordinate and start the session, sir, please. And apologies for this change.
Good afternoon, everybody. So we've had quite a heated prostate session, and let's see if that continues with kidney cancer as well. So for our first session, our chairpersons, Dr. N.P. Gupta sir and Dr. Jagdish Kulkarni sir, please, I'd like to invite you, yes. And is Dr. Pathak here? Dr. Hemant Pathak? I think we informed him, he must be on the way. Our first speaker for this session, Dr. Mayank Agrawal, renal cell carcinoma in transplant recipients. Is there a role for screening?
Slides, please. Good afternoon, everyone. I would be discussing about the role of screening for renal cell carcinomas in patients who undergo renal transplant. So I would be discussing the latest evidence which was published in Journal of Clinical Oncology by the researchers from University of Texas. Patients who undergo renal transplant are at increased risk of malignancies. The most common ones are skin malignancies. The other ones are either infection-related or infection-unrelated. The renal transplant recipients, because of developing malignancies, are at demerit because the survival decreases, and malignancies in transplant recipients is one of the leading cause of mortality. The most RCCs which arise in renal transplant recipients are from the native kidneys, but they can also arise in the allograft. As already discussed, the affectation has not been found to be cost-effective. This is another evidence, although this is an old paper. This is the paper which studied almost 1,000 recipients, and they found that the gains in the life expectancy was less than 1.5 days at relatively high cost. Compared with no screening, the absolute gain in survival is only 2 deaths from renal cell carcinoma avoided per 1,000 recipients if the patients were screened annually for 62 years. However, the study also found that the cost effectiveness is there in the patients who are high-risk individuals, especially the patients who have acquired cystic diseases or who have a family history of renal cell carcinoma or suffering from familial syndromes like VHL. In another systemic review of clinical practice guidelines published in 2017, looking at the guidelines which specifically focused on the transplanted organs, kidney, and the cancer screening was done for kidneys, only one guidelines, European best practices guidelines, recommended screening by ultrasound. Rest of the guidelines did not recommend screening. So to conclude, screening for RCC in renal transplant patient is an effective tool for early diagnosis and to reduce RCC-related mortality. However, it is not cost-effective. It may be considered in high-risk individuals. I would like to thank my teachers and the organizers for this opportunity. Thank you.
Production and with aims of which could predict intraoperative adverse events and internally validate that model, we explored the possibility for such data from Vatiquity Collective Quality Initiative database. So VCQ from 9 countries, and it has for partial nephrectomy about data of about 3801 patients as using this database during past 1 year, we had published 4 papers, including this one, and 1 paper has been accepted recently in European Urology Oncology. So I just wanted to show this because maybe there were some limitations of this VCQA database, which we have highlighted in other studies and may not have been highlighted in this particular article. So data for intraoperative adverse events was obtained from VCQA database by combining the 3 parameters separately reported into the database. First was intraoperative complications, second was conversion to radical or open nephrectomy, third was intraoperative blood transfusion. So the database has
64, they are randomized controlled trials. One was, both are with the immune checkpoint inhibitors, where a good number of patients were there, 994 in the keynote and 778 here. So the first one was with the pembrolizumab, 200 milligrams IV, when it was compared with placebo, and the primary endpoint was the disease-free survival. The risk groups were the intermediate and the high-risk group patient population with a PT2 high grade and T4 sarcomatoid PT3. These were the high group. High group were PT4 and any grade PN1. And the metastatic were NED. So basically these patients either synchronously or metachronously they underwent a resection of their metastatic site. Metastectomy was done. The disease-free survival was, the hazard ratio was 0.63, and at 24 months it was 78.3% for the pembrolizumab AM, and for the placebo it was 67.3%. When overall survival, there was not much of significant identified. In the emotion trial, it was 778 patients were included. It was with atezolizumab, and 1200 milligram was given to the patient IV every third weekly when compared with placebo. Here also DFS was the primary endpoint, and similar risk group profile was there for both the studies. Here the DFS was hazard ratio was 0.93, which was a negative trial, and there was not much of significant in the overall survival benefits also. So to discuss what the author mentioned, identified in the keynote 564 and in the emotional trial, the lymph node invasion was one of the factors, poor prognostic factors identified for in the final histopathology assessment. For the keynote, it was the low proportion was there, 6% of 994 patients were there, but in the emotion trial, it was 11%, that is 83 of 778. So this is a very high risk factor considering the overall prognosis of this patient. Hence, they would have an early progression even after surgery. The second was the complete metastectomy, that is a M1 resected with no evidence of disease. So it is also a poor prognostic factor, increased risk of early progression will be there, which a higher proportion was there in the emotion trial, which was 14%, and in the keynote was 6%. So higher disease-free benefit in the emotion than in keynote 564, but still theoretically we were not able to understand why there was not much of benefits identified the DFS. So the possible explanation what was unexpected findings were there, that 78% of M1 N0 disease included in the emotion trial had metachronous metastasis resected, that is recurrence of disease occurring no less than 12 months after the primary nephrectomy. And the synchronous metastases were 22%. So atezolizumab has little effect after nephrectomy, and that other factors may have probably counterbalanced the risk of progression among patients enrolled in both the trials. So to conclude, patients with lymph node invasion and patients with long-term metachronous M1 treated patients who comprised a greater proportion of patients in the emotion trial than the keynote 564 might not benefit from the adjuvant immune checkpoint inhibitor monotherapy, but they might benefit from the upfront immunomimmunotherapy combination or the immunotherapy TKI combination as soon as there is a progression seen. So absence of benefit for the systemic monotherapy compared with observation in those clinical scenarios has been suggested, although with little evidence. So finally, to conclude,
what happened is we stopped doing cytoreductive nephrectomy for all our metastatic RCC patients. And that paper was done with sunitinib, and over the last few years, we've had a lot of more therapies that have been available. So we compared sunitinib with sunitinib and surgery, and on the other hand, the systemic therapy was only getting better. So there was in fact some evidence, or it was our thought, that back to just discussing a few points about Carmina, it included only intermediate and poor risk patients, whereas this study had good intermediate and poor risk patients. For Carmina, the accrual was very slow and they did not even reach their planned accrual. And there were considerable shorter OS in Carmina compared to all the retrospective evidence that was available till then. Another shortcoming of Carmina was the median size of the primary was 88 mm and the median total tumor burden was 140 mm, so only by the kidney. And that is why the benefit of cytoreductive nephrectomy was not very apparent in such patients, and those receiving systemic therapy had better survival. So to conclude, upfront CN should not be overlooked, as this paper says, and it has a significant better survival regardless of whether you're going to use a targeted therapy or the immune checkpoint inhibitor. But you should not be doing it for all patients, obviously. Younger patients with fewer IMDC risk factors, no adverse metastasis, and better performance status are more likely to be benefited. And you'll get the best results if you do it on the right patient, at the right time, and the right place. So you need to select your patients properly. So this paper is probably just adding on to what we actually do. It is giving us some evidence, first time some evidence, that even in the setting of using immune checkpoint inhibitors, the IMDC risk stratification can still be used. Our poor risk patients, give them the immune checkpoint inhibitors. Intermediate risk patients, stratify. And for the good risk patients, we're anyways doing a nephrectomy for them. Yeah. Thank you.
To the next paper, Dr. Shayan Pal from Kolkata will talk on bone-only oligometastatic RCC patients treated with stereotactic body radiotherapy.
Good afternoon. Thanks, organizers, for the opportunity. So this is actually a very interesting paper. So we heard a lot about MIPS and MAPS in metastatic RCC, but we rarely get to listen to radiation therapy in RCC. So this is an article which was published from Turkey. The retrospective patients data bone only metastatic renal cell carcinoma patient treated with stereotactic body radiotherapy. So as we all know that, so there is a role of local treatment for metastasis in renal cell carcinoma. We have many articles published and we have a systematic review also, which was published in Lancet Oncology and which says that the metastatectomy in metastatic RCC is favorable for overall survival and cancer-specific survival. And we have consensus guidelines from Europe, and which says that the hyperfractionated radiotherapy can be used for metastatic directed treatments, and TKI can be given concomitantly with radiotherapy, and SBRT has a promising clinical effectiveness, and if there is a spinal cord compression, should be given after decompressing surgery. And they have also recommended SBRT for metastatic bone sites. So the thing is that there were articles which was published on metastasis-directed therapies, but there are no article which was published on bone-only metastatic sites. So there are articles which other metastatic sites, visceral metastasis along with bone metastasis, and because the bone metastasis response was also not published in many articles, because it is, as per RECIST criteria, is a non-measurable metastasis. So this study evaluated the clinical data of 54 biopsy-confirmed RCC patients who were treated between 2013 to 2020 in 2 of the centers in Turkey. The inclusion criteria was a histologic diagnosis of RCC on primary tumor, fewer than or equal to 5 oligometastatic bone lesions as per the definition of oligometastasis, and control primary tumor. SBRT fraction they had used is higher than 5 gray per fraction with a BED or biological effective dose of at least 90 gray. They have used an alpha by beta value of 2.60 because there was a conception that RCC is usually a radio-resistant tumor, but if we use high dose per fraction in SBRT setting, we can overcome this radio resistance. So the exclusion criteria was if the patient had undergone any surgical procedure for metastatic lesions, had functional loss due to fracture, or had any other type of metastatic lesion besides bone metastasis. So these patients, this is the criteria, patient's characteristics. Most of the patient had received systemic therapies, and many patients had systemic therapies before doing the SBRT, mostly TKIs and immunotherapy, and few patients have received TKI and immunotherapy both. And in few cases after SBRT, the systemic treatment was also, but only one metastasis, there is not much difference. So all oligometastatic sites, they behave similarly, but patients who were given with studies so far has been published, which
metastatic RCC.
Good afternoon. I would like to thank organizers for this opportunity. I'll be presenting this paper on outcomes of radiation therapy plus immunotherapy in metastatic renal cell carcinoma, results from Canadian Kidney Cancer Information System. It was published in 2022 in Advances in Radiation Oncology by Eric Nguyen et al. Coming to the background of this article, immunotherapy is the first-line option for the management of metastatic renal cell carcinoma, and evidence has suggested that response to immunotherapy may be potentiated by radiation therapy due to the synergistic potential of combined modality therapy. Compared to conventional fractionation, stereotactic radiotherapy with high-dose radiation may produce immunomodulatory effects which enhance immunotherapy response and overcome radioresistance. It has been hypothesized that higher dose of radiation initiates endothelial cell apoptosis, which results in excellent local control, but this is not seen in conventional fractionation. So, purpose of this study was to evaluate outcomes in patients with metastatic renal cell carcinoma receiving immunotherapy and radiation therapy compared to immunotherapy alone. So, data were collected retrospectively from 14 academic centers across Canada between January 2011 to September 2019. In total, 505 patients with the of immunotherapy. When they looked at the results with a median follow-up of 13.9 months, 2-year overall survival was around 55 in a combined arm, and it was 66 in a immunotherapy alone arm. Though outcomes were favorable, but did not reach the statistical significance. However, time to treatment failed was 12 point with the focus on RT timing and clarifying appropriate dose fractionation based on immunotherapy agent. So my take, there's a significant heterogeneity in patient population and also in prescribing RT dose. More than 90% of the patients in radiotherapy arm had brain and bone metastasis, which was poor prognostic factors. And nearly three-fourths of the patient had received palliative radiation with the primary intent of symptom relief, that is purely palliation rather than local control. And majority of them received very low RT doses. Optimal dose and fractionation, it has not been defined yet, but however, preclinical studies suggest that dose as low as 12 gray per fraction is needed to initiate immunomodulatory effect. And finally,
practice, I don't know amongst the audience who is doing this kind of treatment. Regarding the surveillance in renal transplant recipients, I think so ultrasound is very commonly available, and like a annual health checkup, ultrasound should be done in a post transplant patient, and I think so in India that kind of study is not a problem actually, that is a routine practice.
Couple of comments, as Dr. Gupta has clearly said, and I endorse what his views are. Now, of late I'm seeing patients at Bombay Hospital where the transplant program is going on for the last 30 years. And in last 3 years, I have seen patients who had recipients, more than 15 years, 3 renal tumors in these native kidneys. In other words, why it was not there before? Because the transplant recipients are not surviving. As they are surviving more, this is as far as the RCC is concerned. There are other recipients who are also developing prostate cancer, lung cancer, and so many things. So it's going to be there. And I think with the transplant program, which is going on so well across the country, and now we are finding these patients, so we'll have to be more vigilant, and we will have to look into not only ultrasound, but something more than that, because the patients are going to live longer. So that's one take I got. The other thing which, of course, we looked at this cytoreductive nephrectomy. The debate is going on and on. Well, thank you very much for this new abstract which says there is a role for cytoreductive nephrectomy. We are reanalyzing and reinventing those things, that there is a place for cytoreductive nephrectomy. Having said that, oligometastatic, bone-only radiation, again, the radiation was never used as a primary therapy. It is always for pain relief. So I think the articles also clearly mention that the primary treatment plus, and as the immunotherapy is going to be the answer. Slowly, I don't know, Dr. Gupta was saying that we might have not to do any nephrectomy either. So maybe the times have come where we'll have to look into these things. Thank you very much, and very good session, and very good selection of papers. The honesty of the people was good, in the sense those who were reported, especially if you see this article on, nephrometry, nephro score, 24%, as I saw, were converted into open surgeries. Honestly, I think that's very nice. Thank you very much.
Thank you, sir. We move on to the panel. May I call Dr. Bakshi, sir, to moderate the session. And the panelists, Dr. Kishore T.A. from Kochi, Dr. Anil Mandani from Delhi, Dr. Kumar Prabhas, sir, Dr. Amit Ghosh, sir, Dr. Puneet Raj, and Dr. Bhavin Visaria.
Thank you. So we'll have a brief discussion on the papers which were presented. Any specific questions from the audience is welcome. So we'll take one by one. And addition to this is the main organizer, Dr. Kumar Prabhas. There are 2 abstracts which actually need him, and hence he is pulled here. Thank you. So as sir just said, there are 2 articles where they're on renal transplant patients where screening for renal cancer seemed to be important. So we have been in cancer, and sir just made a comment that been seen some 2, 3, 4 patients over a long time. So Dr. Kishore.
Line also recently it has come up.
Ganesh,
Okay.
can I make a comment?
Yes, sir. Please.
Most of these events are later in the transplant recipient. 99% of the times this patient doesn't see a urologist. He's been followed up with a nephrologist. Nephrologists are not cancer oriented. They would be simply looking at renal functions and moderating or modulating their therapy. That's one of the main reasons.
Can I just put in? Yeah, you wanted a comment.
First of all, I have worked in a very high volume center, which is the Oxford Transplant Center, for very many years. And the incidence of that renal cancer in transplants, in my experience, has been very low. That also is applicable in India. If you analyze the data that is already published data, whatever RC happens in renal transplants happens mostly in the non-Asian populations, in the African population. Okay. So I'm a little skeptic about the significant incidence of RCs in transplants in India. But even if it happens, I don't think screening is going to be a problem. I don't think it is going to be actually cost effective. It is not going to be cost effective. It is actually going to be cost effective, but for the wrong reasons we are going to do a transplant.
I have a comment. Recently we have noted...
Quick comment.
Especially in cases of... To know that
we are discussing this paper. I'm really delighted to know that this thing has happened. But if you look at the actual incidence of RCC in 2000, and they had a series of 2,000 patients in 20 years, 16 patients had RCC. So KDIGO guideline does not recommend routine screening. In EUA also says in high-risk patient. But for the first time, we Indians should recommend screening for recipient. It is not a big deal. Annual screening with ultrasound is not going to kill anybody. Just think of yourself as a recipient. Would you mind not having ultrasound every year?
Wait, is it recommended right now? No.
No, that's what I'm saying. Okay. This is the first time we should give recommendation.
So Puneet, you operate cancers. How often you get a reference? Have you operated one like this? I mean, I've been in TMH where there is no renal transplant, so I have no experience.
Patients are dying with cancer.
But sir, but as such in India, every renal transplant patient is getting an average of 4 to 6 ultrasound every year.
So
by the nephrologist.
Saurabh, you said you have been seeing transplant in recipients, right? No.
Yeah.
Have you seen renal cancers in transplant recipients?
No.
Till now, I have done 5. All of them have been low grade. I have never encountered a...
All clear cell?
Yeah. All
One
clear
patient?
cell, no really like high grade lesions I have seen.
These papers had a mix of mostly clear cell, then few chromophobe, and then papillary.
All of them.
If you can, I just have one point to discuss here. For transplant patients, like, is there a, like we are talking about screening, is there a particular category of immunosuppression or drug which causes more patients more prone to cancer? Like TAC is supposed to be a cytotoxic, and in patients receiving tacrolimus, the incidence of cancer is more. Mostly these are skin or lymphomas or leukemia. So, but these cancers can also happen. So, is there a particular thing, like if patient is receiving tacrolimus, you should screen more for that?
I don't think it is drug based in the literature.
No,
Dr. Kishore, anything? I think the immune suppression itself is a big problem.
Anecdotal reports of TCC coming with cyclosporin, that is, otherwise no, not much.
So again, coming back to one point raised by Jagdish Kulkarni sir.
Ganesh, can I make? So I think so now, whenever we have screening, the criteria for screening remains similar, and we need to keep putting, does it fit into it? Is it a significant problem? That's first. So that we need to say it. Second, that does it cause the kind of mortality what we're looking for? Third, do you have a test which can really pick up early to change the natural history of the disease? And then to show that if you did it, it did decrease at least the disease-related mortality. And that's why screening is a big problem. which any disease you'll keep seeing, we know PSA story, we know breast cancer story. So be careful here. If in your
So this is a smaller population.
if your kidney transplant patient, if this incidence is too low, criteria remains the same. The test should be decreasing, it should be picking up early. You should be able to treat to decrease the mortality. No, those criteria, wherever you do, remains the same. You need to fit those criteria. I do agree. It's not a population-based screening I'm talking about.
Okay, I think we'll.
But if you have
Ganesh, one last.
they have more potential to develop other malignancies in the abdomen.
Go on,
so
go on.
It might be worthwhile to get an ultrasound for kidney transplant recipient.
Got it. This is eminence-based guideline. We say it, and I also do it, and that's
Yes,
fine.
Santosh, anything?
Just the recipient kidney which is already affected by CKDs generally don't get clear cell or chromophobe RCCs. There is a category of RCCs called as ACD cystic disease associated. It's a dialysis associated cystic disease which occurs and then develops. That's got a specific morphology which is completely separate and different from conventional.
These papers had the RCCs.
That's a strange funny. I did not reach that.
I agree, but these papers had clear
the
cell chromophobe and
the
papillary.
donor kidney generally has PTL. Which are called as post-transplant lymphoproliferators. That's the commonest thing of lymphomas, because they immunosuppressed lymphomas are the common malignancies.
And I agree. And for that, there can be some argument about it that do you want to have a screening for post-transplant lymphoproliferative disorder? Because that's the commonest disease you have in that setting.
But that acquired cystic disease RCC.
I think we'll go on to the next abstract. Sorry. Development and validation of a nomogram predicting intraoperative adverse events during robotic assessment.
About your ischemia time that is going to happen.
Sir, but don't you feel now enough discussions have happened on ischemia time? Ischemia time probably now is mattering when the parenchyma is as such in a not so normal state, or the recovery, the left out parenchyma after cutting the tumor is very less, or the left out parenchyma has got a problem. So ischemia time is also technically important in patients who have solitary kidney or a deceased or a semi-deceased kidney.
Yes, that is why the function is important. You see, it is not only the imaging and the radiography so far that we considered, it is important the duration of, the proof of pudding is in eating. Your ischemia time may be not 25 minutes, 20 minutes, 30 minutes, but what is the effect of that ischemia time as far as the recovery duration is concerned is very important.
1 minute before you. I mean, honestly, I have done a partial for 1 hour and patient is absolutely fine.
Because his recovery, what was his kidney injury?
It was less.
Yeah.
But so, I mean, we just keep on shouting about ischemia time, ischemia time. It's not, I was saying, not always important.
Yeah, in these situations, transient rise in the creatinine may happen, but usually they comes to the normal.
So that transient is also an AKI which comes back to normal with good recovery and healing.
Yes, one thing.
Probably.
Second,
Those who do not come back is what matters.
Right. So recovery of the left out renal parenchyma post ischemia. Kishore, what is your comment on that? You do a lot of partials.
I think, again, nephrometry score men.
ectopic kidney, horseshoe-shaped kidney.
Why obese patient particularly? Because obesity otherwise should not cause anything.
No.
There is no literature data support on that.
Just my question is, like suppose we are operating on the obese patient.
On evidence basis, I don't think obesity stands anywhere.
Technically, sir, in obese patients doing surgery, lot of fat.
If you're doing robotic surgery.
Yeah.
Easier on the obesity
easy maybe,
side.
but yeah, it's not about only robot. Surgery per se in the obese patient vis-a-vis in the lean thin patient is easy. And
I think come to your specific point.
Yeah. So other factors also play important role other than the tumor specific factors.
Oh, that we discussed. Gopal, anything you want to say specifically?
Sir, regarding...
There are a lot of nomograms.
Yeah,
I think after yours also more will evolve.
Yes, sir. Definitely. So this is different from others because in this we have looked for intraoperative If you have patient's age, all the data from
Agreed.
the 5.
My question was different actually. It was like, suppose if I am doing a very complex partial nephrectomy, today
Yes.
seeing your nomogram, should I totally give up on that? That's the question.
No, sir. There is
It's
no.
basically to have a better idea of what
It is
amount
just-
of complication you are going to have and to counsel the patient.
It is just basically for counseling. Renal nephrometry score, even the scores of 12, it doesn't signify that we should abandon the nephrectomy. It is
But
just
it
to,
does say in the MD calculator that there is a 14% chance of urine leak
That
and
is
there
what
is
is
a
in development.
10% chance of some complexity. It does say that.
so that we can counsel the patient accordingly then.
So that is what is in development, and we can actually tell patients that this
I think we'll go ahead then. Identifying patients for adjuvant therapy for after nephrectomy. Let us initially have a small surgeon discussion and then take Dr. Kumar's view as what he sees in such patients later on, when they are not given probably or too late given therapy. So what we know is all these things: source, assure, extract, and then I just put these slides because these are the therapies. Nivo cabozantinib has a role. Probably Randeep just told me that it is an upfront, you can give it in any patients. Keynote 564, I think lot of big time data and results were reported on that. So, sir, if you have these, okay.
No, I mean, I can comment on this.
Yeah, please.
For me, I don't think there is a role of any adjuvant therapy. There is evidence-wise, there is no evidence to prove that. And rationale-wise, there is no rationale in either giving ICI or sunitinib.
Okay, so
Pembrolizumab does have a role to play.
I mean, it has evidence.
It has evidence, yeah.
So I have changed my practice to basically counsel the patients. So once I see that the patient has a tumor which is T3 or
I'll just give a scenario.
Yeah.
I operate a IBC thrombus which is intrahepatic with a lot of hilar nodes which all come positive, Fuhrman grade 3, clear cell RCC.
Yeah.
What will you do post-op?
Obviously,
surgery is clean.
I would counsel the patient about the role of the potential role of pembro in this setting, and I will tell the patient that there is one study which is supporting this, and that also disease-free survival, not an overall survival.
Or they live more, or they live more without disease. So definitely there is a rationale that one should. TKI, I do agree, NCCN guidelines suggest there was a trial positive, 2-3 negative. Usually people are not so keen. Ganesh knows we are also not so keen in TMH when we were together. Coming to immunotherapy, 1 trial positive, 2, I think so 3 is negative. I totally agree. There are negative study. This trial, all updates has been positive. I don't know, it is a surprise for me. But this is similar issue in bladder cancer also, that there is 1 trial positive, 1 trial is negative. The positive trial this time got updated and presented in GU ASCO. And the difference in survival for PDL DFS is 12 months versus 50 months. Not easy to ignore those kind of data. So here also in kidney cancer, what I'll suggest that the discussion should happen. I'm not saying one has to give in every patient, but to say that discussion should not happen, meaning that we're thinking that that data which has come, and you don't have alternative unless you have it. For example, I say T3, all thing good, Fuhrman 1, perfectly fine. But what was suggested by Ganesh, in that trial, metastatic patient who had a arterial resection was also included. Then you will say, we have 10 nodes, you have removed it, T3 tumors, not easy to ignore. So having a discussion definitely should be there.
So maybe have a good counseling, have discussion and offer. Quick comment because.
What the patient has, and absolutely fine. I'll give you an example, and published from Tata Hospital, we had a lignocaine trial by Dr. Budweiser, 3% absolute benefit, but lignocaine cost a few hundred rupees. This is this has got covered into so many places, including JCO with editorial. So you do have a cost also giving you where you want to use what. I totally agree with you.
Just a comment to Amandeep. Amandeep, this is not aspirin. In adjuvant IO, we will be discussing that in the next session, has toxicity. And there is a discontinuation rate of 20%. Discontinuation. So even if it is one
brain bone metastasis, people who are young, good, favorable IMDC scores, I don't see any reason why we should
but when
do a
you say
nephrectomy.
young, no brain bone, stroke, when you then separate good IMDC score, then one is objective, one is very subjective.
No.
I mean, the criteria are subjective. So I will operate the best of the prostate cancer patients and send the remaining to my radiation friend. So
But that's their job,
we
isn't
used
it?
to have a discussion long back, 10 years back in Tata Hospital like that. So it is that kind of logic. If I give him equal patients, he'll produce results which is quite good.
You can't. In the unfavorable patients, it is already proved that it just doesn't work.
Okay.
So the surgeons are a privileged class, isn't it?
So there was a good deal of matching which was tried in this very large study. I agree with that, IPTW matching. Puneet, I don't know if you have gone into details of this paper.
I have gone into
details. There was
details,
a lot of
but
matching, it
like
was quite
Amandeep said,
confusing.
I could understand a bit of statistical analysis, but not the whole lot of it. You know, there was something called multivariate confounding.
I also thought so. I mean, there was a lot of matching tried, but God knows.
What the gist was that they tried to evaluate, had both the groups been of the similar settings with similar criteria. So what would have been the results in that? So even after that, they found that the upfront cytoreactive nephrectomy was better in both targeted and targeted and ICI.
Reverse engineering. The target was decided, and we looked into that.
So what I think is that had it been based on the IMDC criteria, you divide have a good risk patients, intermediate, and then poor risk patients, and then evaluate do a subgroup analysis. That would have been probably better.
Maybe. Sir, the question is for you, Dr. Mandani, sir. The fourth question. I think we'll end this abstract after that. So, will you change any practice which you do today, or you will continue with the same?
Absolutely not. I would try to remove as many sites as functionally possible and just observe.
Okay.
And if he has residual disease, then only I'll consider him for adjuvant. Otherwise,
No, not
disease.
adjuvant. This is an upfront site to
Upfront,
detect.
yeah, upfront, apart from nephrectomy, as many sites as functional.
So the guideline says that if upfront cytoreactive nephrectomy you should do if you are able to remove that as well as all the metastatic sites.
So that
then
is in
you
a
should- then-
oligometastatic in a group somewhere which are there. So coming to the two radiation topics which we had, bone only oligometastatic renal cell carcinoma. So bone involvement is seen in 20 to 35%, and this was said in the presentation by Dr. Sayan. OS is higher with a solitary, and then as the bone mets increase, it goes down. So what do we routinely do? You have a large renal mass, Dr. Kishore. So the first question, will you always properly do a bone scan?
We do a PET scan, and we have encountered at least 3-4 cases where isolated mets in the clavicle.
Okay.
Long
so
bone
all
of failure.
renal
All have
cancers, you will do a PET scan?
PETs, most of them.
Why I put this question is because sometimes, I've seen many patients where a small renal mass or a 7 centimeter renal mass, nobody does a metastatic workup. They operate.
I mean, some cases you do, it mandates, yeah.
If I say so, PET CT everybody is getting, but that is not the standard protocol.
Not standard
And many times you do a CT abdomen pelvis where you have lower cuts of the lung also. We are talking about bone, but even upper lung is missed in that. So I'm saying bone is not even touched in the preliminary investigation.
But it can happen, solitary mets.
Yeah, I fully agree with that.
Yeah. So we have gone ahead and resected it actually with the help of orthopedician. The solitary mets. We haven't had any experience giving a stereotactic RT to the bone. So.
Okay. So technically, if you see a patient, sir.
Initial workup, calcium and alkaline phosphate.
If alkaline phosphate is raised, we would always do a bone investigation. Right, sir.
Still there. But now change to
PET scan. So if there is a, say, solitary or a bone oligo thing, solitary, how you manage it?
No,
because one
bone
thing I
mets are-
always feel is it is an multidisciplinary team discussion. Rest you answer, please.
Yes, SBRT is very straightforward, especially bone mets, spine mets, easily treatable. This abstract has shown 90% control rate, which I think is fair. It's as good as any surgical resection.
It's a old paper. I think it's a 10-15 years old paper.
But in the article that I presented, that spine metastasis did better than other
Exactly.
bone metastasis.
Kishore said
yeah. So if it is in that case, because it is not in the spine, and doing SBRT in a humerus spine or
okay. So coming
That
to
must
the
be
last paper.
That must be the biology of the disease. They said the better outcome was with the spine metastasis, not with the spine SPRT as such. So it's probably representative of the...
No problem, but the article says that it's spinal metastasis, they did better with SBRT.
Yes, it's the biology of the disease, not so much the SBRT
spinal,
technique.
yes, that is the biology of the disease, but that does not mean that SBRT cannot be done in the humerus. It would be much more simpler. We don't have a critical organ.
Agreed. I think that is the point.
And also it would be a...
Hazard was on the same side. In fact, hazard was better. Yeah, correct. A very good hazard for these patients.
Okay. So this is on the last abstract, outcomes of RT plus immunotherapy, which Vinay presented, and then we had these patients not doing well in the paper. Am I right?
Yeah, absolutely.
So this question to you, is there potential ability for RT to induce abscopal effect or not?
It was a mythical belief. It still is mythical belief. This is proof that this is absolutely a mythical belief. Those patients who received radiation have not benefited.
So you don't believe in astrology?
I don't believe in abscopal effect of radiation.
So sir, Amit Ghosh sir, if you see patient of MRCC and these options are there, we had outcome of radiation therapy plus immunotherapy. So RT to the kidney, right Vinay?
No, bone sites, in any radiation.
Any radiation.
Invariably it was bone mets or brain mets.
Brain mets.
And
not to the primary.
Not to primary.
So would you prefer any kind of surgery or T?
No, where to, sir? The question is where.
No, that's okay. That's okay.
No, obviously for the kidney there won't be an option of lost. If there was contrast enhancement in the baseline evaluation, that is lost.
See, contrast enhancement, diffusion restriction.
Ganesh is asking question, whatever you gave, I agree, your argument can be, it was not SBRT, so you don't have scopal effect. Some effect, negative you don't.
That's what I said.
Then if they are poor performance status, disease burden is higher. When you are doing high fractionated radiotherapy, SBRT, disease burden is lower. So probably they could have done better. I mean, it's just an afterthought.
So this is in Canada. It is state-funded health. So they need to justify every treatment. So those patients who are really symptomatic or really needed treatment only would have got the treatment. So they are the bad biology disease. It's purely selection bias.
So maybe. Thank you. Thank you so much.
Thanks a lot, sir. Thanks to the panel for a wonderful discussion. I think we're going to take 2 sponsored sessions now, since we are ahead of time. So Bakshi sir, if you can still stay up to deliver your talk on agonists versus antagonists. And after that, Dr. Kumar Prabhash sir for case studies in metastatic disease.
Thank you. So this is a sponsored session from about AstraZeneca, Unleashing the Controversy, LHRH agonists and LHRH antagonists. Who need rapid reduction of testosterone. 10, goserelin was used as neoadjuvant in locally advanced prostate cancer. T2 to T4, M0 with or without pelvic lymph node involvement with the locally advanced group in the inclusion criteria, and randomized to neoadjuvant goserelin plus followed by radiation and goserelin versus radiotherapy alone. Now, it's a standard of care nowadays to offer multimodality in these kind of patients. Here the median follow-up was 6.7 years. This trial was published long back in 2008. And a 10-year survival update was performed at a median follow-up of 10.6 years. The primary analysis conducted at, as I said, median follow-up of 5.9 years. At 10 years, 23.3% versus 35.6% had died of prostate cancer in the goserelin plus flutamide plus RT versus the RT alone arm, and 51% reduction in the risk of prostate cancer specific mortality over 10 years with the addition of goserelin. Survival results with neoadjuvant goserelin plus flutamide and RT versus RT alone. So at more than 10 years of follow-up, 64% versus 49% in the 10-year PFS. So if you see the forest plot, it favors radiotherapy plus goserelin. So patients, as per this study, patients who were post-RP needing radiation therapy, there would be more benefit with adding goserelin. Goserelin has again this going on to the metastatic prostate cancer. It has been as effective as surgical castration in the clinical outcomes. So the initial papers were surgical castration rates of testosterone. The goserelin paper had reduced testosterone levels of less than 20. And in these publications with Kayseri et al., phase 3 randomized multicenter trial, the primary analysis was conducted at median follow-up of 63 weeks. The patients had all histologically proven metastatic prostate cancer, median follow-up of 2 years, and there was clear benefit, again a similar trial by Vogel-Zhang. So the goserelin here everywhere was as effective as a surgical castration, which was considered the standard of care. So if you see mean time to response, it is as good. The mean duration of response is as good. Comparative data between surgical castration and medical castration, almost same with goserelin. Large clinical trials with extensive follow-up, again with all the 3 stages of localized prostate cancer, locally advanced and metastatic, shows good effect and benefit with using LHRH agonist goserelin. Recommendation for ADT across disease states is quite consistent between the guidelines today. NCCN, EAU, ESMO, ASCO, all use LHRH in high-risk localized disease with radiation as neoadjuvant as well as adjuvant. In locally advanced also, ADT of 2-3 years has been used. There are papers which have reduced this duration in some high-risk localized to 18 months from the earlier 36 and 24 months. And M0 or M1 CRPC, castrate levels of testosterone are yet maintained, or sometimes these patients are pushed on to the surgical castration. So if you see the overview of LHRH agonist and antagonists, there are a couple of agonists, goserelin, leuprolidine, triptorelin, buserelin, and degarelix still stands across all of them. Has been used, if you see the overall use, it has been all these which are safety concerns, injection site reactions, clots reported significantly higher ISRs in the pooled degarelix groups, 40% versus the LHRHA groups less than 1%. These reactions were mostly mild or moderate in severity and occurred predominantly after the first injection, 33% versus maintenance dose injections where this reaction was lesser. The author suggested that the difference in ISR might be due to the different forms of administration and T-degarelix achievement of castrate testosterone levels that enable it to be used in aggressive prostate cancer for progression. However, a wider use of degarelix is restricted by the lack of dose that lasts more than a month and a higher frequency and severity of ISR. There are reports of degarelix used to ensure rapid testosterone suppression without a flare, followed by a switch to a more tolerable and easy to administer LHRH agonists. The NICE guidelines also report that despite advantage of degarelix providing more rapid and improved disease control.
So we had a whole discussion, so there is no point dwelling on it. You have a oligoprogressive disease or oligometastatic disease, and then what do we do? Here, I think so they decided that, looks like lots of surgeons there, so they decided to highlighting, and many of them we have been discussing for almost now half the decade or more than half the decade, showing why ADT gets used and how it benefits the patient, and also the all ADT are not same, and Dr. Ganesh explained it in detail about it, and you can choose one of them, whatever you want to choose in the clinic. These are for the same, the strength and weaknesses. So the patient progresses and then becomes CRPC. So them. Not a single one is left there, by and large, those oral tablets or injections. Cabazitaxel, because it failed, so it got out, so it has remained in, CRPC. My feeling is lutetium, by and large, in a year or 2 or 3, it is going to be an HSPC. So always the question remains, how do you use the sequencing? And that's why I keep saying, whole lot of our practice is not on level 1 evidence. We say, no one is going to do this study again. You will be kept using this drug, which is sequentially, because the data is indirectly being there, so we'll use one of them. And these are data for abiraterone and cabazitaxel together. And there is a decent data for platinum in, iska naam kya hai, BRCA positive. So not a bad idea. We do this routinely, and you are aware of it. But to say that, yeah, someone needs to work on it. This is one area.
Propel, how will you do it? And in single agent olaparib, how will you do it for ATM check and HRR, which are non-BRCA ATM check?
So BRCA, no doubt, I think so. We all are happy with it. Others, there is a problem. ATM, then also you can, it looks fair. Others, it doesn't look fair. As much, I agree with you, and good you asked this question. So as much we say HRR, HRR has a connotation. So there is a concern regarding others, and not only here, it is a concern regarding in multiple places. So non-BRCA, be careful. Non-BRCA, non-ATM, be very careful, in that setting. Yes, sir. And combination, not sure what that combination does, but we are. So, but Abby looks like because they are exposed to ANZA or something, they have to, for the trial sake, they have to made it, and they had some reasoning also. Morning, Vamsi was about why the reasoning was, but my feeling is that looks like pattern of outcome remains same, if single agent also. So I'm okay with it, but I won't mind combining. If I have to stop it, I'll stop, abiraterone.
So quick comment about your question. If it is first line, then the preference will be towards combination. In first line CRPC, the preference will be for combination. But subsequent line, we have the data of only single agent. We don't have the data for combination. So far as HRR genes.
Many of the patients were exposed to the novel anti-hormone.
Yeah, but they were
in
not.
The Propel, they were exposed to novel
anti-hormone. They were not on abiraterone in last 4 months.
They were not. Yes, there was a gap of 1 year. Yes.
So, so far as HRR is concerned, my understanding is that it's a dynamic inclusion of 15 different genes. It's dynamic. In the coming years, some of them will go away, some new will come in. So, let us see what comes out in next few years.
Yeah, there is a registry there. I think there's a very nice registry by some group they have made, and they are putting all these patients, and what they want to do, each mutation, each gene wise they want to come up with, does the drug works or not. Looks like that is the way we may get the answer. But no doubt that curve doesn't look good. At the moment you go beyond ATM, the curve doesn't look good. If none, then thank you. Thank you so much. Thank you so much.
Okay.
trials. For the first one, I invite Dr. Ajay Singh to talk about his on the efficacy and safety of some drug combinations for renal cell carcinoma with a high risk of recurrence.
Thank you, sir. So good evening, everyone, and thanks to the organizing team and Randeep sir for giving the opportunity. So basically, I'll be discussing regarding the role of adjuvant therapies that is beyond TKI and immunotherapy in advanced resectable RCCs. So as we know why there is a need for adjuvant therapy, because almost 1/3 of the patients present in curative stage, and among the patients who get resectable surgeries, again 30-40% patient had relapse, and overall the 5-year survival rate in these patients who develop metastatic disease is around 10%. So definitely there is a need to add some additional therapy in addition to curative therapies. And among these, the patients who undergo surgery, there are multiple risk scores to define who are the low risk group, who are the moderate risk group, and high risk group. And commonly we generally use UISS classification risk scoring based on the TNM and performance status and the grading score. And in this group, you can see that the patients who are having a low risk, almost having a median OS of around 30 months, then intermediate risk having a median OS of around 18 months, then high risk group having a survival less than a year. So almost 9-10% in the low risk, 40% in the intermediate, and 60% patient in the high risk group have a relapse of the disease after this curative surgery, and their survival is in at least high risk, they're not even a year. So this is a summary of adjuvant TKI in patients who underwent surgery, and out of this only the S-track was the positive trial. And in S-track you can see that the patients who had a T3 high grade tumor or T4 with or N1 disease has shown a significant benefit along with patient having a grading tumor grade of 3 or 4. So, and in this the only benefit was seen in terms of the DFS. There was no any survival benefit. So based on this trial, so sunitinib is somewhat got recommendation in US countries, and it is a NCCN category 3 recommendation to patients who are having these high risk features to recommend sunitinib as an adjuvant drug for 2 years. So as we know, high risk features. So they included a T2 tumor with grade 4, T3A grade 3 and 4, then T3B or C or T4 or any node positive disease, or patients who had limited metastatic and underwent RGO resection, and included clear cell and sarcomatoid variant. So they randomized this patient atezolizumab for 1 year against placebo, and with key primary endpoint of DFS in intensive to treat from population, along with the overall survival in intensive to treat population and DFS and safety profile. So baseline characteristic was almost similar in both the groups, and you can see that there was some PD-L1 positive patients, almost around 60% patients had a PD-L1 positivity. So the initial results was not favorable, and both DFS and OS was not significant in intention to treat population. And in the subgroup analysis, you can see that in patients who had some sarcomatoid variant or the PD-L1 which was higher side, that is more than 5%, they have shown some benefit. So based on this PD-L1 positivity in patients who has more than 5% of PD-L1 IC score or 2 or 3, they have shown some benefit. Otherwise, overall this was a negative trial. There was no any benefit. So for this trial, the conclusion was adding atezolizumab will not be help in prolonging any outcome, and only in subgroup they have suggested, that is sarcomatoid variant or high PD-L1 expression, there may be some benefit. So again, the next trial was the Checkmate 914 trial. So it was a adjuvant nivolumab plus ipilimumab, and the major change is that duration of therapy was around 6 months in adjuvant setting. And again, almost they have included similar high risk patients with the P2A including grade 3, 4, then P4 and PT tumor and any node positive tumor. And here they randomized patients for initial 4 cycles of Nivo-IP combination, and followed by continuing Nivo for at least 6 months. And the immunotherapy era also, except for pembrolizumab, the other 2 trials
angiogenesis has been linked to enhanced efficacy of immune-based cancer therapies. And increased PD-L1 expression has been associated with shorter survival in clear cell RCC who are treated with VEGF inhibitors like pazopanib or sunitinib. So the rationale is to combine the VEGF pathway and subsequent follow-up. So this is a 3-year data cutoff, and after a median follow-up of 44 months. So it also includes the subgroup analysis by IMDC risk category, and it was 16.6, and in the sunitinib it was 8.4 with this impressive hazard ratio of 0.58. It also translated into the overall survival, in which the OS was 49.5 months in the Nivo with cabozantinib, and versus 30.5 in the sunitinib arm. That means we had a 14 months of OS advantage and nearly 8 months of PFS advantage. 8.4, and hazard ratio was 0.59. So overall, also we had a 14 months of OS advantage with a combination of Nivo with cabozantinib versus sunitinib. So this is the OS data. We can see that in the patients who have favorable risk, the curves are nearly overlapping, whereas in the intermediate risk, it is separating wide, and definitely in the poor risk, we can see that the Nivo plus cabozantinib is it is favoring the treatment over sunitinib in the poorest especially, although it is there persistent across all the 3 subgroups. So moving on to the response rate, the overall response rate of the combination arm was 55%, and the sunitinib was 28.4. The CR and PR, both the CR, PR and both the things, they favor the combination arm of Nivo and Caboza versus sunitinib. And we can see that 6.2% patients had progression in the combination arm, and 13.7% progression in the sunitinib arm. The median duration of response was also high in the combination arm, which was 23.1 versus 15.2 months in the sunitinib arm. So here, if we subclassify according to the IMDC risk group, here also across all the subgroups, favorable, intermediate and poor risk, we can see that the combination arm fared better as compared to the sunitinib alone. So moving on to the adverse effects and the toxicity profile, we can see that the common toxicities which we see in our clinics is like the diarrhea and hand and foot syndrome, which was also reflected in this trial. And we can see that the any grade toxicity was seen in 97%, and the diarrhea was a predominant side effect of the combination arm, which was seen in 55 of any grade, and the grade 3 was seen in 7%. In comparison with sunitinib, it was 46, and any grade was 5. The other side effects are hand and foot syndrome, hypertension, and fatigue and hypothyroidism. But the grade 3 adverse effects, which predominantly are our concerns, are hypertension, diarrhea, and hand and foot syndrome. Definitely, there is some the others. The toxicity profile which we look are the mucositis, stomatitis, anemia, thrombocytopenia, and transaminitis, which was slightly higher in the combination arm, but the anemia was higher in the sunitinib arm. So if we talk about the treatment exposure and subsequent therapies, we can see that the median duration of treatment of Nivo plus Caboza was 21.8, and sunitinib it was 8.9%. The dose reduction was seen in 62.8% of patients in the combination arm versus 54% in the sunitinib alone. Disease subgroups, the use of subsequent therapies after discontinuation was also higher with sunitinib versus nivolumab plus cabozantinib, and the results they continue to support the combination of nivolumab along with cabozantinib as the first line treatment options for advanced or metastatic RCC. So the takeaway from my end is like the sustained OSS 3 years follow-up. The median duration of response was 22.1 months. There is a ORR data. The time to subsequent therapy is also impressive, 20.6 months. There is a depth of response. There were a large number of patients who were poor risk patients. Nearly 19% of the patients in this trial were poor risk patients. The one variant which we are concerned is sarcomatous variant. In sarcomatous variant also the PFS was 13.8 months and OS was 37.5 months. With this I would like to end this. Thank you so much for attention.
Thank you very much. Can I ask the next speaker, please? Shantanu Pense.
Good evening all. My today's topic is, thank you first for the opportunity given. Today's topic is phase 3 trial of addition of cabozantinib to doublet immune checkpoint inhibitors, nivolumab and ipilimumab, Cosmic 313, which was, so the background for this trial is formed by 3 trials, that is Checkmate 214, which was phase 3 combination immune checkpoint inhibitors trial were compared to sunitinib, which showed OS and PFS benefit. Overall response rate as well as duration response was better with doublet. No additional safety or toxicity issue was observed, but the treatment discontinuation rates was high and use of high dose glucocorticoids was high, suggesting that higher clinically significant toxicities were more with combination of immune checkpoint inhibitors. Then cabozantinib trials came, and then Checkmate 9ER, which Dr. Darshit recently presented, update show is also weekly, plus minus cabozantinib or placebo. Cabozantinib dose was 40 mg per oral per day, and the nivolumab treatment duration was a maximum up to 2 years. This is the 1:1 randomization design. One prior adjuvant systemic therapy was allowed for completely resected RCCs, and pardon this mistake, if recurrence occurred after 26 weeks after the last dose of adjuvant, the treatment of inclusion was allowed. Tumor assessment was done initially at week 10, then every 8 weeks through up to week 50, that is up to 1 year, and then every 3 months thereafter. And discontinuation of one agent did not mandate discontinuation of all agents. Baseline characteristics were almost similar. Median age was 60. Baseline was also stratified for PD-L1 status, intermediate and poor risk stratification, prior nephrectomy status, common metastatic sites, and primary endpoint was PFS for first initial 550 patients. It was blinded independent central review. Secondary endpoint was OS, which is yet to be presented officially, and additional endpoints were overall response rate, duration of response, and safety for all randomized patients, that is intent to treat population. Median follow-up for intent to treat was nearly 1.5 years, and duration of trial was from June 2019 up to March 2021, consisted of total 855 patients, of which 3/4 of the patients, that is 75% patients, were intermediate risk, 25% were high risk, and 428, almost similar number in both the arms, received cabozantinib and placebo. What were the results? This trial was positive for its primary endpoint, that is PFS. Addition of cabozantinib to dual checkpoint significantly improved PFS with hazard ratio of 0.73, which looks impressive, though median PFS is not reached, and median PFS for placebo arm was 11.3 months. And the benefit was found across all the subgroups, including age, sex, geographical variants, including sarcomatoid histology and PD-L1 status. A separation starts at about 3 months, and the gap is maintained up to the follow-up of nearly 2.5 years. There is consistent difference in the graphs. What was striking is there was little more benefit of addition of cabozantinib to intermediate risk group than poor risk group. A reason is unknown. Maybe IMDC subgrouping is not yet, may not be valid, and it is 3 patients with grade 5, that is death as adverse events. Probably it was immune-related and immune-related hepatitis. One death was immune-related hepatitis and one is myocarditis. 2 of the deaths were within 30 days of the last treatment duration, and one was after 100 days of the treatment. So these are the common side effects: AST, ALT elevation, diarrhea, expected on the line of cabozantinib. For cabozantinib, immune-related fatigue and lipase amylase elevation. Median response, treatment exposure and duration, number of treatments received is relatively lesser in the cabozantinib, nivolumab, ipilimumab arm. So fallout is higher in the triplet arm, probably related to toxicity. Dose holding is also significantly higher in triplet arm. So investigators' conclusion was improved PFS for cabo arm for previously untreated intermediate and poor risk across all subgroups with greater benefit in interim group with numerically higher overall response and disease control rate with manageable safety profiles consistent with individual profiles of given agents. And ongoing follow-up is going on for OS. So does it change current standard of care for me? Probably no. Till OS data is mature, it is difficult to say that this changes the current treatment paradigm. In addition to that, there are significant toxicity, including financial toxicities and increased hospital visits. There are no... another question is whether... one more question is whether cabozantinib addition to Nivo is better than... triplet is better than cabo plus single agent nivolumab, that is single immune checkpoint inhibitor. That needs to be answered. So probably this trial is not going to change current standard of care in upfront RCC till longer results are available. Thank you so much.
Thank you very much.
Thank you very much. Can we have the next speaker, please? Ashish Joshi.
So good evening, everyone. Thank you, Randeep. Thank you, organizers, for giving me this opportunity. Disparate from what my previous colleagues have spoken, this is more of an observational study, but it focused on a so-called orphan disease. It's a non-clear cell metastatic renal cell carcinoma. And as we all know that it constitutes almost 25% of the metastatic RCC that we see in the clinical practice and also is backed by the literature. The issue with this is that there are most of the pivotal trials which includes RCC would exclude non-clear cell histology, and hence there is no optimal standard of care. And if you dwell into the clinical or rather the algorithms, it's still mentioned that type 2 depending on the MET and the RET oncogen overexpression. The non-clear cell ones, the metastatic RCC, whatever the evidence which we have is very limited evidence, with most of the numbers of the trials includes 30-40 patients. The current standard of care includes data for nivolumab plus cabozantinib. There is a phase 2 study which is showing the overall response rates and disease control rates to the tune of 50 to 70%. There is a study of lenvatinib plus everolimus which works across all the non-clear cell subtypes and again gives a disease control rate of 50 to 70%. Axitinib monotherapy, there is some evidence of disease control rate, and there is also evidence that pembrolizumab monotherapy is active in metastatic RCCs. So metastatic RCC, non-clear cell carcinomas constitutes almost 25% of the patients with RCC, very limited therapeutic options, and they have generally overall lower response rates compared with metastatic clear cell RCC. So this study aims to investigate the effectiveness and tolerability of pembrolizumab plus axitinib combination as a first line in chromophobe and papillary metastatic RCC. This study actually included only patients with chromophobe and papillary RCC, which constitutes almost more than 80% of non-clear cell histology, but there were 2 or 3 patients with sarcomatoid, not variant, sarcomatoid features, non-clear cell RCC as well. So the baseline characteristics, non-clear cell RCC as well. So the baseline characteristic, overall response rate, disease control rates, and the PFS and toxicity were retrospectively collected from 12 Italian referral centers from December 2020 to April 2023, and only patients with chromophobe and papillary histologies were included in this particular observational study. So these were the baseline patient characteristics. As you could see here, chromophobe and papillary are the ones which are predominant. There were patients who had IMDC score of good, intermediate, and poor risk. Predominantly intermediate risk is what were included. Many of the patients had previous nephrectomy, or also some of them underwent cytoreductive nephrectomy, had a decent performance status for all 3, and they had synchronous metastatic disease involving bone, liver, lung, and nodal disease. So these were the radiological response rate that you could see. CR rates were seen in none. You had a partial response of almost 43% in the overall population, and 16.1% in the chromophobe and 19.3% in the papillary histology. There was overall response rates of 43.7% at a group level, but at the individual level, the chromophobe 1 had 41.6% and 47.3%. And I think that probably allude to most of the previous data that we know, that the chromophobe are not the one which respond very well to the treatment compared with the papillary histology. So overall response rate by the histology, again amplifying in this particular bar chart, were 47.3% in the papillary subgroup and 41.6% in the chromophobe subgroup. Again, similar to what has been echoed in the previous phase 2 study which I just mentioned before. And the disease control rate, which includes partial response as well as stable disease, was hovering around 60 to 70% in the papillary histology and around closer to that in chromophobe histology as well. So the regimen was active in both chromophobe as well as papillary variant of the non-clear RCC, and fairly decent response rates and disease control rates. Again, this study is not powered to study PFS and OS, but the progression-free survival is around 10.8 months, and which is what actually you see in most of the non-clear cell RCC studies, except for the monotherapy with pembrolizumab and axitinib, where the PFS was almost 6 to 7 months. So this again is consistent with the observation that we had with the previous study, that the PFS was around 10.8 months. Median progression-free survival in the papillary variant again was 10.8 months. So the results were 25 to 30 eligible patients, fairly impressive disease control rates of 70 to 80% in both the subgroups, slightly inferior in the chromophobe versus papillary, and the partial response rates or the overall response rates of close to 50% in both the histologies. Again, the tolerance was fairly okay. 34.3% had to interrupt the treatment because of the immune-related adverse events. Grade 3 hepatitis, grade 3 hypophysitis, grade 3 diarrhea, grade 3 pancreatitis and asthenia were seen, and 12 patients interrupted temporarily because of axitinib due to persistent hand-foot syndrome and hypertension. So the conclusion of the study is that pembrolizumab axitinib combination could be an active and feasible first-line treatment options for patients with papillary or chromophobe RCC. And my comments would be that data is too small, but all metastatic non-clear cell RCC data is around for 30 patients. So maybe we could debate on that. It's again an observational study. We have a data of nivolumab cabozantinib phase 2 data has a similar disease control rate and overall response rates. The keynote 427 data, which is pembrolizumab monotherapy, overall response rates was, as a monotherapy, was inferior with a PFS was just 4.8 months vis-a-vis 10.8 months, as you could see in this observational study. And probably it's the way of, can we declassify this
both for the surgeons and medical oncologists. So this was an abstract which talked about the grossing and reporting of post-immunotherapy nephrectomy specimens. So this is not a common thing. This is from a single institution, the MD Anderson Institute, and some of the pathologists on board are my good friends in this. Single institution experience of 70 cases. So immunotherapy is being increasingly used as neoadjuvant chemotherapy. We all know that, and in management of advanced RCCs, somewhere in the renal sinus fat, somewhere in the perinephric fat, you might find some viable tumor, and that's important. So what was the result? That they found discrepancy between the macroscopic and the microscopic extent of the tumor, and the post-immunotherapy staging may not be exactly translated from the AGCC staging which you use for a radical nephrectomy specimen. So post-immunotherapy staging might be a different, and it has to be looked up into, and that's one of the important results of this study. Another important finding, they divided these tumors into two groups, group A and group B, based on the viable tumor post-immunotherapy. So the patients who had less than 20% viable tumor post-immunotherapy did very well compared to the group B, which show more than 20% viable tumor. And that's why you need to grid the tumor and take multiple sections so that you exactly know what is the amount of viable tumor. And this is the curve which they have charted out, which can clearly shows that the tumors which had more than 20% viable tumor post-immunotherapy radical nephrectomy, they have done worse compared. So this is an important thing. So these are a couple of papers from PubMed which I picked up, which have now studied, a lot of studies are coming on neoadjuvant nivolumab and other immune checkpoint inhibitors before you do a cytoreductive nephrectomy in these patients. So I think this is something which is going to come in the future more and more. And this is a big study from a very, very important institute, the MD Anderson study. So the basic conclusion is that we have to grid the tumor because the microscopy and the macroscopy would be different. The staging might be different post-immunotherapy. and the importance of the amount of necrosis post-immunotherapy is important. A couple of discussion points which I put here maybe can be discussed in this panel is how common is it in India to do resection post-ICI? For the surgeons, how easy, difficult? Aman is here, maybe I can put this question to him later. And is this a paper queue on how to evaluate the response? And is there any radiological or other tips on radiology how to pick up the response? So that's the first paper. The second paper is again a little relevant in the day-to-day practice. Strangely in India, we have a lot of prostate cancer patients who come early. We have many patients who are less than 50. In TMH, we conducted a recent study in which we have picked about 50-55 below 45 prostate cancer patients. So are there some histological features which suggest that you can do this HRR testing in these prostate cancer patients? This was a study again from Salt Lake Utah University. So this is the background. We know that somatic and germline homologous HRD, HRR mutations are seen in up to 20% of prostate cancer patients, and they are now known to respond to PARP inhibitors. And this study, they hypothesized that the histological patterns might be helpful in saying which patient should go for HRR testing. We have some guidelines, the NCCN has some guidelines. There is a Philadelphia consensus guidelines of 2019 which spoke of this, but I don't think in day-to-day practice we refer to it in prescribing this kind of test. So what they did in their design is they took 130 patients with 38 BRCA1-2 positive patients, 36 with non-BRCA1-2 HRD mutations, and 56 as a control group which did not have any mutations. They were evaluated by histopathologists to see if the histopathology correlated with this BRCA mutations. The results were a negative study. So the NCCN as well as the Philadelphia says that if you see cribriform pattern, introductal pattern, you may suggest that these patients are likely to be BRCA mutated. Strangely, they have found that neuroendocrine carcinoma, when it comes, they are likely to be BRCA mutated. So there is a case that neuroendocrine carcinoma small cell of the prostate may have a BRCA mutation, and those should be tested. And again, they are bad tumors, and they may be a case for BRCA PARP inhibitors. So this is a table. I will not go into the details of this. We can discuss it out during the panel discussions. And the conclusions and take-home messages are that histopathological patterns, even though there are guidelines which say that they can be predictive of HRD, this study did not find that a marginal increase in neuroendocrine morphology and a high volume cribriform pattern was seen in BRCA1-2 mutation. And so the importance is that you have to decide on a day-to-day basis which patients to send for ancillary molecular diagnosis. Most of them are young patients with a family history, and those are the patients who would be harboring these mutations. Again, the discussion points I would leave is, in your practice, what triggers BRCA testing? Do patients now regularly request for genetic and molecular testing? And do clinicians really in day-to-day practice, maybe we can discuss during the panel, follow the Philadelphia consensus guidelines or the BRCA testing? And as a Eurocare team, I think when you do a genetic testing, you have to have a genetic counselor in place before you actually do this. Thank you very much.
Thank you very much. Yeah, I guess that finishes all the 5 papers. And now I think we're going to go on to the panel discussion. But before that, I'll just say these were excellent papers, went very nicely, neatly, in a progressive manner, looking first at the combination of atezo and nivo and EP, and then non-contribution, and the fact that the cabozantinib and nivo is definitely a great contributor. The third paper was again on triple therapy with cabo, nivo and EP, and in clear cell. The next paper was on non-clear cell and the use of pembro in non-clear cell. And finally, a lovely paper on the histology and the correlation and young people with prostate cancers and the need to do BRCA testing and other genetic testings in these patients. I now invite Dr. Randeep Singh to do the panel discussion.
Thank you, chairpersons, and I have two small announcements before we start the panel discussion. There is, on the behalf of Dr. Kumar Prabhash sir, he is conducting a survey of management patterns on urinary bladder cancer in India. There will be a team who will circulate among your tables, and if you have not filled up that, there is a request to fill up that survey. It's hardly 5 minutes long survey to be filled. Second, I would like to invite Dr. Amit Ghosh, sir. Sir is President of Urological Society of India Oncological Chapter. He has a small announcement to make before we start the panel discussion.
I'm actually the chairman of the uro-oncology section of the USI, newly formed and born on the 2nd of February during the UCCon. And it has been a universal decision that we are going to hold the annual conference in the middle of the year. All the sections, the uro-oncology section is hosting the meeting on the 9th and 10th of June this year in Delhi. Now, if you have not received, this message contains the registration mode as well. My appeal to all members, this is a very big conference of great significance for uro-oncology. If you can please cooperate and take some time out to register for the conference and give it a boost. It will be great for the future of the section. Thank you very much.
Moving towards the panel discussion moderated by Dr. Randeep Singh, I will invite the panelists, Dr. Ashish Joshi, Dr. Shantanu Pense, Dr. Amandeep Arora, and Dr. Deepak from Indore.
Dr. Deepak is not there. Okay, so we can have the Ajay. Ajay, can I request you to join the panel? Ajay Singh. Okay, fine. So we will have a short panel and we can invite the comments from the house. So there are 5 abstracts and apologies, the abstracts of pathology are not there, but I have noted the comments from Dr. Santosh and I will definitely include that in discussion. We will first start with the adjuvant therapy. There were 2 abstracts of adjuvant and that makes us about total 4 studies, phase 3 randomized of adjuvant in RCC. Apart from that, there is an evolution now. Just a second, I'll just put this off. There is evolution in the metastatic RCC settings and there is an escalation from doublet to triplet. And in the last, we have non-clear cell RCC, which was discussed by Ashish. And so to my mind, the ideal adjuvant therapy, and this applies to any oncological setting as well as in RCC, shall eradicate micro
Patients also, we have something called as a Leibovitz score that is available, which has all histopathological features that we enter, and we get a 5-year and 10-year progression-free survival and cancer-specific survival, which I then inform the patients.
Perfect. So Amandeep, you do it for risk stratification.
Yep.
We ask our medical oncology colleagues, do you do it for a risk stratification, prognostication, or do you do for predictive also?
So currently it's for prognostic stratification, but I think probably now that we will discuss about the adjuvant data, some of these factors will have a role to play in predicting a response to the, or whether aligning the adjuvant treatment.
So Ashish, I was just going through this UISS and of course these were also there in the inclusion criteria. T2 grade 1, how many of us are comfortable in putting, I mean of course there are T2 grade 2 grade, but T2 grade 1, how many of us are comfortable in putting it in intermediate and high? First Ashish and then Amandeep. And then of course.
So I think if you look at the grade 1, that the biology is very, very indolent. So putting such patients into intermediate could be...
Intermediate high.
Intermediate high.
Yes, it's intermediate high. It is not even intermediate. I would have been happy. It's intermediate high, and that goes into the why I'm asking you this particular is because you know that it goes into the trials which we are discussing now.
Correct. So not very comfortable.
Amandeep?
Yeah, not at all comfortable.
Shantanu, if I'm right. Shantanu, no. And okay, fine. And what about these? This I will first ask our medical oncologists. Do we risk stratify? Of course, these are the prognostic established risk groups. The Leibovitz as well as the UISS. What about what we have learned from the clinic? And
not a great biomarker.
Not a great biomarker. Okay. Now we come to the both medical oncologists. In today's era, do we consider adjuvant TKI? See, so before you make the comments, I will make 2 comments. If we are a hardcore fan of regulatory authorities, then only 2 things are approved as of 2023 sitting here. One is adjuvant sunitinib. Whatever we may debate the data, and one is adjuvant pembrolizumab. These are only two approvals in front of us if you want to be play medico-legally safe. So what if the patient is affordable? Will you still consider adjuvant TKI? And if yes, what? Ashish and then Shantanu.
So the length and the breadth of the data with TKI is far more bigger than pembrolizumab. So I would consider adjuvant therapy in M1 NED as we speak.
Okay, interesting.
Definitely I will do it. Now whether I'll use TKI or pembrolizumab, that something is very much debatable. The pembrolizumab data looks impressive. Probably one may shift from TKI to IO.
Okay, and if there is affordability issues or whatever, if there are contraindications for IO, such as patient had some transplant or is having an active SLE, a systemic SLE or an active autoimmune disease going on, then
M1 NED definitely sunitinib.
Sunitinib. And among these, there is an Everest trial which is not there on this slide. That was for adjuvant everolimus.
Yes, everolimus. Yes.
That was also there. So Shantanu, your comments, if you have to use adjuvant TKI in one who is financially and medically eligible for IO versus one who is not eligible for IO either financially or medically.
Sir, only for M1 NED I may consider sunitinib, but otherwise even for sarcomatoid and affording,
It's a doable regimen. Okay. Adjuvant pembrolizumab, to be very honest, I haven't used in my clinical practice.
Great. Okay, fine. That is the next question.
Do all M1 NED have to go on adjuvant therapy?
Okay, would anyone in the panel would like to take that, or all NED would like to go for that, and I will come to that comment. Yes, we can have the anyone. Okay, Chirag sir, would all M1 NED would like to go for? Can you be more specific? Would all M1 NED like to go for adjuvant sunitinib or adjuvant pembrolizumab? You sir will answer. Very good, sir. Sir, please answer both of them for us.
My strong preference is towards pembrolizumab.
Okay.
Sunitinib, I don't think abstract included the patient with M1 NED.
No, it did not include. And I think what Ashish and they wanted to say, and I did not comment, was an extrapolation because that is the group which gets benefited.
So, till the data of pembrolizumab came in, my answer to M1 NED going for sunitinib was no. I am not using sunitinib for M1 NED.
But now, sir, today?
Today only. Till the data of
No, so M1 NED not eligible for IO, either medically or financially?
I don't give.
No, nothing. Okay, fine. And all M1 NEDs will go for adjuvant pembrolizumab? That is the next question Amandeep is asking.
I will prefer.
But all financially and medically eligible patients?
All, yeah.
Okay, fine. So we will come to that point again. So again, back to both of them. Will you consider adjuvant IO? There are 4 trials now. The Keynote 564 we all know, that is of adjuvant pembrolizumab for a year. IM Motion 010 as well as Checkmate 914 were presented, and one which was not presented is Prosper. Prosper was one dose of adjuvant, one dose of new adjuvant Nivo, followed by 9 months of nivolumab post-op. Only one dose was given before. They have different inclusions criteria, but one thing is common among all these. All of them have at least high risk. Intermediate may be a debatable thing, but high risk they all of them have, and 2 of them have M1 NED, Keynote 564 as well as IM Motion 010, and most of them have a sarcomatoid. Even Prosper had M1 NED, and we will look upon that data. So with this, again Ashish and then Shantanu, will you consider adjuvant IO? If yes or no? And we have the data, and you know that there is only 1 positive, 3 negative standing against. And before you make a comment, these are the graphs. The first graph on the right hand upper is adjuvant pembrolizumab, and I am happy that there is some tail happening, and the tail which all oncologists look in IO trials, the tail is getting achieved here, and that tail is maintained, which gives you some confidence at 30 months of follow-up. IM Motion 10010 adjuvant atezolizumab, no tails. Checkmate 914 absolutely negative till 48 months, and Prosper again till 36 months or even beyond. There is hardly any separation. So with these 3 standing against 1, Ashish, what will you?
So it's 3 versus 1. I'll always go for the majority.
Now it has become 3 versus 1. First it was 1:1.
But again, going back to that previous discussion about the prognostication models, correct? And the risk stratification that we've discussed. So have we optimized them adequately? Does it include all the qualitative as well as the quantitative factors which are required for a risk stratification? I think that's something which is very, very important and still debatable. There is still one only trial which is showing DFS benefit, 3 are negative trial, So if you ask me honestly today, I would probably not do adjuvant IO.
Pembrolizumab.
No.
Okay, Shantanu, your comments.
Sir, I would
And I
still-
will come to subsets. Let us have a broad, Ashish, what, a broad one, then we dissect out the subsets, of course, because the data is the intention to treat DFS.
I would still be tempted to use adjuvant pembrolizumab in at least M1 NED and sarcomatoid histology.
Okay, so now we will focus on these two subsets, M1 NED and O. So I will present the data of all the 4 trials. The first one is adjuvant pembrolizumab. Of course, M1 NED, total number of patients are 50 out of a 700 database trial. As in sarcomatoid, if you see on the pembro, of course, there was a benefit with a hazard ratio of 0.54. The other true, there is the sarcomatoid, again the benefit is in adjuvant nivo EP. The hazard ratio is similar to adjuvant pembrolizumab trial of 0.3. But in perioperative nivo, when 1 dose of nivo is given, only 1 dose nivo, and it is mainly a post-operative nivo only. Again, if you see sarcomatoid is not there here, but there is a M1 here. But in M1 again you can see the diamond you can't see because that is on that line of unity. And there is a wide confidence interval, and the most part of the confidence interval is against using the IO. Now you tell me, that is an old age concept that these tumors will regress on their own once that the parent is removed, and that is what was taught from us, not now, from 10 years, that RCC is a tumor when you remove the parent tumor, and then these micrometastases may disappear. And we have seen initially, I mean, I have seen in my practice at least 3 patients who had these small lung mets, 1 or 2 or 3, and they were just kept on observation, and they remained on observation after their cytoreductive nephrectomy was done. And that is why it always makes me think that whether we are helping them or not. Shantanu, now M1 NED and sarcomatoid. I don't know. That is why we are discussing. If you know the answer, I would have told you directly that yes, do this. We don't know. That's why we conduct these points in the discussions and discuss here in the meeting.
Sarcomatoid, I would like to discuss it at least with the concerned patient, even for DFS benefit.
And then M1 NED, your confidence is shaken.
M1 NED, yes.
Now the confidence is shaken. Chirag sir, can you help us? And anyone else from the floor? Sir, after this data, you can guide us as what to do.
So in the morning, the same discussion happened, and I said that we should treat the patient with adjuvant therapy where it is likely to work the best, not in the very early subset, not in the very advanced stage where it's not going to work. So Ganesh, I think Ganesh had given the example of the thrombus reaching up to the intrahepatic.
Sir is there right behind, yes. Ganesh sir is there, yes. So intrahepatic, same question, intrahepatic IV is involved or nodes positive. But R0 resection done.
And maybe 3-4 lung metastasis excised totally. That is very advanced disease, and that disease is going to come back whether you treat now or not. But if a 6 centimeter tumor and 1 lung metastasis is totally excised, so these are the patients who are likely to be benefited the most. So this is the patient whom I will treat. The other patient I will not.
So, but M1 NED by definition is that all the synchronous and metachronous metastases are resected, whether there were 1, 2, 3, 4 lung or it does not, or even a bone, it does not matter. The definition in all these trials have been that there is no evidence of disease and the metastectomy has been done.
I will use my discretion.
So is there any M1 NED whom you would put on surveillance? Any M1 NED?
I think same question what Amandeep was asking before now.
But is there any patient that you can say, ye patient ko I will put on surveillance?
For very advanced disease, whom I think that by the time patient will be discharged, patient will come with some.
So, but then there are more so reasons, sir, to start them on a therapy. If you know that they are going to relapse on the first follow-up, then there are more so reasons to start them now.
The point which I want to make drive is that there are some patients who are very advanced, who are going to have the recurrence. In those patients, I will wait till the recurrence occurs. So there are some patients who are going to be cured without any adjuvant therapy. There are some patients who will not be cured in spite of adjuvant therapy. We don't know who are they. We don't know at present who are they. But applying the common sense, applying the logic that we are applying in day-to-day clinic, I will use my discretion.
And then you will have to stop the therapy at 1 year in these patients.
Yeah.
And also, I think, completely agree with Chirag sir there, and hence probably sunitinib is the middle way.
I think sunitinib will be very difficult to justify because, I mean, either if you have to give it, you give it a adjuvant pembro, else you don't give anything. I think that is my take. And toxicity, there is actually, and that was I think comment by Amandeep only, that is that this is a slide grade 3-4. I will just concentrate on clinically significant toxicities. Atezo is 27%. The right hand curve is the Pembro keynote trial. I'm very bad with numbers, but the grade 3, 4, 5 is 32%. Discontinuation, and again the Nivo EP, it is around the grade 3, 4 is 38%. Treatment discontinuation in Nivo EP adjuvant is 32%. And in the Pembro is 10%, and in Atezo single agent treatment discontinuation is last one 11%. So it's 10 to 30% treatment discontinuation as you intensify. And of course you are giving toxicity. It is not a easy regimen in the adjuvant setting as well as others, but these are grade 3, 4. I'm not talking about 1, 2 toxicities here. So to summarize, and we can have comment from all three, starting from Shantanu. Are you satisfied with the trial designs? Both the trial designs were placebo-based. All of them are placebo-based. Yes.
Nivo EP looks like over-treatment with given toxicity, shorter treatment duration is also different. I mean, it is intense and shorter duration, which is probably not justified.
But you don't feel that these trials should have been compared with sunitinib when you have only one approval and the trials, the ones they had started, why they were not compared with adjuvant sunitinib? We all discussed that we will give adjuvant sunitinib, and if these data would not have been there, either you observe them or there is an option of sunitinib. So are you satisfied with the trial design? That is the question.
Probably sunitinib also with an adjuvant setting has a lot of weaker data. So
trial design is satisfactory.
So trial design is okay.
Fine.
But again, 2 drug for an adjuvant setting, I agree with Dr. Shantanu.
To give or not to give, that also you tell. Practice changing to give adjuvant or not to give adjuvant?
Give adjuvant after discussion with due discussion.
So you will
in
still
selected
consider.
patients, yes.
Okay, and it can be adapted if finances are met. Amandeep, any separate comment? No. Okay. So we will shift gear. And OS are almost similar. If you see 0.7 is the hazard ratio. Why the Checkmate 9ER and clear trials are showing a very good hazard ratio? Don't get carried away. Their follow-ups are very less. They're just 23, 24 months. So that is not, but OS, all of them are hovering around 0.66, which is a clinically and a medically significant. There are other differences, of course, that the combinations of Nivo, Cabo, Pembrol, and Nivolumab are more active. And there is a difference of, shows you very good results, had only 9% poor risk, which is the least. And to my mind, Nivo, Cabo appears to be best. It has 20% poor risk. And in spite of that, they have done well. And we have a follow-up data, which was presented by the speakers, and they have the PFS is holding to 0.73. Chirag sir, your comment, and then we come.
So my question is to any of the panelists about favorable risk.
Okay.
The recommendation you said that all 3 combos are preferred.
Okay, sir, I will include that. Please give me time. I will include that. So where do you place update Checkmate 9ER, and then there is the Cosmic data. Cosmic data was, so let us start with Checkmate 9ER, and this was the slide, sir, where the hazard ratio for the favorable is also put. So let's talk, where do you place Checkmate 9ER? Follow-up data of 44 months, which is a good enough. And then there is a triplet also here, which is a Cosmic. Before you make comments, I will just summarize this slide. Cosmic, one good thing I liked about Cosmic is a very early separation of curves starting at 3 months. The tail is maintained, but 35% of the patients did not underwent nephrectomy. And when we talk about ipilimumab, this was not brought up by the previous speakers. Percentage of patients who were receiving 4 doses of ipilimumab is 58%. And yes, there is a hazard ratio of 0.73, which was statistically significant for the intention to treat. So where do you place them with this data set? We can start with Shantanu and then Ashish. And then, of course, the comment was about favorable, that even in the 44 months of follow-up, the Checkmate 9ER hazard ratio for survival is standing absolutely at 1.07. Exactly.
Unless the patient is financially challenged.
So if there is no financial challenge, then what will be the medical reasons to give sunitinib in a favorable risk? No contraindication medically and financially for immune checkpoint inhibitors. Then what will be the medical subset of favorable risk where you would like to give sunitinib? Anyone or 0?
I will use immune checkpoint inhibitors combination.
So there is a 0. If they are medically and financially eligible, like they are good performance status and they have no finance problem and no contraindication to checkpoint and others, you would like to use in all these trials. So anyone eligible, anyone you will put on single agent sunitinib Monday morning? Okay, Chirag sir, you got your answer.
I will give sunitinib only. And whole world, nivolumab and axitinib and cabozantinib and everolimus with lenvatinib as subsequent line of therapy. And that gives me equivalent survival. So why do we give the combo in the first place?
So both of them can answer. Why would you like to give the combo when the patients are surviving same? I gave my reasons that the PFS is doubling, so I gave my reason that it is 13 to 24 months. I am happy with the patient living for 12 months without disease free, although they are living same. Or they are living, I mean, they're starting at one point and they're dying at one point in a similar way. But I am happy if 12 months they are happily living and they are tolerating the regimen, of course.
Yeah, I think the tolerance is very important for a low risk patient. If suppose we have a combination regimen which we are comfortable in doing it, then this almost doubling of progression-free survival will be conspicuous for me, and that's probably the reason that I would probably consider using a doublet even in a low-risk patient.
Okay. And now what about triplet? Chirag sir is not happy with the answer, but fine. I stand with Dr. Ashish. This is our take on the data. So what about triplet? And this was the stratification, and what was sir talking about is in the all. This was the slide. Of pembro axitinib again. I mean, these are the, if you concentrate on favorable risk, actually what Dr. Chirag sir was suggesting is that wherever we are concentrating on favorable, the discontinuation is going beyond 40% and the usage of steroids is touching 50%. So what I feel is that when we escalate the therapy, if we are using steroids, we are even compromised, we are discontinuing clinical investment. So Ashish, you have already given your comment, whether you would, so here you would like to give a single agent versus combo. Here is a space where you like to give single agent or a combo, and which is the single agent here? Shantanu, you first, and then Ashish has, I think, already said yes.
Sir, combo, sir, because we are unlikely to get much of the data, much phase 3 data anyways for this kind of patients. So whatever,
if you don't have a phase 3 data, then how will we give a combo here?
PFS benefit, whatever we have with combination, I would be happy with it.
Okay. Ashish, which combo?
Pembro axitinib.
Pembro axitinib, which was presented. Okay. Ashish?
Pembro axo is what I have presented, but the data is predominantly for nivo cabozantinib. You have a very good data for lenvatinib plus everolimus. That is also a data which is there, and axitinib monotherapy. In fact, lenvatinib plus everolimus is something which was across non-clear cell histologies.
That is there here, yes, actually.
Yeah. So I'm actually been using lenvatinib plus everolimus in many of my non-clear cell histology patients. I haven't used IO plus TKI combination in this group of patients.
Perfectly. But what will be your first choice of Monday morning?
So
let
Monday
us say
morning,
it is type 1 RCC and type 2. There are two papillary RCCs patients. One is type 1 and one is the hereditary fumarate hydrate deficient proven, or no NGS done.
So no NGS done, but the hereditary papillary renal cell carcinoma, I would still have used bevacizumab plus erlotinib.
Okay. There is a data of bev-erlotinib as well as the tizo-erlotinib, and for the type 1 RCC, non-hereditary, you would use a combo or a single agent?
I will still use a combo of lenvatinib plus everolimus.
Lenvatinib plus everolimus.
Because that has got one of the best data.
But sir, yes, I will come to this is the data which is one of the largest database. Unfortunately, this is also, I think, only of 100 patients. And this is a SWOG 1500 subset, a phase 2 trial. If you are using a single agent, it has shown that cabozantinib is best because cabozantinib acts on many targets, and MET is one of the target which is very popularly exploited in papillary RCCs type 1. And that is why if you have to use a single agent, it shall be always cabozantinib. And then you can use a combination of nivo cabo also if you wish to. And then type 2 RCCs are treated separately. Yes, sir.
So that was the comment which I wanted to make. And for chromophobe, there is evidence of PTEN loss, and for PTEN loss, everolimus is a better drug.
Yes.
So I will want to use everolimus with lenvatinib.
I think that is one of the best combinations as of today. And then there, even in the guidelines, why cabozantinib is recommended is because of the strength of data. Otherwise, we all have phase 2 data only. I think in the last, I will take two comments from the panel. This was regarding Dr. Santosh Menon's inclusions. First was very interesting that I will start with Amandeep. Amandeep, how many patients you are working at a high volume center? And others, if there is any other surgical oncologist who can cover up and help us with this question after you first. Post ICI, do you do nephrectomies, and how is your experience?
Yeah, so our intermediate risk patients who've had a year of immune...
No, neoadjuvant ICI. They have received some sort of neoadjuvant therapies. Neoadjuvant ICI, anything. I mean, not talking about...
So our intermediate risk patients with 2 or more factors who were planned for systemic therapy first and then possibly a
Yes,
interval
exactly.
nephrectomy. So if
Yes.
they've had their 1 year of therapy and they've shown a good response, we've had few, not many, I can probably count on my fingers, we've done them. The nephrectomy is not more difficult or easier than any other nephrectomy. It's definitely not more difficult.
And what are your, and how do you response assess? Do you do a PET
Yeah.
scan is fine, or a MRI or whatever, do you assess them in the same way as you would do for anything else?
Yes, there's nothing different than assessing.
And what will be that? Suppose on a baseline to do for an RCC, you will do
We
a
do
CTKUB
CT,
basically.
yeah, but I
Or
think here we do a PET and then decide.
And then you follow up with the PET scan.
The follow-up is done with the medical oncologist again.
But you have to operate, na?
Yes, yes. So the medical oncologist has assessed that the response has been good. Then we discuss in an MDT whether adding surgery to this patient would be beneficial. That
Okay.
PET scan is enough for me to
Okay,
assess
got it. So
effectability.
we will be also, if someone has
Yeah.
done a PET scan and there have been a one or two oligo or other, we will be also doing the same, a
Yeah.
scan only.
Yeah.
And anything else, Ashish or Shantanu, you would like to add and Dr. Santosh did mention that the pathology is also challenging. It is not only the clinician's problem when you give neoadjuvant ICI in a new disease, and giving neoadjuvant new immunotherapy in RCC is definitely something new for all of us. Shantanu, any comments? I don't have experience of giving neoadjuvant ICI yet in my patient. No experience. Okay. And the next comment, I think that is simpler. We can have comments from all three of the panelists. We all face this, and this was very interesting that we all know the guidelines of doing BRCA testing in breast, as well as we know for colon, doing Lynch and prostate. But as a medical oncologist, we have been more comfortable, and we have been taught, and by heart we remember the breast guidelines, like one relative, two relatives and all that. But Dr. Santosh made a very good comment that how much we are pepped up as a medical oncologist to do that, follow the guidelines for prostate. And here we are talking about prognostication and family history. We are not talking about using our PARP inhibitors in the future. Shantanu, and other histologies, especially cribriform and intraductal, do they make a difference, or you would like any young patient who is fitting the criteria, irrespective of histopathology, to undergo pre-genetic counseling followed by BRCA1-2 testing?
Yes, sir. All young patients with low PSA, particularly low PSA, high Gleason.
Low PSA, high Gleason. Okay.
It's not typical.
Maybe these.
So in fact, that paper also it said that the BRCA is histopathology agnostic. So
yes, he
meant that. That is what was mentioned, I think, Doctor. And so for all young patients, yes, BRCA, yes, but coupled with the genetic counseling, just not writing a BRCA prescription. That's very important.
Amandeep, your comments?
Yeah, so honestly, we don't do it, although it is there in guidelines.
Look, because breast unit, they are all do it, and even now we have also
So the guidelines say for all high risk and for all metastatic, honestly, we don't do it. But if we have to do it, then yes, definitely genetic counseling along with the testing.
But for everyone who fills the criteria of the guidelines, and these guidelines have been issued
Ideally,
not
yes,
by
so I think it is
the
at
South
least our-
Asian, these are all guidelines from the Western world.
Yes, so
How
I
much
think
will
it is
they
at least
adapt
our
to?
job to inform the patient that you are not the routine prostate cancer patient, and we have evidence that we should be doing genetic testing in you, and then I think it's up to the patient also to decide.
Okay, fine. I think we are come to the end. I will just summarize. These were the points which were discussed, and I will just put my comments to it. High risk RCC, I would like to keep them on surveillance, but for sarcomatoid and M1 NED, I would definitely like to discuss about adjuvant therapy. My choice for adjuvant therapy will be pembrolizumab if me and the patient and the tumor board agrees that they shall be treated with some sort of adjuvant RCC. For good risk, definitely single agent sunitinib will always be there on the card, but my preferred combination will be, this is my personal choice and my experience. It is not that one is better over the other. I have been using Nivo Cabo, and it is just about your comfort level. It is not that Nivo Cabo or Nivo EP or Pembro axitinib as well as pembrolizumab. There is erlotinib with Bev or atezo with erlotinib, and this is my take on the data, and of course there will be some ifs, buts and wrongs to this statement. Thank you. Thank you, sir.
Sponsored session on role of apalutamide in prostate cancers.
Good evening. It's a sponsored session, so the content is majority provided by the sponsors. That's the disclaimer. We are here to discuss about apalutamide quickly. It's a new thing which is coming up, and it's important for us to run through the literature for us to have more learned outcome. So apalutamide, it's a next generation oral androgen receptor inhibitor. All of us know 2017 it started with the buzz about it. 18 there was an approval for NMCRPC, and 19 there was an approval for castrate sensitive phase. Mechanisms, it ultimately it's a AR inhibitor, receptor inhibitor. So it blocks the binding, then it blocks the translocation and blocks the subsequent transcription. So same process which we all know about this. Pharmacokinetics wise, so oral bioavailability is fantastic. It's nearly 100%. That's one good advantage. It achieves the Tmax within 2 hours. Generally, food does not have a lot of implications, so it can be taken with or without food. Mean half-life is quite longer, so 3 days, and major circulating compound is circulated in the bloodstream for many days. So up to 70 days, a single oral administration of radio-labeled apalutamide is found for 65% occasions. So roughly the dosage are 240 milligrams, so 4 pills a day orally with or without food. That's the standard thing. It obviously has to be combined with the androgen receptor, the ADT or the blocker or the orchidectomy. So non-metastatic CRPC, typically in India we get a lot of these kind of situations that a patient is diagnosed earlier in castrate sensitive phase, the localized or locally advanced stage, and someone has done an orchidectomy and not treated definitively the local cancer, and then eventually PSA starts rising. That's the common occurrence which we get for all patients, and that's one typical scenario. And second scenario is obviously post-surgery or post-radiation when you have a failure of biochemical recurrence. That will be non-metastatic CRPC when patient is already on androgen deprivation therapy. So rising PSA criteria, serum testosterone of less than 50 by the old norms, and no evidence of any detectable metastasis. So that's the definition of non-metastatic M0 CRPC, and that's the timeline which we pointed out, 2018. So let's run through both the trials. First, Spartan trial for NMCRPC. So they evaluated apalutamide in multi-center randomized manner, a double-blind placebo-controlled trial for patients of NMCRPC. Apalutamide was given 240 milligram once a day along with ADT, and the other arm was ADT with placebo. The inclusion criteria was NMCRPC, but important key line here was PSA doubling time of less than 10 months. So that's very important. So you need to have some serial intervals PSA monitoring. Primary endpoints were metastasis-free survivals, and there were certain secondary endpoints including OS and time for progression, time for initiation of subsequent cytotoxic chemotherapy. Median age 74. So these were the statistics, median statistics. So previous, if you observe this, prior surgery or radiation was about 77. So in India, that this possible percentage will be more towards previous orchidectomy done, which is more than 70% probably. So prior treatment with anti-androgen, which is bicalutamide or flutamide, was about 69%. Median PSA of 7.8 and Gleason score more than equal to 7 or above are around 78%. The primary measure, so metastasis-free survival, because it's NMCRPC, so we are looking at metastasis as the primary outcome to minimize the chance of metastasis. So apalutamide plus ADT significantly improved MFS, metastasis-free survival for 2 years, which is 24.3 months versus placebo. The hazard ratio is quite less, almost 0.28, so it translates into nearly 72% reduction in for metastasis, median progression-free survival, symptomatic progression, OS, and initiation of cytotoxic therapy. Majority parameters were significant, and hazard ratios were in the range of 0.20 to 0.70 for OS. So majority of the secondary endpoints were satisfied. Exploratory endpoint was second progression-free survival, and that also had reduction of about 51%. So time for PSA progression, again, that is almost 94%, and if you see the curves, they are almost on different platforms. The placebo curve is almost dipping down immediately, and apalutamide. Hypertension, skin rash is one side effect which is very well described for this particular drug, but I don't think it is a very dominating thing in the clinical practice because it can be managed on some antihistaminics. Some few percentage patients having diarrhea, nausea, weight loss. So predominant ones are fatigue, a bit of hypertension, and skin rash. These were the predominant side effects. the similar, I think that just continues the other parameters. So this is about the non-metastatic CRPC phase. Then the second phase of approval was for castrate-sensitive metastatic cancers in the initial phase of diagnosis. That's the Titan trial and the investigation. So it's a phase 3 apalutamide versus placebo in patients of metastatic castrate-sensitive prostate cancer receiving ADT. So it's a combination of ADT plus one therapy, doublet therapy. Apalutamide, and it's again the androgen receptor blocker, which we discussed already. Let's understand the trial design. So patients were metastatic castrate-sensitive cancers, good performance status, either 0 or 1. Prior ADT within 6 months. So they were not very prolonged course post-diagnosis of metastatic castrate-sensitive phase. Within 6 months of initiation of ADT, they need to be randomized, and within 3 years of local disease. So again, apalutamide 240 milligrams once a day with ADT versus placebo and ADT. So again here, the primary endpoint will change because this is a metastatic cancer already. So we are looking at OS as the primary endpoint. Against to that, in non-metastatic CRPC, we were looking at metastasis-free survival as the primary endpoint. So here primary endpoints were OS and radiographic progression-free survival. Secondary endpoints were time for pain progression, time for skeletal-related events, time for chronic opioid use, time for cytotoxic chemotherapy, and exploratory ones are again similar, PSA progression. So eligibility, documented metastatic prostate cancer, ECOG 0 or 1, castrate-sensitive phase. Previous docetaxel up to maximum 6 cycles were allowed, ADT within 6 months of initiation, and within 3 years of localized prostate cancer undergoing a definitive therapy. These were the inclusions criteria. Baseline characteristics were almost matched. If you observe the median age, it was almost 68 and 69. They had a fair representation of low and high volume disease, because in this particular space we always think about volume of disease for our decision making. So low volume of about 40% and high volume of about 60% or 62%. Nearly 11% had prior docetaxel, and so Gleason's less than equal to 7 and Gleason more than equal to 8 were about 1/3 and 2/3 proportions. So primary endpoint, radiographic progression-free survival, significant difference, 68% versus 48%. The hazard ratio is about 0.48, so nearly 50% reduction in the risk of radiographic progression or death with apalutamide. Overall survival curves again had a difference after the progression of about 12 to 18 months. Hazard ratio is about, they've not mentioned about it, so 33% reduction in the risk of death because of apalutamide. So OS subgroups, majority parameters will be in favor of apalutamide against placebo and ADT combination, irrespective of the performance status. Bony metastasis presence, yes or no. Visceral metastasis being present, yes or no. The visceral metastasis had, if you see the yes parameter for visceral metastasis, it is not in very much favor of apalutamide, but majority other parameters, disease volume, if you observe high and low, both are almost on the side in favor of apalutamide. So metastasis stage at the diagnosis. Secondary endpoints, again, time for cytotoxic chemotherapy, time for pain progression. Out of these parameters, time for cytotoxic chemotherapy if patient has not received, or time for PSA progressions were in favor. PSA progression happened for 75% versus 36% in favor of apalutamide use. Conclusions, so in patients with metastatic castrate-sensitive prostate cancer, addition of apalutamide to ADT significantly improved survival. Recurrence progression-free survival of 52% reduction in radiographical progression-free survival, hazard ratio of 0.48, and OS there is 33% reduction, hazard ratio of again 0.67. Apalutamide in this setting also demonstrated prolonged time to initiation of cytotoxic chemotherapy if not utilized earlier, and PSA progression and increased PFS2. Apalutamide was well tolerated with adverse events consistent with the previously reported data. So no major side effects apart from the ones which were described, and investigators concluded that the results support the addition of apalutamide to ADT for patients with metastatic castrate-sensitive cancer. So significantly longer OS and radiographic progression-free survival than placebo plus ADT, that is one. Prolongs time for cytotoxic therapy, and second, progression-free survival. Higher percentage of patients in whom undetectable PSA levels were achieved, and longer time to PSA progression than placebo. So PSA repercussions were stronger. Incidence of high grade and serious adverse events did not differ substantially between the groups. Rash is typically the main side effect which is described but can be managed with conservative agents. Incidence of hypertension was lower and ischemic heart disease was higher in apalutamide group in the Titan trial than the Spartan trial. So in conclusion, Titan trial involved patients including those with high volume and low volume disease, previous docetaxel use, previous treatment with localized disease, previously or newly diagnosed prostate cancer within 6 months of diagnosis, and apalutamide plus ADT resulted in significant longer OS and radiographical progression-free survival. The repercussions on recurrence-free survival, progression-free survival were much higher, and OS benefit also did exist to about 33%. Thank you so much. There is one more thing for question answer. So it's one couple of situations which they have given. I'm probably just going to ask it to the audience quickly for the sake of completion. So everything is majoritarily discussed today, but I'm just going to take you through the presentation. So treatment setting, let's talk about treatment settings of NMCRPCs. So probably Amandeep, in your practice, I mentioned about this, that majority of the times in India, we have patients undergoing orchidectomy at the stage of localized disease. It's coming down, the percentage probably are coming down now, but when we were residents, probably we used to see these kind of situations much more often. So whenever these patients present to you with typically rising PSA, they are already castrate. So ultimately, do you qualify these patients into this particular definition? What's the treatment strategy like? Yeah.
And if the PSA is rising, the next would be to image and see if disease is visible. So do
Absolutely.
a PSMA PET scan.
Absolutely.
And if no disease on the scan, then this patient is a non-metastatic CRPC. Yeah. So
perfect. So Dr. Vivek, treatment landscape. So we do a PSMA PET, there are no metastases, PSA is rising, he's already castrated.
Then it comes the role of the doubling time.
Yeah.
So if the doubling time is rapid, he would be a good candidate for apalutamide.
Perfect. Are there any medical oncologists in the group? Dr. Randeep, I think we are the only surgical guys around. So anyone from medical onc here? So yes sir, so how frequently we measure PSAs to qualify? So PSA doubling time of 10 months. Do we actually wait for 10 months? No. So what's the strategy like, and which calculators do we use for a basic calculation or handy evaluation? Right. Okay, and how do we exactly calculate the doubling time for the sake of benefit for all the audience? Are there any calculators which you use in routine practice, or it's right? So it's a estimation based on
imaging becomes a little more sensitive.
Absolutely, and plus the therapy getting more embarked.
Yes.
And we are not in early 2010ish.
Yeah.
Right. Okay.
this is for all residents and senior residents. And the guidelines go as we have 20 questions. They are MCQ based. You would be given a sheet. And on that you have to write your name, email ID, phone number and institute. And you will be given 20 minutes. At the end of 20 minutes, we'll be taking away those sheets from you. And based on, there are no negative markings, so please attempt all questions. Another thing, there is a quiz tomorrow also, and the winner will be decided based on both the quiz. So don't give today and miss tomorrow. There are no two winners, no two first prizes. So that's how it goes. Any questions? Maybe we can space out a little bit. I mean, we can, two of you can go behind and also. Anybody amongst residents and SRs who's left behind? I think it's me. So time starts now. It is 7:14. I take your papers at 34. 5.